For those in the room, we're just going to wait till CMS is in the building because they'll be right after my opening remarks, which will be brief. So we're just going to wait for them.
Hey, Joe. Okay, we're going to get started, so I'm going to have everybody sit down. We're going to take about a 3-second beat, and then we're going to go live. So good morning. My name is Sean Martin. I'm the Executive Vice President and CEO of the American Academy of Family Physicians. On behalf of the AAFP and our Primary Care for America partners and collaborators, I want to welcome you to PrimaryCare26. We have an exciting agenda filled with some pretty amazing speakers. We're going to have a robust conversation about how we drive greater investment and innovation in primary care. To get us started today, I'm pleased to introduce the Chief Executive Officer of the National Association of Community Health Centers and our partner in a campaign that we will launch later today, Dr. Q Rhee. Q.
All right, how's everyone doing? Great, yeah. And for those online and in person, I know we have nearly about 1,000 folks registered, so I know folks will be watching either live, in person, or on recording. But I do want to welcome you to PrimaryCare26 and the opportunity to see these possibilities. And it's so exciting to see so many familiar faces, but also some new faces as well. And we do have a great special day lined up for you. So for the next 10 minutes, I'm just going to frame it a little bit and give you almost like a preview as we reflect on the day and the opportunities and the possibilities that stand before you. As was stated, let me see if this works, there we go. I'm Q Rhee, the President and CEO of NAC, and I'm gonna talk a little bit more about that and myself in a minute, but first, I wanna recognize Primary Care for America. So, as a pediatrician, you know when you turn 5, that's a major developmental milestone, right? So, can we sing happy birthday? You see, next slide, I'm pushing it. Can someone push the next slide? Sorry. There you go. So 5 years of Primary Care for America, and I just am very proud to reflect on what this collaboration has accomplished. NAC joined from the very beginning because of Sean Martin, his vision, his leadership, to bring together a diverse collaboration of organizations, leaders and stakeholders, united by that common belief that primary care is essential, even foundational, to a stronger, healthier America. Over the last 5 years, Primary Care for America has helped to elevate the profile of primary care amongst policymakers, healthcare leaders, innovators, investors, and other key influencers. One of the greatest strengths of Primary Care for America has been its ability to unite voices that do not always sit at the same table. I like that quote, if you're not at the table, what are you? On the menu. And I would suggest, at times, primary care has felt like it's been on the menu and not necessarily at the table. And so as we reflect at the table that's been built here, community health centers, family physicians, clinicians, employers, health plans, researchers, innovators, investors, policymakers, coming together around a shared goal and message of strengthening and investing in primary care. That collaboration has created momentum to help build a stronger foundation for our future. As we celebrate the past 5 years, NAC is excited about this next chapter and what comes next. It is about catalyzing this momentum into a movement. And movements need shared messaging. As we look to the future, Primary Care for America provides a natural home for the triple-double message and campaign, and a platform to engage even more partners around a bold and measurable vision and action plan for transforming primary care in America. Okay, next slide. Thank you. So thank you, Sean and AFP and partners. We're grateful for you, your leadership, and our shared commitment that have brought us to this milestone. And we look forward to continuing this work together to primary care so we make sure primary care receives the recognition, the investment and support it deserves from the public and the private sector, especially for the communities and patients and families all across our nation. Now, I often share the importance of stories and statistics, and throughout this day, you'll hear about stories, you'll hear about the statistics and the numbers, and I often love to reference Simon Sinek's Golden Circle, and starting with your why, that core belief, that purpose or cause that drives you and or your organization. So if you go to the next slide. So I started my career nearly 20 some odd years ago here at the corner of 14th and Irving at Upper Cardozo Health Center at a, where's that? And as a primary care doc, as a National Health Service Corps scholar, I witnessed firsthand the challenges as a medical director, as a chief medical officer at Baltimore Medical System of delivering primary care. I saw the power, the potential, and the challenges of primary care firsthand. And I want to say that that experience has been core to the work that I've done ever since. Being a family doctor for those patients and families and multiple generations, I love this picture, that was the hardest decision to leave that primary care practice and leave those patients, those multi-generational patients where I took care of the kids, the adults, the grandparents, and to think and see about what we need to do differently to improve primary care for America. I witnessed firsthand the power of prevention and healthy people, families, and communities. Since then, I'm grateful to have worked in the public and private sector and have seen the extraordinary opportunities to improve health from government, health tech, retail, and a large payer. In these roles, the primary care doc in me has been the heart and the faces of those families and patients that I served has always led me to pursue two key questions. Why do some people get good care and others don't? How do we improve access and innovate for all, especially communities in need? That's why I ended up at NAC, because I believe that health centers, and I do think all of us working together to advance primary care, are going to be the best answer to follow up and address those questions. So as we set the stage, if you go to the next slide, I just want to highlight the last 3 years, I have visited 49 states and territories across this great nation to witness and see firsthand, as the CEO of NAC, what we are doing in primary care with the community health center model, from San Juan, Puerto Rico to Nome, Alaska. Since 1965, community health centers have grown to become our nation's largest primary care system. We serve 52 million patients, or 1 in 7 across this nation, including 1 in 3 in rural America. We have over 17,000 locations, where 1 in 4 of those locations are school-based in elementary, middle, and high schools, and 1 in 10 are mobile sites, like vans, mammography, dental, behavioral health, primary care. We have a primary care workforce of over 330,000 FTEs, delivering an ROI for the communities that we serve, as affirmed by the Congressional Budget Office. We've created over 500,000 other jobs, local jobs, and produced over $260 billion in economic output. We only cost the system $60 billion to serve 1 in 7, including 1 in 3 in rural America. 1% of all healthcare spend for 14% of the population to present and provide affordable, comprehensive, effective primary care and preventive services. So we, on behalf of NAC and the community health centers and this movement of 60 years, we're excited to be at this next chapter of primary care for America and the launch of the Triple Double, a shared message to advance a shared movement. Next slide. So I am so excited to preview the Triple Double, a shared messaging campaign this morning. The Triple Double will help us build a stronger primary care foundation in the US. Why do we need to do this? Next slide. Simply put, and we can use so many adjectives, our health system is broken. It's been built for treatment, not prevention. We spend too much. We have worse outcomes than our peer nations. And chronic disease drives the majority of spending. And most of this chronic disease is preventable. I love, if you've read in the New England Journal of Medicine, you could just Google the ecology of medical care. It was published with adults, and there's a version of it in pediatrics. And you basically look at 1,000 people in a month, and many of those folks have symptoms, maybe 800 of them have some symptom. Maybe they have blood in their stools. Maybe they have frequent urinating at night. Maybe they have a mass in their breast. Maybe they're having some discomfort in their chest. The reality is less than one of those folks go to an academic medical center. And I don't want to underestimate the power of academic medical centers. They are incredibly essential for science and innovation and care delivery in our health system. But so much of care happens outside of those academic medical centers, in the community, with a focus on primary care and prevention. And that is where people get sick. That is what is chronically underfunded and undervalued. And this is where primary care can come in to save the day. Next slide. Primary care manages more than 35% of all healthcare visits on only 5% of total spending. That mismatch is where the affordability problem starts. 1 in 3 Americans, more than 100 million people, lack reliable access to primary care, especially in rural and geographically isolated communities. Now, the evidence and the science is clear. It's extensive. It's consistent. Adults with a usual source of primary care are more likely to receive cardiovascular risk factor screenings, cancer screenings, prevent or manage their chronic conditions before they become heart attacks, strokes, metastatic cancers, and less likely to experience avoidable ER visits, specialty visits, and hospitalizations. The lack of this front door for so many people, for those 100 million, those 1 in 3, the lack of a primary care workforce, and not having the 70,000 primary care physicians means no prevention, no early detection, no chronic disease management until the condition is too expensive to treat. And it leads to the pain, suffering, and cost for families, workforces, and communities impacted. Next slide. So what is the solution? The triple-double is a simple, measurable roadmap and message to strengthen and transform the U.S. health system. It's got 3 key components, and it's got a basketball analogy to boot. The first is to double the investment in primary care from 5 cents on the dollar, the fact that we only spend a nickel of our healthcare dollar, to a dime of total healthcare expenditures. And we have this data at a local level, at a state level. We can look at it with Medicare, Medicaid, and commercial. It's not just the level of spending. How we spend matters too, moving away from fee-for-service towards capitated models that support team-based, whole-person care that actually prevents and rewards the prevention of chronic disease. The second ask is to double the reach of primary care, beginning with increasing the number of patients served annually at health centers from 10% to 20%. We currently serve about 1 in 7, 14%, because if you look at a primary care panel, it's broader than just the patients you saw in the last year. This would lead to us serving 1 in 3, including 2 in 3 of rural America. The infrastructure exists. The model works. Expanding reach requires investment in health center funding and workforce, something we've learned in the 60 years of the health center movement in a bipartisan way. And we're grateful earlier this year, the president signed the largest funding increase in a decade for the community health centers. The third ask is to double the next generation of primary care workforce from 20% to 40%. As you look, and as I remember, I was with my mom, I grew up in this area, and when I told her I wanted to do primary care in underserved communities after the investments she had made in 14 years of education, she was like, oh my gosh. But I will tell you, the fact that I got the National Health Service Corps Scholarship played a very important role in her appreciating the fact that she and my dad appreciated the value of purpose, that why. So we do need to recognize that only 20% of the workforce that's graduating today, who are physicians, physician assistants, nurse practitioners, are doing primary care. And that is not sufficient for the workforce of today or tomorrow. So we need that to go to 40%. Next slide. And I will tell you how we do that is GME, addressing GME reform, and also teaching health centers. Why the triple double? So let's go through and just build this out. And I love, as I said, Simon Sinek's golden circle. The triple double is not a legislative package or a policy mandate. It's a unified national movement built on shared messaging and evidence, organized around shared goals, and designed to catalyze a political and community will that the evidence alone has not been sufficient to generate. It serves as a framework and a set of goals that we can all get behind. We can all track. You measure what you treasure what you measure. In short, the triple double is a roadmap to strengthen and transform our U.S. health system. It helps align patients, clinicians, health centers, payers, philanthropy, and policymakers. It builds on what states are already doing, as you're going to hear about, the stories, the statistics, the impact that's already being delivered at a grassroots level that's working because so much of spending and policy is determined at the state level as well as the federal level. I want to commend the partnerships that we've already seen this past year between state primary care associations and state AFP chapters that Sean has led, and we've worked tirelessly to think about how we can address primary care for America at both the local, state, and federal level. Next slide. So I just want to highlight these great partners that we have as we inaugurate this great campaign. And I also want to applaud and ask many of you to hopefully join as we think about this next chapter of Primary Care for America and advancing the Triple Double campaign. And you'll hear more about it later today. Next slide. Oh, no, stay on that slide, sorry. So I just want to highlight, we have a great day ahead of us, the Triple Double, and we're going to, there's a quote that actually is on my LinkedIn profile, and I love referring all the time. It's a Helen Keller quote. And also, Ellen, Zoe, who are watching, my daughters online, nice to see you. And the new puppy, Noah. I forgot to bring that up at the beginning. Look, this Helen Keller quote is really about how we need to catalyze this momentum into a primary care movement. Alone, we can do so little. Together, we can do so much, is the quote. We have so many parts of the health system today, in person and virtually. And as we look towards this next chapter of Primary Care for America and building on the momentum of the last 5 years into a movement, we will need to bring all of us to that table of the health system, advancing primary care. So on that note, I am so excited. We've got wonderful leaders from the federal government here who are going to share their vision for the future of primary care in the U.S., Abe Sutton and Joe Albanese. Thank you so much for being here. And with that, I'm going to pass it over to my wonderful friend, colleague, and fellow champion for primary care, Sean Martin. Thank you.
Thank you guys. Thank you guys so much for being here. Wherever you want to, you comfortable here?
You're the host. You tell us.
I'm comfortable here if you're comfortable here. Thank you guys for being here. Really appreciate it. So let's jump right in to our conversation. So I thought we would start simple, which is an easy question about why primary care. So we've heard arguments. You guys know this literature where, well, there's broad agreement that primary care produces better health outcomes at a lower cost. But in the United States, for many years, we've struggled to really, I would say, capitalize on the promises of primary care in our healthcare system. And I'm just kind of curious how you guys think about how we translate that evidence into policy and speak to the good work that you guys are leading.
First off, good morning, everyone. It's great to be with you all today, and it's great to join Primary Care for America for this conversation. Thank you for the opportunity to be here on behalf of CMS and to everyone for dialogue on this important issue. The truth is we underinvest in primary care in this country, and that has consequences. It has consequences in terms of detecting disease, in initiating lifestyle change, and it has consequence in the chronic disease burden that we see in America. We have a more obese population. We have people who do not get caught early enough and do not get supported early enough to see the change that they want to see and to will the change they want to live. And that's a shame, because the truth is we have a great healthcare system. We have wonderful resources in place. We have cutting-edge technologies. We have something that advances every single year, such that odds of survival with cancer are significantly improved from what they were 15 years ago. But we don't do enough to do the smart early intervention. We don't do enough to activate somebody early on. And that's the consequences of the incentive structure we have set up. When we rely on a fee-for-service schedule and we are tied to an RVU-driven approach, we underinvest in primary care at the current prevailing payment rates. And there is a bias inherent there that I think you've seen us try and confront at some of the changes that my colleagues in the Center for Medicare have made in how we approach primary care vis-a-vis different specialties. But you also see inherent in how we collectively are approaching the importance of accountable care and the right incentive structures, where people who are upstream, who say, I will engage proactively with my patients, are empowered to do so and are able to capitalize that investment, either themselves or with partners. And that's the vision that I see, when we're able to undertake that investment, both through changes in how we approach the fee schedule and through changes to enable people to underwrite those investments to support their patients.
That's great. Joe?
Yeah, likewise, appreciate the opportunity to speak with you all here today. And I would echo a lot of what Abe said. I mean, at CMS, we're trying to do a lot to advance a healthy America, making America healthy again, having a more affordable healthcare system. And I think as we've learned from experience, the importance of team-based care, care that is accountable to the patient, and the importance of the primary care physician in being the quarterback for their patient's health. That's something that we have, I agree with Abe, we have not invested enough in the past. And when you look at, I think particularly the international comparison that you made, Sean, when you look at the general practitioner in other countries, there's such a larger supply, there's a larger, I think, formal role, and why we don't have that same tendency in this country, I think, is in large part due to the payment policies that the federal government, through especially the Medicare program, have made over time. And the RVU fee-for-service administrative pricing approach, where we basically feed in the cost data and use that to dictate the pricing, as opposed to looking at what is the value that a specific service is going to deliver to the end patient, is a huge consequence of that. And over time, that has compounding impacts. One of the things that we like to talk about at CM is payment accuracy, which is very technical, kind of sounds green eye shades. Like a tendency there, and people think we must be talking about overpayments, and you want to reduce the amount of spending in the program. And certainly there's areas where we would do with having a more affordable healthcare system, but it also goes in the other direction. And when you have long-term distortions in how you're evaluating primary care, even though maybe an individual visit doesn't on paper seem as costly and therefore does not command the same price as a specialty visit, you are going to have a consequence downstream in the supply of providers. So we're trying to fix that in a number of different ways in our rulemaking at CMS.
Yeah, Joe, let's stay with you. So I'm really curious to kind of dig into your two distinct roles at CM and at the Innovation Center. But Joe, you guys have clearly, not just in this term, but in the previous term, the administration has used the fee schedule to drive changes in the Medicare program, or at least signal desired changes in the Medicare program. And I'm wondering, can you describe some of the work you've done to date? And I don't think anybody would be upset if you wanted to make news about the work you're going to do in the future. But I think really, thinking about the work you've done historically to drive, changes around primary care using the fee schedule.
Sure. So obviously we don't yet have a proposed physician fee schedule rule for next year, but some of the themes that I'll talk about that we accomplished last year are going to continue to be things that we're interested in working on. So the three big shortcomings that we were trying to correct in the physician fee schedule. One, that there is an undervaluing of primary care, and I think one of the ways that we had addressed that, in addition to looking at the way that coding and payment works for individual services, thematically, we have also introduced an efficiency adjustment that takes non-time-based services and codes and acknowledges that, over time, some of the more complex surgical or specialty services are going to have efficiencies from innovation over time. And when you acknowledge that, because there's a budget neutral system in the PFS, when we implemented that change this year, it actually led to a conversion factor increase overall. So it's something that redounded to the benefit of doctors who for a long time have not seen that acknowledgement in the fee schedule. The second is that our system is very geared towards and biased towards large health systems, hospital-based care, more expensive for the system, but also for the end patient, and not always clinically necessary or justified. So we made changes to the way that we calculate practice expense in the PFS to acknowledge that, right now there's a dichotomy. You pay for a facility-based service or a non-facility-based service. And on the previous system, we had been potentially double paying for the indirect costs that a hospital has, with the assumption that, there's going to be salaries, overhead, and essentially they get paid twice in our payment systems. And what we did was we corrected for that in order to acknowledge that those who are delivering services in non-facility-based settings, particularly in private practices, have been biased against in our previous system. The third thing is just a reliance on flawed, outdated data sources, which again is very technical, but it's something that has downstream consequences. And so we've been looking for alternative sources of data, including outside the PFS, more market-based data, but in the PFS, even borrowing from our outpatient hospital system for specific services where necessary. Radiation therapy is one example. So we're trying to use more empirical sources of data, have less of a reliance on survey data or things that have small sample sizes, things that have been distorting the overall pricing that we've been setting. And so trying to double down on those three shortcomings and corrections to those has been an important part of our work so far.
Thank you for that. So Abe, you sit over the Innovation Center. The Innovation Center has a history of investing in primary care in a variety of successful and unsuccessful ways. But I'm curious how you are thinking about the runway in front of you, like a 2 to 3 year runway, and kind of how you're thinking about primary care and investment and innovation.
So there are a number of models in our current portfolio that do touch on primary care and ensuring there is adequate support for the delivery of primary care in an accountable manner. One I'll call out, operates in a portion of the country, is the AHEAD model. And within AHEAD, we created something on primary care capitation, where there's the hospital global budget layer, but then there is also this layer for primary care practices that want to take on primary care capitation to do so, to front load investments. There's some quality measures that attach to that, but it should be a workable system for primary care physicians in those states. Beyond that, there are other models that get at encouraging investment upstream in primary care. The main one I want to call out is our LEAD model. LEAD is our long-term enhanced ACO design model. And ACOs are really the best mechanism if you want to be able to make as large an investment as possible in a way that you see as right, to take on the accountability and therefore be able to finance that investment. There is a professional track there, but also a global track if you want to take on the full amount of risk so you can engage and put the resources in place to support patients. And so the ACO model, which is the successor of our ACO REACH model, is really designed as a pathway for that. I think of our primary care supports really outside of as on a spectrum. On the one end, there's one from the Center for Medicare that touches on advanced primary care management, where we have codes where you could bill for some of that coordination and support that you do for patients. It's not a risk-based structure, it's a fee, and it's built into the fee schedule. Then we have people who want to take on more risk in different levels, where we have the Medicare Shared Savings Program with a number of different tracks, including some that are upside only for a period of years, all the way through what is called the enhanced track. And then we will have the LEAD for the full risk spectrum all the way at the other end. This structure with options that are designed to meet primary care physicians and practices where they are is intentionally designed to ideally not be confusing. These are distinct enough that you can see, yes, this is the one for me, that's the one for me, but gives people a menu of options to choose from.
Well, while you have it, so the Innovation Center certainly drives investment in innovation and does some directional signaling, but there are also learning labs. And you and I have talked about this a lot. Like, we learn things. And you guys, over the years have invested that, community health centers are involved in innovation. There's direct contracting and direct primary care in various ways involved. You have ACOs, you have independent practices. What are you learning, and what are you anticipating that you will learn over the next couple of years?
One learning that we had is that incentive alignment matters. It is important to think of both upside and downside and how that aligns incentives and gets people to act in a different way so that they go upstream and make the investments that we're all talking about in this conversation. It also is important to think about the structure of the drivers that catch people in a difficult economic situation. I was having a conversation with somebody who is in OBGYN who was in solo practice in a rural community, and she was describing how it's just been challenging. If we look at the prevailing reimbursement rates that Medicaid has for maternity bundles, I know there's a shift on the horizon there, but I'm sure everyone's tracking that, but there were some real economic challenges highlighted. There were also just the factors of not having the infrastructure, not having a patient population in her community to fill her schedule adequately. And so she decided to close her doors and is now affiliated with a larger medical center, which is fine if that was the choice she wanted to make, but it shouldn't not be economically viable to deliver primary care, to deliver maternity care in communities across this country. And given how we've seen increased productivity from other parts of the economy, a software engineer today could do a lot more than a software engineer could do in the year 2000. Frankly, a software engineer today could do a lot more than they could in the year 2024, right? Just looking at some of these advancements. As you see productivity increases, you see compensation go up in those industries. But a nurse, an APP, still has to compete on the market to pay rent. And if the software engineer can now pay more, turns out cost of living is driven up. And so if you want to attract people to go into the medical profession, and if you want to train people and keep them in it as opposed to them leaving for greener pastures elsewhere, you have to pay in a competitive manner. And so that puts upward pressure that hospitals and practices bring in negotiations with plans where they're like, hey, we need to be paid more because costs are rising, and if you want to maintain our socioeconomic status, let us afford to live in the same way, attract people in. You want the best and brightest to go into healthcare, enable us to do that. But there's not increased productivity being delivered. And so what that translates into is the high premium increases in the commercial market, 7% year over year consistently, 9% in some parts of the country. It translates into rising costs for the Medicare program and the Medicaid program. And so these structural factors are making it hard to operate within the healthcare setting, and makes it hard on the provider side, makes it hard on the payer side. And it's in that mix where we're having this conversation. And so one lesson I take from that is that we need to do more to invest in areas where we could grow productivity in the healthcare sector. We need to do more in the drug space, where you, beyond exclusivity, have broad accessibility in this country. We need to do more in leveraging digital therapeutics. If we look at our access model, it's designed to bridge the time between office visits so that a doctor can help keep their patients healthy with some support and hold down the amount of time people need to come in to see the doctor so doctors can serve more patients in their community as we confront a physician shortage. And so that lesson that we've learned just from the structural situation we find ourselves in is shaping our portfolio and where we're building out models. We've got 4 drug models that we've announced so far this term. We have 3 models that get at outcome-aligned payments, including one that touches on technology, and then we have 3 that get at really upstream prevention. And so that's a reflection of where our priority is on prevention and where we just see economically the healthcare sector impacted.
Yeah, that's great. Thank you. Joe, any comments on that question? Or
Well, I think first of all, the lessons that we are learning from the Innovation Center are always hugely important to us, and we look closely at things like access, especially how our ACO models work together and test different use cases. Historically, we've had a lot of incorporation of the successes of previous CMMI models into the MSSP, and I expect that's something that can continue to inform each other. And I think just moving towards a more accountable healthcare system overall, I mean, there's a lot of different ways you can get at what we like the term value value-based care, right? You can have different payment mechanisms. We're still trying to improve on the fee schedule, but when you have greater tests from bundled payments, having different mechanisms for sharing in risk and in upside savings, that's something that we are greatly interested in as well, and trying to make sure that the MSSP, especially as sort of our biggest in CM, the biggest way that we try to make our mark on moving towards accountable care, is something that's going to continue to be informed by those lessons with proper insights for how do we incorporate tech and other innovations that don't fit neatly into a fee-for-service model, because there is so much incentive for just greater volume. How do we have these advances in things like AI incorporated into our healthcare system in a way that actually drives down costs as it does elsewhere in the economy, instead of being something that's inflationary? So the lessons from the Innovation Center are going to be hugely important to us as we look to that, and as we try to find ways to make sure that the new tech-enabled care opportunities are going to redound to the benefit of beneficiaries and to our system as a whole.
Yeah. So I love this phrase that Dr. Reese said earlier, that we measure what we treasure. And I think if you ask physicians in this country, the healthcare system and Medicare treasure a lot because we measure a lot. So I want to kind of think, like, you guys have really been purposeful in trying to reduce the administrative burden. And it's frustrating. It's hard to do, but I would love, Joe, for you to just take a few minutes and just talk about some of the work you're doing just to reduce the administrative burden on physicians and clinicians and try to create that space for them to focus on patients.
Yeah, I think quality measurement is actually a really great example of where we see, the right intention. We want to be able to have a mechanism for outcome-based payments and to pay based on outcomes. But in practice, does it actually drive the ball forward, or are we just creating a lot more paperwork that has unclear value? And I think across our centers at CM, CMMI, our colleagues in the Center for Clinical Standards and Quality, we measure between us a number of different quality measurement programs, quality measurement in different models. And I think philosophically, we're all aligned with having greater streamlining between different types of specialties, between different types of settings. One example in CM is in the Medicare Advantage program, where earlier this year we finalized the removal of 11 different measures, which were mostly administrative procedural processes that we didn't feel provided a meaningful opportunity for comparison between different plans. And for one thing, it was something where there was not a lot of variation and not a lot of upside improvement potential among plans. So when you're the beneficiary trying to use a star rating to choose between different coverage options, and you don't find that there is any differentiation, it's not a helpful tool to you. And to your question, we are still continuing to have providers report these metrics, even though the value at the end is not something that we can necessarily speak up for in this case. So we removed 11 measures. At the same time, we added a measure for behavioral health screenings to acknowledge that what is lacking in our measurement set in the star ratings context, but I think this holds true in other quality programs as well, is a lack of focus on clinical outcomes, primary and preventive care, and the things that we feel really do make America healthy. So moving towards rebalancing our measure set, having greater ability to rely on digital quality measurement and use those tech tools to make the reporting process easier for clinicians, less burdensome, more meaningful for patients, and for visibility in the entire healthcare system is going to be something that's hugely important, that we think will drive quality, but reduce the cost that it takes to go through the paperwork burden that we've been seeing historically.
Okay, so we're 5 questions in. You've mentioned AI. You've mentioned AI. I have not mentioned AI, so I'm going to take advantage of this opportunity. So obviously, artificial intelligence and digital health are driving, innovation in ways that I don't think we truly understand. You mentioned access and the way you're using it in administrative burden reduction, and et cetera. So I hate to ask this question because it's so open-ended, but how are you viewing AI in primary care? But I think, the question that I think everybody is like really focusing on in the conversations I'm in is, what guardrails do we need to put in place around AI? How are we focusing AI on the right things, the right work streams? But I do just want to ask you that open-ended question, like, Abe, how are you thinking about AI in primary care?
I'm glad you brought that up. We should probably think about AI. That's what
Yeah.
think about it. Remind me what it stands for again. So we are thinking about the use of different technology tools in supporting people and giving them access to care. I think of it primarily as about affordability. Right? Like, what can we do to make sure that people have access to supports in a way that they didn't have before? How can you get personalized healthcare tools at the direction of your doctor in a way that really works to keep you healthy? That would be a great thing in our healthcare system if we had an explosion of access where you could rely on it and know that it was safe and suddenly live a healthier life. I think that's a bit of the utopian vision. It's where we'd want to go. There's also some, I think, negative scenarios that I can imagine. Right? I can imagine a scenario where AI was on the fee schedule and we had an explosion of cost from clinical AI applications. We are already seeing some of that, not through clinical AI, but through administrative uses of AI in increasing billings, and that's part of what's driving the premium impact that we're talking about. So to get to the world where we have clinical AI applications that are not, by definition, driving up utilization in a way that is not connected to better healthcare is the goal. I think if people are choosing to pay more for use of tools, and we as a country or health plans say, yes, we should do that because over time it will result in better clinical outcomes, that is a good thing. But I don't want to just by default open up the doors and have all these different tools pushed on people in ways that aren't really linked to delivering better clinical care. So one way we can, I think, have confidence is if a healthcare system or a primary care practice that is at risk for their population, potentially via lead or a different model, chooses to say, hey, we're going to invest in this tool, we'll monitor the results, and we're giving it to our patients, right? You've got a stark and anti-kickback safe harbor as part of the ACO structure. You're able to go and offer tools to people that you know can help them. Another way is if we as CMS see clinical value and say, all right, we'll lay out the structure of how you need to deliver these outcomes, improve A1C levels, help keep people healthier, and then we'll pay for it. Inherent in this is a focus on measurement to ensure that we're delivering better outcomes and also to ensure that there are not adverse impacts of tools that are meant to be helping people. And so there's a role for us in that from reimbursement. There's also a role for our colleagues in the FDA from a regulatory perspective in terms of market access, where they're very focused on safety as well. And we obviously do have conversations across different agencies. I think we've seen some states step forward and play a role in terms of how they license clinicians and deeming technology tools clinicians. And so different elements of the government, federal and state, are making judgment calls here and deeming different things safe and giving different market access and setting up different reimbursement structures. I think everyone has a common goal in conversations that I've had with folks at the state level and conversation with our colleagues in the government. Everyone wants to focus on ensuring that access is there and that it is not doing damage along the way. And so I see a lot of commonality there, but this is something that we are putting a lot of thought into because it has the potential to be transformative in a good way by opening up affordability.
Yeah, that's great. So just same open-ended question to you, but I would ask one specific one, like how, there is this possibility of paying for services, either independent AI agent services or kind of these pass-through services where, physicians or others are using AI, and kind of building on Abe's comments. How are you guys, you own the fee schedule. The fee schedule's budget neutral. Abe kind of alluded to the fact that a lot of these tools may be inflationary, at least initially. How are you guys thinking about them?
Yeah, it's a good question. It's one of those areas where we are jealous of like the flexibilities that the Innovation Center has to like, we'll do the access model, we'll have outcomes-based tech-enabled payments, and that's why we're watching it very closely. It's a harder nut to crack in the fee schedule because sometimes it feels like when we're having to deal with new innovations in the healthcare system, we can be putting a square peg into a round hole with a fee-for-service model. And I don't think we want to replicate the volume-based incentives that have historically plagued the program, even for traditional healthcare services. So we're thinking through how can we have the tech applied in a deflationary manner. I think in your original question, you mentioned a little bit about guardrails. One question about that is how do we ensure that AI is in the service of the physician-patient relationship as opposed to becoming a new opportunity for arbitrage or for using AI to bill for things that maybe were already taking place or could have already easily or should have already been part of the workflow of the doctor. So with those kinds of principles, understanding that we do need to make sure that we are embracing innovation in a way that can help the end value of the service to the patient, while being cautious enough to understand that Medicare, especially original Medicare, is rife with opportunities for fraud, waste, and abuse, and we need to be on guard for that and proceed carefully. And so as we go through the next few rulemaking cycles and we think about how can we make sure we're transitioning to the right end state where you are not only having AI in the clinician's office, but also as a support tool for decisions on coverage, for on the back end, reducing costs associated with things like prior authorization. These are all different applications that we are thinking about at CMS, not only in the fee schedule, but in a number of our other tools and our burgeoning health tech ecosystem as well. So with those principles in mind, that we want to make sure we are not reiterating the same flawed volume-based incentives of the past. That's going to be, I think, our guiding principle as we work through our rulemaking authorities there.
Yeah, that's really helpful and insightful. Okay, you guys have been very generous with the time. I want to thank you for being here. So 5 years from now, we're sitting at the 10th Primary Care for America event right here, and we invite the two of you back. And I'm curious, like 5 years from now, what do you hope has fundamentally changed about how we support and value primary care in the country, and like what metrics do you think will be most impactful in measuring that over that time period?
So I think two big things. One, I hope that there'll be a greater penetration of value-based, risk-based, accountable models of care, whether it be in Medicare Advantage relationships or accountable care models that we have in MSSP and in LEAD and other great CMMI programs. And that will really instill a team-based approach to care that will have the primary care physician at the center of, again, that quarterback relationship, calling the plays and helping to manage somebody's care. And I also hope that we will recognize that some of the more costly, less clinically appropriate biases that exist in our system will be less of a problem and will help drive a more affordable system. So I mentioned before we made changes with practice expenses between facility and non-facility settings. Outside of the PFS, we've proposed this year to make changes to hospital payment for outpatient drugs and for routine imaging services to try and equalize the payment rates between settings and have Medicare and Medicare patients paying in concordance with the acquisition and cost of outpatient drugs. So I think these things where we're trying to identify areas of arbitrage in the system, and we welcome all your public comments on these areas across our payment systems as well, will help set the stage for a healthcare system that is, again, much more focused on the relationship between the patient and the doctor and having primary care at the place where it will be able to deliver the most value to patients.
I think the traditional way to imagine, a couple of years out into the future is to talk about how the self-driving cars will bring people to the events. Seeing as we're there, I guess we should take it in a different direction. I envision a healthcare system where we're much more intentional about the ways that people get access to care. In many ways, the ways that we erect barriers today are not intentional and result in higher cost down the road. So it's not even a cost containment strategy. It's a neglect strategy. I would hope that we have a system where we've set up incentives where somebody sees it as their role to be accountable for the care of every beneficiary of our programs. And so we see that, the earliest form of that in the AHEAD model between the hospital budgets, the primary care head, and then the geo entities taking on every unattributed Medicare beneficiary in that geography. I want the entire healthcare system to start to look like that, so that people who are not engaged in the healthcare system, suddenly have people reaching out to them to try and engage them. Whether it's the primary care physician who's in their community or somebody else coming in from a plan perspective who now sees it as their duty to do so. I think it's incumbent upon us to build the infrastructure to make that possible. That's what I'd like to see in 5 years.
That's great. Thank you both so much for sharing your time and perspectives with us this morning, getting us off such a great start for this program. We're going to transition to our next panel, and with that, I would like to introduce our friend and colleague Mara McDermott from Accountable for Health to come up and introduce our panel. Abe and Joe, thank you so much.
All right, good morning. Well, I think we had hoped to be reacting to the physician fee schedule, but we're not. So we're going to react to the panel instead. It's my great pleasure to have Katie Boyer and Aisha Pittman with me today, and we're going to have a great conversation about what's going right and where there are policy opportunities in primary care with a particular focus on accountable care models. So before we jump in, I want to give each of you a chance. I know there's lots of familiar faces in the room, probably fewer familiar faces in the ether. I want to give you each a chance to introduce yourselves and your organizations, and Katie, I'll start with you.
Great. Well, my name is Katie Boyer, and I work for Agilon Health. And before I tell you who Agilon Health is, I want to thank Sean Martin and everyone here for inviting us and for having a wonderful panel to kick us off. I was saying to Aisha and Mara at the table, I think all I need to say up here is ditto to what Abe and Joe shared. It's really nice to be as aligned as we are. So Agilon Health is a value-based care company that partners with independent primary care providers across the country. Right now we're in 12 states and we serve over 30 communities. And our role has really been to recognize this underinvestment that I think we've heard a lot about this morning, this underinvestment in primary care, and help primary care providers enter the value-based care arena in a way that helps them shift the economics of their business so that they can get to the good work of taking better care of their patients and transforming health in their communities. We do this through joint partnerships, so we create risk-bearing entities. There's no ownership relationship between Agilon and our partners. And again, we help them enter these models that may not be as intuitive for an independent primary care business as you might hope. So I'll pause there and turn it to Aisha.
Hi, good morning, everyone. I'm Aisha Pittman, and I lead government affairs for the National Association of ACOs. So we represent ACOs, their participant practices, and other providers doing value-based care across all lines of business to, achieve our ultimate goal of accountable care being the prevailing form of payment for healthcare. And as you heard in the prior discussion, as Mara mentioned, accountable care is so grounded in advancing primary care. And I just also want to say a thanks to Sean Martin, Q-Ree, and all of the Primary Care for America sponsors and partners for this event, but then also a lot of partnership in advancing accountable care as well.
It's a great place to start. I think before we dive into some of the challenges and policies we want to work on, wanted to take a minute to just maybe do a little bit of a victory lap, because we have had such enormous success over the last several years in building primary care. And I want to start with you, Katie, and give you an opportunity to shine a bright light on all the success that your members are having, or your companies are having that you work with across the country, and share some of those success stories.
Yeah, it's always a really fun place to start, and there is a lot to celebrate. I think I'll start by saying the work that we do with primary care providers allows us to see firsthand that the number one success is how amazing primary care providers truly are. Their ability to connect with their patients and establish these longitudinal relationships over the life course enables all of this work that we want to do here at the national level and with these models that we're talking about. And so, as always, hats off to primary care. As I think Q alluded to, it's not always the most popular choice or certainly the easiest choice, but they truly are amazing individuals who are dedicated to their patient populations in ways that are hard to find. I think from a successes perspective in terms of these models, we just saw the results from ACO REACH from 2024. I know that sounds a little bit far away, but certainly lots to celebrate there. I think we're seeing in the evaluations for the first time that what we know is happening in those models is starting to show up in the sort of longitudinal reports. From an Agilon perspective, we have 8 ACOs in the ACO REACH program taking care of over 120,000 Medicare beneficiaries. And really exciting, we had 4 ACOs that achieved a 100% quality score. Our average across our network was 96%. And even more exciting, we were able to help the Medicare Trust Fund save over $54 million just in 2024 alone. So we're really proud of those results. But I think if you peel back the layers, how are we making that success possible? It's this ability to leverage models like MSSP, ACO REACH, ACO LEAD, et cetera, to shift the way primary care providers, independent primary care businesses are able to use cash flow from these models and invest ahead of outcomes. And so we are helping them to establish really specific clinical pathways for folks who have chronic disease or early in their chronic disease journey to help them better manage their health, keep them out of the emergency room, keep them home with their families, doing the things that they love for much longer. And it turns out, I think as Abe and Joe alluded to, aligning those incentives is good for everyone. So again, really proud of that success. Lots to celebrate there, and we're looking forward to for future collaborations with CMS.
Aisha, anything you want to add just from your broader membership perspective?
Yeah, I would just sort of echo some of what Katie is saying in that, we're approaching 15 years of MSSP plus longer when you count Pioneer model. So we've seen sustained success of these approaches over time, getting close to $38 billion in total net savings to the government. Year over year, we see more providers come into the model. We're now currently around 51% of traditional Medicare beneficiaries in an accountable care relationship. And that just is a testament to this is a strong program for primary care providers to have additional investments and really build team-based models to best care for their patients.
Great. I'm going to stick with you, Aisha, and just maybe build from there. What are some of the policies you think that this administration could adopt, like potentially in the fee schedule tonight, that would continue to build on this success? Like, how do we take that 50% and get to the shared bipartisan goal of 100%? What are the things that can be done around burden reduction, other areas of interest for NACOS and its membership?
Yeah, we sort of think about this in 3 main categories. One is around sustainability of the programs, and not to get too wonky, it goes to the benchmarks in the core budget. So we're facing a challenge now that we've been in these programs for a long term. If you've been in it from the start, your benchmark is ratcheted constantly, which just reduces the investment. Shared savings has been one of the main ways that we can really see a true additional and enhanced investment in primary care. And so reducing that shared savings over time makes it a really, really difficult to address. So one thing we're looking for is just addressing that long-term sustainability challenge. I know in the LEAD model, they're trying to think about that as well, which is why we see a longer 10-year model where you're not rebasing your benchmarks. Burden reduction is another huge one. To Sean's point earlier around, like, we like to measure a lot of things. That has been a real challenge in these programs, and so wanting to see things shift there. We also just want to see a lot of innovation in the model. So the shared savings program is great, but it hasn't really shifted much since 2019. And there's a lot of ways that we can bring novel things that have been tested in the Innovation Center and have proven really successful into the core program. One of those being additional options for shifting your downstream payment. So that's primary care capitation or hybrid payments. Those have been prevalent in the Innovation Center models long term, but we haven't seen them in the permanent models at all. I think another place, I'll jump from the administration to Congress as well, we're really also looking for them to address and continue investing in both primary care and the drive to accountable care. And so I know we're all anxiously awaiting seeing what the Doctors Caucus has been working on. And they have stated that they are really focused on increasing investment in primary care and then also ensuring that there are strong incentives to join and remain in accountable care. MACRA, since 2015, did its job. Those advanced APM incentives really did drive more practices and additional investment to practices, and that was critical. And we just want to ensure that some sort of stronger financial incentive for joining accountable care remains.
Yes, and much like the fee schedule, I think we're hoping to see something on that this week too. So big week for primary care. We're just on the front end of it. That's really great. I want to stick with LEAD for a second. Abe spoke about the LEAD model, which is the sort of next turn of the crank on the CMMI portfolio of accountable care organizations. We're headed into, I think, our 15th year of CMMI ACOs, and we've learned a ton. Katie, I'm curious what the Agilon doctors are excited about as they look at LEAD as an opportunity. How is Agilon thinking about LEAD, planning its participation, whatever you're able to say about that?
Yeah, it's a great time to have that conversation. It's a great question. I think for those of us, particularly the three of us on this stage, it's been a labor of love to get to the point where we could celebrate the existence of the LEAD model. So I'll start there. I mean, I think the partnership with CMMI to develop a model that has a little bit of something for everybody has been a really tremendous partnership. You already alluded, Aisha, to the 10-year duration of the model, the no rebasing, which are huge opportunities. I think there's an interesting mix of stability, meaning elements of other models that we've seen that folks are comfortable with in the LEAD model, and then brand new things that will be tested and hopefully learn from along the way. I think we're really interested to see more detail on some of the financial parameters around the model, which of course are some of the most important decision points for folks who are considering participation in the model. But an interesting approach to benchmarking, which you had mentioned, some ability to add back in some prior savings adjustments makes a big difference for ACOs who have historically been successful in prior ACO models. It's not always easy to design an ACO model for people who have been around for a while. And then this idea of integration of specialty care, risk arrangements with specialists, is also really interesting. I think we're really excited to learn more, to work with CMS to see how that will work out. It's been a long-term challenge, I would say, not just for folks in our network, but I think probably primary care ACOs in general, to figure out how to have those kinds of really meaningful relationships with specialists and help their patients move through the full spectrum of care in a way that protects the Medicare budget, protects the pocketbooks of Medicare patients, and avoids any sort of unnecessary higher acuity care than what a patient might need. All of that happens now. So really excited about those few things. I think we're hopeful to announce a little bit sooner to the launch of the model, our participation, but we certainly will be part of that model in some form or fashion, and we're really excited about it.
Aisha, anything you want to add on LEAD? And maybe talk about how your members are thinking about the participation choice between LEAD and the Medicare Shared Savings Program, both, of course, offering that potential to invest in primary care.
Yeah, I'll add one more thing that I'm excited about in LEAD, which is incorporating approaches to bring more complex, high-needs beneficiaries into accountable care. REACH tested that as a separate track, but what I think is really important is LEAD is recognizing that for many practices, they have a range of patient acuity. There are, of course, the practices that really focus on the complex, but for those that have a range of patient acuity, you need more resources for that complex set of beneficiaries in your practice. So we're excited about that aspect of it. In terms of thinking about LEAD versus MSSP, a lot of it is into the math. So are you full risk, or are you, people are tending to look at just the enhanced track. So that has different financial considerations. But then, as I mentioned, there's different flexibilities in how you might adjust your models of care because of the flexibilities that are are built into the model. So I know what we have seen from many of our members, lots of putting in applications for both, waiting for the additional details on the financial methodology to make the ultimate decision between the two. And I know for many of our large members, they participate in both MSSP and Reach previously and then LEAD. So we expect to see a blend of that, but waiting without the financial methodology, I don't think folks fully know what they're going to do.
That's right. That's right. I want to turn to the topic of AI. We heard a lot from our administration speakers about access and other efforts going on across the entire government around AI. I was at a talk recently where a primary care physician known, I think, to everyone in this room, but I'm not going to name him, told a story about how he had just trained a resident on how to use a fax machine. So I feel like now I have to bring that up every time because I just feel like that is still like a main staple, the healthcare industry keeping that machine alive. I'm curious, Katie, for you, how are your practices thinking about incorporating AI as a tool? Is that going to be patient-facing? Is it more back-end, risk adjustment, those kinds of things? We're almost, by the way, at our accountable care bingo. We've hit APM and MACRA, rebasing benchmarks, so we're almost there. But I'm curious how your practices are thinking about using AI and incorporating that into the future of their performance in these models.
Yeah, and I think there's a whole spectrum of opportunities and tools that are either patient-facing or back-end. But since you brought up fax machines, I'll bring up that my mom was a medical transcriptionist, and she literally got tapes from the hospital that she would plug into and put on headphones and type all the dictation. Now with AI scribes, we've come such a long way where you don't have to employ a whole army of transcriptionists. There's more real time. It would take them weeks to complete the dictation on these tapes. And now these ambient scribe tools are really important, and there are several of our partners who are using them, and they report that their time spent doing dictation and other types of administrative tasks because of these tools is reduced pretty significantly. And they have come a long way too. You didn't always hear that they were excited about using these tools. And now what we hear is they're actually quite good. And you can apply other AI tools on top of those things. So you can look at the notes and have an AI tool help you think about, okay, well, you mentioned this, you talked about these symptoms, you prescribed this medication. Could it be that this patient has this diagnosis? Helping them think through, certainly not making those decisions for them, but helping them to think through and reduce some of the sort of mental load of being a primary care doctor who's looking at every aspect of a person's health. So those tools are certainly in use across our network. We also have one really leading edge practice that has invested their own funds. Again, because of the resources available through value-based care models, they were able to invest in an AI tool that's, I think they call it an AI coordinator, that is patient-facing. And so for patients who need more hands-on kind of monitoring, let's say each morning they get a text message from this AI coordinator saying, how are you feeling today? And the patient says, well, actually I woke up this morning and I was having it was a little bit more challenging to breathe. I took my weight, it's a little bit up today. I'm not really sure what's going on. And the AI coordinator will probe a little bit while also saying to a primary care doctor, like, hey, he probably needs to come in today. It helps to triage the level of urgency, the level of acuity. Sometimes the answer is, okay, well, let's get you in this week, right, for your primary care appointment to see your doctor. Or it's, you should come in today. We're going to make that appointment for you. If you need help getting here, we're going to help you with that too. And then the doctor calls them. So patient-facing, but also helping the practice better manage their population and, as always, keep patients out of the emergency department or having a health crisis that could have been prevented.
Aisha, similar question. We heard a little bit from the administration speakers about potential around volume with AI. We've been thinking a lot about the overlaps between access and ACO models and sort of the great promise of those tools, but also some of the challenges. Would love to hear your thoughts on AI incorporation.
Yeah, I think Katie gave some great examples. What we've seen from our members is that they have really shifted from AI focused on sort of the back office functions and now really thinking about patient-facing tools. And what I've learned from our members is everyone is really challenge their assumptions. So things like we thought virtual care managers, that patients don't want to do that, but then they see huge uptake. I think the promise of access is shifting payment stream. So right now, what most of our members are doing is taking their shared savings and investing into AI. That then reduces what also they have in their pools to go back to their participating practices. And so if there is some level of payment for it from payers, that is really positive. So we're excited about the access test in helping us understand better how we pay for it. The thing that we are closely monitoring and our members have the most concern is, how does this partnership really work? So we've been talking to our members a lot about who makes the best partners from an AI tool perspective. How do you structure those contracts? How do you know that their tools do what it purports to do, and it's actually going to lead to savings, or if it's not leading to savings, what is the other value it's bringing? So really thinking about who are your partnerships is the first most prominent thing that's top of mind. I think the secondary thing is if there are tools out there in the market that your patients are engaging with, but you have no idea. Access does have a requirement that information has to go back to the primary care doctor. But what does that look like? We have a lot of still interoperability challenges. How quickly do you get that information? And then how do you partner with folks where you don't have a financial relationship? How do you best support your beneficiaries when they're using some tool that you don't have access to the data? So I think we're gonna learn a lot, but there's also some areas where we're a little cautious and continually monitoring that I think will evolve as the model continues as well.
Great. For those of you that know me in this room, you know, and certainly you two on the stage know, I can't get off a stage without talking about skin substitutes, so we're gonna go there next. Over the last 5-ish years, accountable care organizations led by Primary Care have demonstrated how effective they can be at identifying aberrant patterns in data and helping to really pinpoint fraud and abuse. One of the most egregious examples of that, of course, has been skin substitutes, where we saw over $19 billion of spend in 2025, up from a reference point of 2019 spend of $250 million. Aisha, can you talk a little bit about the role that ACOs played in that, uncovering the skin substitutes problem, helping the administration take action, and any future asks around how to sort of speed up that time so we're not spending $19 billion on every new fraud that is discovered?
Yeah, I think the skin substitute example and then the year prior, the catheter fraud example, is just a testament of the value of accountable care. So through various forums, they're both NACOS and Accountable for Health, it was just our members coming together and saying, hey, we're seeing these costs escalate and it makes no sense. But then because it's founded on primary care, we also had stories from the practices of, yeah, we are working with our beneficiary. They don't need this at all, or they didn't receive this service at all. They're getting a weird explanation of benefits that makes no sense to them. We have to talk to them about it. ACOs have an obligation to report what they think is suspected fraud, waste, and abuse to the government, and they do that, but it tends to go into a black box. And so the sort of power of ACOs coming together has helped really highlight and elevate these things and bring the attention to CMS to, in this case of skin substitutes, address the payment policy flaw, and in the case of catheters, sort of stop the bad actors. Some of the things that we want to see to improve these processes, one is opening up that black box. We feel like we do a lot to identify the fraud. We're talking to our beneficiaries about it. We're reporting it to the government, and then we don't know what happens with it. And so we want a better feedback loop of at least knowing, yeah, we're investigating this. It helps practices communicate back to beneficiaries in a better way, but then it also has a financial implication. So across all of these things, we have been saying, are we going to be held accountable for these costs that is fraud outside of our control? Sometimes CMS is not actually even paying the claim. They're just putting it in escrow while they continue to investigate. but that shows up on the ACO's financial statements, and they have been held accountable for it, and which means like it ultimately reduces their shared savings, and then sometimes it changes an ACO's into having to pay shared losses. And so ultimately, we just believe we shouldn't be held accountable for fraud that we're discovering, communicating with beneficiaries about, and reporting to the government. And so we want to see stronger policies, and I'm hoping that we see that in this upcoming fee schedule rule of just a better approach for ensuring that if it's fraud, it's not held accountable for ACOs.
Go ahead, Katie.
I think the one thing that I would just add is being in a really wonderful position to be members of both of your organizations and working with the members that belong to your organizations. Sometimes one ACO, is the first to figure this out, and sometimes you hear about it from somebody else and you think, oh, wow, let me go look. And so this community aspect of these collaborations between ACOs has also been really powerful in the sense of fully helping to investigate and understand the scope of some of these fraudulent or wasteful activities, and saving Medicare and patients even more money and strife and potential harm than might have been discovered before. So just kudos to both of your organizations for convening all of us and helping us to help the government discover the depth of this.
Yeah, it's been really interesting, I think, to see how far the data capabilities have come for ACOs. This was always part of the original vision of the ACO movement, was to incentivize the finding of the waste, the reduction of the waste, and then sharing in that waste reduction. So it's been really cool to watch. And also, Aisha and I have learned that the health plans have had this sort of system of communication around bad actors and fraud and abuse and patterns in the data that ACOs until this year hadn't been invited to participate with, and now they are. So I do feel like we are making progress. We still have a long way to go, but it's really a testament. Thank you for your kind comments about our work, but to your work too on the ground, getting the data together. So I think we have time for one more question. And I liked Sean's final question from the last panel, so I'm gonna go with that, which is, when we sit back on this stage in 5 years, where do you hope we are in terms of the advancement of accountable care and primary care? And Katie, I'll go ahead and start with you.
Yeah, so I think today we've spent the bulk of our time talking about traditional Medicare, and it's a really important element. Certainly has been driving a lot of value-based care innovation, and certainly the work with CMMI on the traditional Medicare side has been incredibly important. There's this whole other half of the Medicare program where folks are choosing Medicare Advantage plans, and we want to make sure that there is equity across those programs so that patients, no matter what they choose, have access to what we view as the really superior care that ACOs and other accountable models can provide to them. And so I would hope in 5 years there's recognition sort of across the entire Medicare spectrum that primary care providers who are doing this work and taking on financial accountability, some call it insurance risk, regardless of which program they sit in or which program their patients sit in, that there's this recognition both in Congress and at the administrative level that when you turn the dials, the policy dials on any of these models, it really does sort of land at the downstream risk provider level. And I don't know that we have a long way to go in terms of educating all of our policymakers about what it is that we do and how we provide that kind of value to the Medicare program, and we'll continue to do that work. And I hope by the end of the next 5 years we have succeeded in sort of elevating that layer of this sort of ecosystem, because right now I think there's a lot of opportunity there.
Absolutely. Aisha?
My pie in the sky numbers would be that we close that gap and we're at 100% of traditional Medicare beneficiaries in an accountable care relationship. I second Katie's point as well of that we have advanced and grown physician and provider-led accountable care models within Medicare Advantage. Many of our members are doing those form of risk-based arrangements, but it's hovered around, I think the latest Lance survey was still around 30%, so just doubling that would be great. And then I think from outcomes and quality and how we provide care that, I talked about bringing more innovation into the models, that we have new innovations that we wouldn't have thought of today. So we've been kind of testing around the edges of the same things with sort of the waivers and flexibilities that we give, but what's that next set and next level? And I think some of that ties into what can we do with AI as well.
Great, thank you. Well, I see Sean approaching, so I think it means I have to wrap it up. Thank you, everybody, and thank you to my panelists, and we look forward to the rest of the conference.
Thank you all very much. Thank you for that great discussion. So we're going to keep the program moving. I'm going to tell a brief story. In 1997, a primary care physician in Bainbridge, Washington, became frustrated with the system of the day. Imagine the frustration that individual would experience today. And he imagined a new approach to primary care. Over the next decade, practices in places like Green Bay, Wisconsin, and Wichita, Kansas, and Enid, Oklahoma kind of began to get on this bandwagon. And then through the ACA, it really got thrust into the forefront, a new approach to primary care called direct primary care. There was some accelerant poured on that last summer through HR 1, for the first time creating a permissible allowability of the use of personal HSA dollars to drive this primary care relationship through what is known as direct primary care. As happens in this town, as things become more prominent, the regulatory and legislative framework around it become both more important and more complex. So to have a conversation about the importance and complexity of that regulatory framework, I'm going to invite my colleague, Stephanie Quinn, to come up to lead a panel discussion on where we are and how we can continue to push that innovative model of care forward. Stephanie.
Thank you. I would like to invite my co-panelists, Jay Keese and Heather Mead. I'm Stephanie Quinn. I'm the Senior Vice President of External Affairs and Practice Experience at the American Academy of Family Physicians. As you all know, direct primary care over the past decade has really grown in popularity among physicians, patients, employers, looking to increase access, decrease administrative burden, and strengthen the patient-physician relationship. But there are still some barriers that exist to its uptake and questions around where it should be regulated. So we're going to dig into some of that today. So I'm excited to have Jay Keese with us, who serves as the Executive Director of the DPC Coalition. He has been blocking and tackling on the federal and state level in support of the DPC model, and his career has spanned over health delivery reform, physician advocacy, and a lot of these knotty policy issues. So we're excited to have him. And Heather Mead, who is currently a principal at Washington Council at Ernst & Young, who serves healthcare organizations, nonprofits, employers, a multitude of healthcare clients, and helping them navigate healthcare and tax issues, and brings with her advocacy, congressional, legal, and political expertise. So we have some heavy hitters here to help us dig in, and so we will jump right in. So first of all, thank you for being with us. I think let's start at the start. A lot of people don't live and breathe this every day. Can you give a brief flyover of what direct primary care is, and maybe how you've seen it evolve over the past few years? And I'll open that to whomever wants to jump in first.
I'll let you start.
Well, thank you, and thanks for having me here today. It's an honor to be here with such a great panel and in such a great forum, because I mean, I think Sean really laid out the start. I remember sitting in my office in 2009 as the Affordable Care Act was rounding the finish line, and Dr. Garrison Bliss from Seattle, Washington, and a group of folks with the clinic he was running came into my office and said, you know, we have this Affordable Care Act thing is really moving fast, and it's going to require that all primary care be delivered through insurance. And we have this great model that's working out in Seattle where the primary care is actually separate from the insurance. People pay a monthly fee and get all the primary care that they need from a doctor they have a personal relationship with. They can come in and visit anytime, and you know, their cell phone, they can talk to them anytime. And I said, well, my first reaction was, well, how do I get that? And to be honest with you, since then, in my work with it, that has been the first question policymakers ask when we go in to describe what the model is how do I get that? Because at its essence, what primary care is imagine a world in which every man, woman, and child in America had a primary care, had a health care benefit, and at the center of that health care benefit was a personal relationship with a primary care doctor that was accountable to them, the patient, and that relationship also created around that personal relationship was a financial structure in which the payment for the physician in the direct primary care agreement was directly accountable between the doctor and the physician. So we talked a lot about risk this morning with our friends at CMS, Abe and Joe, and so I mean when you really look at it, direct primary care is the most risk-based form of primary care out there because it is 100% performance risk. The nature of the relationship in the direct primary care agreement is functionally between the doctor and the patient. Now, sometimes an employer is paying for that service. Sometimes a health plan is even paying for that service. There's lots of different ways to sort of skin the cat about where the payment model goes. And I know there's some conversation about, well, what's DP, direct primary care, what's pure direct primary care versus what's not. The reality is it's a relationship in primary care between a physician and a patient that is paid for outside of the confines of third-party reimbursement of insurance that, again, is a contractual relationship between a doctor and a patient to pay for primary care. And it's grown since then. We did get the provision in the Affordable Care Act. We've spent, decades since then flying around the country to 35 or more states, passing laws that harmonize with that provision that says that direct primary care is an agreement between a physician and a patient. It is regulated like any other part of healthcare by not an insurance commissioner or an insurance department, but by a board of medicine as a part of the practice of primary care. And we've really been blessed to have AAFP as a partner, and Sean Martin early on in this journey came into our conference room and said, we really want to help direct primary care grow because the AAFP looks at direct primary care as one of a few models that are really going to help advance the cause of the small primary care physician, in addition to the larger network practices that we all know are out there that are doing this at scale with employers. So that's some deep background, and it's a great question. I'd love to hear from my colleague over here about it.
Jay, I think you said all of the most important things to answer Stephanie's question. I want to make sure we get through all of the other questions too, Steph.
Yeah, that's fair. So in my experience, legislation typically follows understanding or misunderstanding. From your perspective, what are some of the misconceptions that you've observed from policymakers about direct primary care, and is that a shared interest? Is that bipartisan or a shared misunderstanding?
This is actually something that has made me very sad over the last year in particular. Jay and I come from opposite sides of the aisle, but have a unified and shared love for the power of DPC and what it does for patients. And I think one of the challenges that we have faced with direct primary care is that the barriers that are created to sort of really realizing the potential and benefit of DPC has in some ways made the expansion and the continued growth of DPC partisan in a way that it does not deserve to be. So one of the pieces of legislation that Sean was mentioning in the One Big Beautiful Bill, or HR 1, that passed last year, it made changes to the tax code to facilitate the ability of DPC practitioners to support their patients in using their health savings accounts. DPC is beautiful if you need primary care, but for patients who may need specialty care beyond that, they need the practice to work with their coverage beyond that. And so it has made many Democrats in Congress view DPC as aligned with health savings accounts, which they view view as a partisan issue, and to think about it as an access issue rather than actual care. And I think that's a real misnomer, and I think something that Jay and I will be continuing to have those conversations on the Hill.
Do you see anything on the other side of the aisle in terms of misconceptions or misgivings about expansion of DPC?
You know, I would echo what Heather said, and you know, the reality is we tried for 10 years to talk to Democrats about the notion that if there weren't HSAs, there wouldn't be this problem. So to say that DPC and HSAs are connected is only really a truth since January of this year, when the IRS made the final rulemaking for HR1 that allowed this compatibility between HSAs. I think the biggest problem that we get, and this also is a point that Democrats have made over the years, is that people conflate direct primary care with concierge medicine.
100%.
And while they share similar traits in that you have a personal relationship with a primary care doctor that's paid for outside of fee-for-service medicine, they are fundamentally different approaches to primary care. Direct primary care is a primary care relationship for a covered service, which we all, you know, the ACA mandated that primary care be a covered service. And even before that, Medicare mandated that primary care be a covered service. So functionally, while a direct primary care payment for a direct primary care agreement is it's a payment for a covered service. In other words, it's a new way to get to paying for primary care rather than fee-for-service, paying for widgets, paying for 99124s. It's paying for care. I think that was my club membership, not an actual. You know,
Nobody should bill that code.
So don't bill that code. Put it on the Underhill tab. In concierge medicine, it is a fee for a non-covered service. Generally speaking, in a concierge relationship, it's a fee for an executive physical or something that isn't covered by the insurance. So they're sort of fundamentally paying for different things. But at the end of the day, the idea is to make primary care as efficient and as affordable as possible and put it up front at the beginning of the relationship, so the primary care benefit is paid for outside of the insurance, and then the insurance can do the things that can't be done in primary care. Concierge service, I would say, is great if you can afford it. It's sort of extra, which is what the term concierge applies, and it's a wonderful thing. But our mission with direct primary care is to see that, you know, everybody has access to this kind of care. We want to see it in Medicaid. We want to see it in Medicare. We want to see it in employer-based coverage. The coverage is separate. And so that's the fundamental difference that I see. And I think HR1 and the passage of that did a great job of saying this is what it's about. You can now take money that is your money out of your HSA and pay for your doctor. Employers are now allowed to use that to pay for a primary care benefit through a DPC agreement, and it really has, you know, sort of there are very specific levers within that bill to say that this is a payment for DPC, not for concierge, which is, you know, part of it is the $150 limitation on the cost of the agreement. Part of it is other aspects around the bill that define it that as covered services and as opposed to non-covered services. So it really did a great job to clarify that, but I think there's still some conflation there, and we work hard to try to fix that.
So let's move inside the Beltway. So we've established that there's some bipartisan interest in expanding DPC, but it's been incremental. If Congress could take on one or two issues to accelerate adoption, what might those be?
It's interesting, right? Because part of what makes DPC so beautiful is that it's actually the clinicians driving the decisions, right? And not Congress driving the decisions or regulators driving those decisions. And so it is a little bit double-edged, right? As we take what is really this organic model of bringing the patient and the doctor as close together as possible and say, yes, but how do we take the benefits of this and expand it so that everyone has access to this potential? So I think one of the things that we're going to be watching for, and what you've heard in the other panels, right, is there is a lot of conversations that are bipartisan about, all right, how do we change payment models? These are congressional conversations, right? How do we revisit MACRA? How do we revisit the payment models that we've set up so that we're bringing in the most innovative and the most promising models? And so I think there is a question about, as we do that, how do we consider the inclusion of DPC models so that we both retain the independence of the model, but also share the potential of the model? So I think that's part of the next conversation that we're about to have. There's also some cleanup work being done on HR1 that Jay and I have been spending with Stephanie a lot of time, making sure the administration finalizes the regulations in order to give the greatest opportunity for growth, allowing employers to more flexibly contribute to DPC arrangements to really support their patients. One of the things that is so beautiful, I think, is we're starting to see people that are outside just those DPC arrangements themselves recognizing the value and wanting to see that replicated across government payers, whether it's the Medicaid system, the Medicare system, but also really in the commercial system. And so I think watching that while maintaining the benefits are something that will be coming next.
Heather, I'm going to stick with you. One issue that comes up repeatedly is around tax policy. Is this an issue of fairness, or would modernizing these policies really expand access to this?
It really does expand access. And I think part of what is happening, right, is the consumer has very few healthcare dollars, right? And they're trying to figure out how to maximize them. I'm going to ask everybody to raise their hand. You can, if you think premiums and prices for consumers are going up, let me see a raise of your hands. Right, like we need to move, right? So there is both an impetus by Congress and an impetus by individuals to figure out how to stretch those dollars. And the way most people access their health care is through the employer-sponsored system. And the employer-sponsored system is flexible. It is really constrained primarily by the tax code, which means that we also need to work within those parameters if we're going to expand coverage for care. So I do think it is both a fairness, but while I think there's some irritation about having to do it, it is about creating that access for the employee. And so employers are looking for those places where they can offer the highest value care, and they're finding that in that DPC relationship. And so we do need to make the tax code work in order to facilitate that access, both for employers and for employees, because they're trying to get to the same place.
Well, I would again completely echo that, and the work that we did to try to get this provision, the Primary Care Enhancement Act, to change the tax code. I mean, I'm just going to lay it on the table. It took more than a decade. So, changing the tax code is hard. And I think what could be next to follow up on this is looking at, candidly, other parts of the tax system, like the Social Security system, into the Medicare and Medicaid programs, using employers who have led the way on these models as probably where we could go next. We talked a lot about measuring what we treasure today, and one of the key learnings here is that primary care is, let's face it, probably over-measured for what it can deliver. We believe in the direct primary care movement that it's time to really look downstream to the carriers, and the employers have been great partners in this, showing us the data of what actually happens when you include direct primary care into the benefit mix. And what happens is magic. People have a relationship with a primary care doctor that they trust. They seek more care in less expensive, less invasive, less acute primary care, and they reduce downstream costs to the system. And I think DPC can play a great role with that, but only if it's handled carefully. Medicare is very good at collecting data. Let's collect the downstream data to measure how DPC is doing on the front end, rather than burdening the providers that are out there doing direct primary care with a lot of measures up front. Measure on the downstream. And we've had a long conversation with CMS about this, and they've come a long way on it. And I think that's kind of what's next.
So it's very difficult to have a conversation in DC about healthcare with it not landing on access and affordability. That's where most conversations are grounded. And I think there are two schools of thought, and I would love your perspective. Some see DPC as a fundamental part of this larger conversation around reform, and others see it as just a departure and just a very different way of doing things. What is your perspective on how DPC fits into the affordability conversation?
Well, I mean, you see the provision in HR 1 and the Primary Care Enhancement Act was specifically designed to address affordable primary care. So we are completely aligned with the role, the goals of the triple double that we're having a conversation about here. But the reality is, there's been a lot of cuts to physician services and payments over the years, and we don't want to cut what works. And so my argument has always been that if you pay more for primary care, we will be paying less for other services downstream. The other factor is that one of the things that direct primary care seems to make, and Dr. Emily Scott is here, you can talk to her. She has one of the most successful primary care practices in the country in Irvine, California. They make happy patients and they make happy doctors. So the largest growing cadre of the direct primary care movement right now is people coming out of med school. And interestingly enough, it's also, on the other end, people at the end of their careers in fee-for-service medicine having a look back saying, hey, I could do this another 10 years if I could do it this way. So I think both we can address the cost to the system by bringing better primary care up front and reducing downstream costs, and we can grow the primary care workforce by making some happier doctors.
Yeah. One thing I do think it's really important, and your question was like, is it the same or is it different? I think the answer is it's essential. We are going to have to think about healthcare differently if we're going to do this. And I do a lot of work with employers, very, very large employers and also small employers, but mostly very, very large jumbo employers. And one of the things that we've seen, Abe talked this morning about how premiums are going up 7%. I will tell you that's actually a significant understatement, right? Large employers who are the most able to negotiate with insurers are seeing premium increases this next year. They would be happy to take a 7%. They're seeing 8, 12, 14, 20% premium increases. And where this has taken them is actually back to that partnership with physicians and back to primary care. And the employers that are engaged in these relationships are seeing cost savings in those populations of 11, 12, 13, 14% across those populations. Those are massive savings when you're spending $2, $3, $4, $5 billion a year on healthcare. And so they're actually looking for an expansion of this, and they would love the whole system to shift towards this, and they're trying to lead the way. Part of what they're doing, though, is they're leaving their insurers to do this, right? They have been working with their insurer partners asking for these types of relationships because it's very difficult for them to manage these large populations. They're not finding it. And so they're actually asking their physicians to come work with them on building these types of approaches. It's both in direct primary care, but it's also direct contracting directly with specialty practices and hospitals as well. They're continuing to see these types of savings. One thing that I think is really interesting in this space is one group that I work with, the Purchasers Business Group on Health. They represent 40 of the largest employers. They're also very innovative, right? They're trying to make changes in the system. So this last year, they took all of the new healthcare transparency data that is very annoying on a clinician side to have to produce. But they also took the insurer data, and then they actually applied quality data on top of it. And they looked at all the different arrangements that they had available across 5 jumbo employers, so millions and millions of lives. And the one thing that stood out to them was that in every single instance where there was a direct contracting arrangement in place, which included those DPC and advanced primary care arrangements, they won on cost and they won on quality across the board. And so you're going to continue to see those types of lessons being picked up by large employers, and they're looking for opportunities. So getting that tax code right, getting the conversation moving in the right direction, focused on primary care. Every single large employer group that I work with, they're asking the same questions that you are. How do we get more primary care workforce? How do we double that workforce? How do we make sure that our community health centers are healthy? You actually have a lot of friends in that employer space that are asking those same questions, because if we're going to do reforms, it needs to be kind of that core question. How do we get everybody to this model?
I completely agree, and it sounds like most of the progress is, unsurprisingly, not happening in Washington. It's happening in the private market, but also the states. Jay, can you talk a little bit about how some of the states have really embraced some changes that have driven progress for the DPC model?
Sure. I guess first a story. I had a little procedure that needed to be done in the hospital a couple of years ago, and I.
This is no longer HIPAA protected.
Yeah.
Okay.
So I signed the waiver, so my doctor sent me to a cardiologist, and I needed to get I had atrial flutter, so I needed to get an ablation done, and I went to see the cardiologist. He says, "You got atrial flutter. I'm going to refer you to a cardiophysiologist." Is that the right? There you go, electrophysiologist, to do this ablation. And basically on the way to the hospital, I got a call from the insurance company that says, "Well, you didn't have a referral from your cardiologist." And I said, "Well, yes, I did." "Well, it didn't have a referral from a primary care doctor." I said, Dr. Matt Hayden, my direct primary care provider, made the referral. And they said, "No, it needs to be an in-network primary care provider." So I had to go back to an in-network primary care provider to get a referral for something that had already happened 2 months ago, so they can be contractually in agreement with. So where I'm going with this long story is that all over the country we're seeing referrals being sort of denied by primary care providers because they're not in the network that the specialty care is being provided in. So Iowa passed a law this summer that basically says any primary care provider can refer anybody into regardless of the network, into anybody's network. We're seeing laws like that being passed. As I mentioned, we've passed laws to sort of harmonize with the provision in the Affordable Care Act that says DPC is not insurance, it's not regulated by the state insurance commissioner. We've seen that pass in 35 states. One of the great things that happens in a direct primary care agreement is also that most physicians in DPC dispense medications right in their office. It's usually a $5, $6, $7 copay for a 30, 40 day supply of medications. You take it with you. There's 100% medication adherence, but there's still states, Texas and Massachusetts, that prohibit that. So we're actively engaged with states to try to change those dispensing laws to allow physicians to dispense medications. When did dispensing medication not become part of primary care? So we're active on a lot of fronts now. I think we've won a lot of the major battles on this, whether or not it's insurance. That question has been solved at every level on the regulatory side. So now we're looking at things that are going to improve what the DPC doctors can do, refer into networks, provide medications, really sit at the table with the insurer in a debate about who's going to provide care in the Medicaid system or with state employees, and have an equal footing with the managed care providers in those states about what that looks like. So lots and lots going on in the states, and it happens a lot faster than it happens here in Washington.
Yeah. Well, great. We're going to hit the lightning round now. So I would love it if you could hit us with one policy development that you're watching closely over the next 12 months.
Related to DPC. I think we're going to have this massive conversation about healthcare affordability, and it is happening both on the Republican side of the aisle and the Democratic side of the aisle, and I think making sure that these types of arrangements in primary care is at the center of that is really important. There are opportunities to weigh in. Democrats are holding a process where they're inviting people in to talk about it. Go in and talk about what you're doing and how it makes a difference. So I think that's really exciting. I'm also watching this tiny little bill in California that's allowing a a demonstration project for direct contracting with a large employer group. The fact that we have to have a bill to do that is insane, and I would like to see that resolved for all of our physician-employer collaborations.
Well, I've mentioned the conversations we're having with CMS about Medicare and Medicaid on the federal level. I think that's obviously, what is next. But I really do believe we are at an inflection point. You know, when you're paying $27,000 for a health insurance product that does not allow you to access, you know, the primary care provider of your choice and doesn't provide a lot of value, I think that we are at a point at which we're whether it's about affordability or it's really, to put it more succinctly, I think it's about value, where we're going to have a conversation about what we value in care. And I think if you ask the question, would you rather have health insurance or would you rather have a primary care, a relationship with a primary care doctor that knows you and knows your family, which of those things brings you more value? I think there's very little question that while you need both, the thing that brings you the value, again, is having that entry point into the system be with a primary care doctor that you've chosen, that knows your family, that knows you, that knows your history. And I think DPC will be a major part of that inflection point, moving people into that area where they have better choice and better options in the healthcare benefit that they choose.
Well, thank you both, not only for being here today, but for the work you're doing to advance DPC. Please join me in thanking Heather and Jay.
Stephanie.
Thank you all so very much. So we just kind of gave you an overview of what's happening out there with respect to direct contracting and direct primary care. I am now pleased to bring some of those innovators up here. And to lead this conversation is Dr. Sarah Pastor from Elation Health, but also a DPC practice owner herself. And this will be our last session of the morning, and then I'll come back up. Dr. Pastor.
Hello, hello.
It is bright.
It is so bright. Well, great to be here, and I think that previous panel set up very nicely what we're going to talk about. And you heard them talk about how the direct primary care model is really payment for primary care that is divorced from the insurance machinery. And I think that is like the foundational principle that we really need to focus on. And one of the beautiful things about that is that it really unshackles primary care to start to innovate, and we're here to talk about innovation. DPC started as sort of this fringe grassroots movement and now has taken the country by storm and is becoming more and more popular, and adoption rates have been doubling, tripling year over year amongst both physicians and patients. And I practice in DPC myself. My family has a DPC doctor. I'm all in on DPC. Once you go DPC, you never go back. And one of the beautiful things is that you really begin to realize when you practice in that model that we have been sort of stuck in this box of how care should be delivered. And in DPC, the rules are, there really are very few rules. And we really get to reinvent how care should be delivered, where we should meet patients, and how we can really begin to impact health and relieve suffering and improve lives. And so it's really a magical thing, and we're excited to talk to you about it today. So that being said, I would love to do some introductions first and let you meet our wonderful panelists. And so maybe we'll start. Oh, I should introduce myself, Dr. Sarah Pastor from Elation Health, and also I do still practice in the direct primary care model in San Antonio, Texas. So maybe we'll start with Kelsey and then Michael and Sabina.
Hi, I'm Dr. Kelsey Smith. First and foremost, I am a family physician practicing in the DPC model in Stillwater, Oklahoma, but I'm also here in a different role. I'm the president of the Direct Primary Care Alliance, which represents direct primary care physicians across the nation, so I hope to be a voice for them as well.
Dr. Michael Hobbs. I am a DPC pediatrician. I was in fee-for-service for 20 years, and I've been a DPC pediatrician for 3 years. I practice in Minneapolis, Minnesota.
And I'm Sabina Singh, a family practitioner in Green Bay, Wisconsin, with a large employer-based practice, and also had been practicing in a fee-for-service model healthcare system for 20 plus years, and started Inovia Health 5 years ago.
Great, thank you. So, Michael, I think we'll start with you. You are, the pediatrics community has really started to take hold of DPC and see the value there. And you're a fairly early adopter and representative of those folks. And I'd love to hear from you what DPC looks like in pediatrics, and maybe something that policymakers don't know or don't understand about DPC in pediatrics. And I'll start with a personal story. I mentioned earlier that my family has a DPC doctor for many years, and my youngest child actually, went into that DPC relationship as a teenager, and it was really incredible to see her develop her own relationship with her doctor, a texting relationship with her doctor where she could reach out personally to her doctor without having to go through mom to schedule an appointment, to be taken to the doctor, all of that. And she could get those needs met and really have that relationship. And it's been so powerful for her. And she doesn't really know care any other way. And I think that would really be jarring for her to experience. So tell us your story.
Well, let me do the policy one first, because this audience is, I think, primed for that. I think the one thing about pediatrics to know is that it's kind of a catch-22. Children are generally really well covered. About 40 to 50% of children are on Medicaid. The rest are usually under private insurance. 3 in 5 pediatric patients will be covered by Medicaid at some point in the first 18 years of their life. The other catch-22s from a policy standpoint is you don't see the benefits of pediatric interventions until they're adults. And so you have all of this money spent. There's not the clear impact that you see in adults. And sorry, I forgot my last point. Anyhow, the Medicaid piece. And so the benefits would be having some coverage for that, which doesn't exist right now. So parents are paying out of pocket. The HR1, the HSA coverage is great for people who have insurance benefits, but if you've got 1 and 2 kids who don't have that, then you don't get the same coverage. What was the other question?
What is it like? How is DPC different in pediatrics?
Perfect. The big thing in pediatrics, and this goes back to my sort of catch-22, is because of the good coverage that kids have, most preventive care is covered, and that includes vaccines. And the problems in DPC is that vaccines then, because you don't have a relationship with insurance companies, is you don't have that covered, and so you either have to find a separate source for those things, or you have to establish a relationship with a third party who provides those things. And that's probably the biggest friction point I think that we see in pediatrics.
The vaccine piece, yeah. Good. Okay, so Dr. Singh, you practice in a little bit of a different model. It's employer-based, meaning that the relationship is between the patient and the doctor, but the employer is paying for that for their beneficiaries. And I'd love for you to share with our audience a little bit about Inovia's story and how you've been able to get employers to understand the value of this and build this into their benefit plans, and how this looks a little bit different. How do you drive engagement? How is how you've had phenomenal growth of Inovia over a short period of time. So tell us about that.
So we have grown in 0 to 5 years. We have grown to about 17 near-site clinics, a few employer clinics, and 40,000 patients have access to us. So you're right, it has been tremendous growth. I think it started with trying to figure out the pain points for employers, which they want to give a great benefit to their employees. They want healthier employees, and they want to keep it simple. And that's where I think we were able to hit on the need. And also being in Wisconsin, which is a lot of consolidated healthcare, very large healthcare systems, and also very expensive healthcare. So I think that's what got us going in terms of getting in the door. We work with brokers, we work with TPAs. We are willing to try and figure all this out together. And then having the employers and the HR folks understand how to do this and sell it to the employees to get that engagement. It's not just us. It is the relationship. They are thrilled when they come in. You'll hear this all the time with DPCs. They like the time, they like the personal relationship, because that builds the trust, that gets us to help them improve their health and get the downstream savings. So I think, the need is there. We have all different kinds of employers, from manufacturing to banks to now school systems, county governments. Everybody's looking for great care with cost containment. And I think, we filled a need. We filled a great need that's only growing.
There is a independent nonprofit called Fix Primary Care, PHYX, that is founded by Dr. Stephen Waldron, who's the CMIO of the AAFP, and Dr. Edmund Billings, his partner in this venture. And they recently did a case study on Inovia that I think is the first of its kind and really fascinating. Can you tell us about that?
Yeah, so we are happy to participate with them. We did do an initial study just broadly on patient satisfaction, employer satisfaction, provider satisfaction, that led to the case study with one of our employers. And I brought it up here to give accurate numbers. Their savings, working through their insurance broker to help figure this out for 2025, was $684,000 in their plan. Their cost per employee went down 14%. And we have a very high NPS score of loyalty and patient satisfaction with all of that. So by doing certain things, but mostly because starting with us and spending more on primary care, as we have said, more on the right way for primary care, for the actual care, they were able to compare us through patients who were not using us, and that's where these numbers actually came from. So it was a cost of care by full episode and led to remarkable savings. And we will hope to replicate this as we expand to look at it with other employers. So very thankful to Jay and Heather for the comments that they made and all this legislative work, but also that it looks like, I believe Heather said that they've already looked at it for those jumbo employers and how it makes a difference too. So it'd be interesting to compare at the different levels of where it happens.
And that 684,000 or whatever the number was over how many employees?
Only 153.
Yeah.
A small group, but a vast amount of savings and very intense management on their part and our part in terms of care navigation, pharmacy benefit manager, other direct relationships, all the things that have been mentioned, but we need to reinforce over and over again that this can be done and this is how we can do it.
Amazing. Who doesn't want to save that much money?
Exactly.
Dr. Smith, the DPC Alliance recently, just very recently, published some survey results about sort of the current state of direct primary care in the U.S. and would love to hear a little bit about those findings. I know you're going to showcase them later this week at the DPCA Summit in New Orleans, where we will, 3 of us, be. So tell us what you can, what those insights were about what's going on in DPC and how it's growing, what's the average cost, where it's headed.
Sure. I think being able to describe the direct primary care movement has been difficult because a lot of it is anecdotal, and the mantra has kind of been, if you've seen one DPC, you've seen one DPC. We all take our own personal tack at designing our practices to serve our communities. But this survey allowed us to get a broader picture, kind of a 30,000-foot view of what that looks like. And it confirmed some of the things that we thought about the movement, but it also put into question some of the things that were assumed. What we found was that the model is adaptable to really a lot of different communities. It is not only an urban type of model. It's not a suburban, not constricted to that. It's even successful in rural communities. We had respondents who have successful practices nationwide, so it's not really restricted by, the location or demographic or anything like that. We've seen direct primary care thrive in a variety of situations and environments. So that was encouraging. We found that the majority of our respondents were female physicians. Michael and I were kind of joking about this. He's the token male up here. But female physicians, I think, are uniquely situated to feel the pain points of insurance-based care because of maybe more work-family balance priorities that we have. Certainly our male colleagues do as well, but I think for a lot of female physicians, direct primary care represents a way to continue to practice medicine meaningfully without sacrificing their other commitments and responsibilities. We also found that the price point for direct primary care nationwide is an average of about $98 a month. So I think that statistic allows people to very quickly differentiate us from concierge medicine. I think you try to define something by something else that you already know. And so Jay astutely said, when you start to describe DPC, a lot of people think, oh, that's concierge. I've heard of that. Policymakers in the room would maybe say, oh, well, that's a capitated plan. I know what that is. It's not. It is a different animal. And so we've seen that direct primary care gives people a way to reimagine medicine in ways that are not currently being practiced. And this study kind of highlights the ability of that to grow nationwide.
Yeah, it's. I find DPC to be this beautiful blend of sort of old-fashioned medicine, where you're sort of the country doctor, the Marcus Welby, whatever, and alongside really innovating and adding technology, and breaking outside the box and thinking always of how we can do things differently to make it better. And so we would be remiss if we didn't talk about AI while we sit up here. And Dr. Hobbs particularly has expertise in this area and has been leaning in some really magical ways to use AI to improve the patient experience, the parent experience, the physician experience. And so I definitely want to hear from you, but I'm going to start with Dr. Singh because you are piloting something really cool at Innovia that I think is worth talking about that most people don't think about when they think about how powerful AI can be.
Yeah, so as mentioned earlier, AI scribes are everywhere. We are using them regularly. It helps with documentation. We need it at point of care because there are so many recommendations, requirements we should be talking about with patients. But what we're doing differently in our model, we do have physicians, but we have a lot of APPs. We have to spread the way we care and trying to have that close collaboration, not working side by side as I previously did in the system and not really knowing what was happening or how it was happening. We want to have a very close, tight collaboration. So we're using AI tool, a new one being developed as a smaller practice for peer learning, for improvement. And learning in the sense not of punishment, not of review, but in terms of how can we do better, and how can we do better, including our referral process and in choosing the appropriate tests of where to go and how to do things. That's where some of the cost savings come from. So it's good medicine that will also help save money. So we're starting to experiment with that and still doing it in a manner where it is, like we said, collaborative and learning, trying not to make it punitive. It will still evaluate for the usual things that you look for in medicine and medication appropriateness, diagnostic testing, what are you adding to that? Did you evaluate this? But this is all kept at a level of how can we do better? And how can we do better in a manner that it feels gentle as opposed to pointing fingers. And so at any rate, that's something that we are just starting to get into, and we'll see how that works.
So it's basically a chart review, but in a way that is really helping people with choosing wisely.
Yes.
And leveling up their care, no matter who you are.
Exactly, and we hope to have it a discussion. it is, here's the tool, and yes, you can read your own report and see what you can do better, but how do we discuss it as a collaboration? And how much of that collaboration extends down to the rest of the team, to the RNs and LPNs that we also use?
And I want to give credit where credit is due. This was invented by Dr. Paulius Mui, who's also a family physician and very creative and kind of a genius with this stuff. So, so exciting to see that tool is being put to good use, and I hope it spreads far and wide. Okay, Dr. Hobbs, tell us all the AI things.
Well, let's take it from two layers. The most important layer is that AI creates like fractional employees for people. And so you talk about agentic AI. So DPC practices are often in need of help for marketing and business and CRMs and all this. And hiring a full-time person just doesn't work for that kind of task. So you can build agentic experiences that can offload work, that can play those roles. But I think from a larger healthcare system standpoint, AI has a way to be like an augmentation of primary care doctors, because we have a shortage of primary care doctors. Patients want information, patients have questions, patients send portal messages, patients send emails, patients make phone calls. And if you have a intelligently created artificial intelligence tool, it can play that role. OpenAI has done a lot of research that showed that 7 out of 10 health queries come after hours. This is a great role for AI. And people are willing and accept it. So those are the two most important ways I can think about applying.
How are you using it in your practice?
How am I using it in my practice? Very different issue. So, we talk about like clinician AI scribes, right? But patient AI scribes are pretty interesting too, because patients come to appointments, there's real asymmetry in knowledge, they have a lot to retain. There's data that shows that after 20 minutes that people don't remember what they were told. And so let them record the visit, let them go home, and then ask questions to the transcript. I have an AI receptionist. I have clinical decision support tools that patients can access. So if they have a question, I'm not available, they don't have to wait. I have played with different scribes. And one of the fun things I think about with AI, and this is for anybody who does any job, is just kind of refreshing what you do. So when my own my clinician AI scribe does notes for me, it drops little clinical pearls in for me, just like, hey, this is the most recent literature. This is the last paper on that subject.
So cool.
It's pretty cool.
So this question is for any of you or all of you. What do you think are the biggest barriers to more physicians and more patients adopting the DPC model? And what are the sort of risk factors to mitigate in order to be successful in working in that model?
I'll throw one out there that I think is really important, because I love hearing that new grads are going into DPC. And one of the benefits of going to DPC after being in practice for a long time is having a lot of just muscle memory. It's seeing lots and lots of patients. And so I wonder if there's a place where we need some sort of mentorship, apprenticeship sort of experience, because they just don't have the same experience seeing patients, and they go from a hospital-based care system to a primary care system, and it's just a different experience.
I think we find ourselves still in the pioneering phase of DPC. I was talking with a colleague and, said the Garrison Blisses of our movement were like the bushwhackers, and then we had the people who followed that, and now we're kind of in the pioneers, like settlers type standpoint. So we have more of a roadmap to follow than those early docs, but we're still some of the people who maybe are a little unconventional, and DPC needs to maybe become more of a conventional thought process for the more physicians to come on board. The majority of docs that we surveyed and that are part of the DPC Alliance have a bit of an entrepreneurial spirit, and I think to be able to be adopted across the board, one of those pain points is to open up DPC to physicians who do not want to be business owners, who want to be able to participate in this model and not innovate to the degree that some of us currently in the model have had to do. So I think that's probably one of the pain points right now, is trying to make that accessible to physicians who maybe don't see themselves as rebels or pioneers.
Repeat the question.
Oh, well, just what are the barriers to adoption, and what are risks for being successful?
Yeah, I think Kelsey hit the nail on the head to a degree. I talked with other people about golden handcuffs, at least in Wisconsin, of non-competes, being employed your whole career, the security of it, loan repayments. How do we get, this is all addressing the workforce that we are going to need to take care of all of us. And the DPC model can provide that excellent care, but we do need the family practitioners and the pediatricians and the internists to do it. So to get over some of those barriers, like I said, some of those things will have to go away to make this happen. Exposure is tremendous, so we have to get into the medical schools and undergrad teaching for healthcare professions so they can see that there are alternative ways to do this. And I think also, like I said, you mentioned the employed model. That's what we do. We don't have physicians as partners unless they have been with us for some time. Again, back to the old-fashioned, are you going to be a part of the practice, and how are you going to be an owner, or are you going to be employed? We are away from the RVU model because that does not work in team-based care. We all need to be helping out the patients in any way we can. And so I think having other options, especially for physicians, is tremendous and will go a long way to burnout, to getting more students to go into primary care, to attracting quality candidates.
Anyone can answer this question, but I'm going to start with you, Dr. Smith. Any policy changes that at the federal or state level that you want policymakers to hear that we need?
Yeah, I mean, I feel like direct primary care, at least my personal experience of being on the insurance-based, like we'll call family medicine, like a slow-moving barge, I started to see that the ship was starting to leak a little bit and was maybe listing to one side. And as one person on a large ship, I couldn't do a lot to right that course, but to be able to maybe see those issues and jump ship and build a more nimble, like a racing sailboat type of thing, allows me to change course. So it's difficult to look back and talk to policymakers now to say, okay, well, now that I've found a different way to practice medicine, how do I help you right that ship? It's hard. And when I hear people talk about reporting measures and coding, and I start to get a little bit of chest pain. Truthfully, a little shortness of breath. It brings back some PTSD. So I think that, necessity is the mother of invention. And so I think, like you said, thinking outside the box to be, how do we uncouple primary care from some of these things that policymakers may find really hard to let go of and put patients back in the driver's seat. I think the idea of using HSA dollars and putting those in the hands of the patient and allowing them to spend them where they see fit is a true innovation. I think it makes policymakers a little scared to think about that. But I think that is really where we might see the future of primary care become more powerful.
Anyone else?
I think figuring out how to do this in Medicare and Medicaid is going to be the challenge, but also the biggest reward. Again, that's half the population now. We're primary care. We want to take care of everybody. And we do have families where they do have children on Medicaid, but they are on the employer plan or vice versa, and then they move on to Medicare. And we have that relationship already. We want to maintain that relationship throughout the lifespan. So I think that is to be determined. Won't be easy, but that is definitely the way we have to move.
Universal vaccines for children. Covered for all kids at all ages. It is the biggest barrier to a pediatrician deciding to do direct primary care is, how will I get the vaccines covered? Because if you can't get the patients. If you can't get the patients, you can't keep the doors open.
Even you've been struggling with that, right?
I have, and I think I'll have to talk to Michael later. Some of the resources there are just very limited and have become prohibitive.
Yeah, so that's a big opportunity. All right, keeping with the theme, looking ahead 5 years, our final question, where do you see direct primary care going? Anyone?
I would hope that every medical student knows that it exists. I think even still, people who go into medicine may have an idealistic, and all medical students have a lot of idealism just built into them, but they have an idea of what they want to accomplish in medicine, how they want to help people, how they want to serve their community. But I think through medical school, a lot of that is institutionalized out of them. And so I would hope in 5 years that medical students and residents would see primary care as a place where they can be the doctor they always wanted to be, and that it is a desirable path in medicine. I think what family medicine has struggled with as an identity crisis is when you introduce yourself to someone in the medical community as a family medicine doctor, I think the unspoken question is, well, what kind of doctor did you want to be? And that family medicine is somewhat of a fallback plan. And it wasn't for me, and nor should it be for medical students that choose that path. And so I think showing that family medicine can not only be palatable, and primary care in general can be palatable, but desirable, is where we need to be in 5 years to drive that doubling of the workforce.
I think 5 years is hard to predict, given that's the length of Inovia at this time, and did not predict this. However, what would I'd like to see? I think DPC expanding, hopefully to everyone, as we've talked about. Everybody needs primary care. How do we make that work? I think the AI possibilities are tremendous, and I think that's the unknown of how can we use it for patients to get information, for clinicians to get the right information, for the understanding the risk, how we can understand policies. It could be not something we can't even think about at this moment, and how that could work. But it still comes back to, right, having the people to do it, having the resources to do it, and investing the money to do it. So right back to the, the triple-double.
Yeah, one of the things that I've been noticing in my own practice and heard from colleagues is that clinical decision support tools driven by AI have really driven down our need to refer. I no longer need to refer to get a question answered. I really only need to refer for like edge cases that are diagnostic dilemmas or to get a procedure done. And so that really increases the need for primary care and dramatically decreases the need for the downstream stuff and improves the quality of the care that we're giving. So think 5 years from now, what that's going to look like.
Yeah, I'd love to see DPC be a household word. Everyone knows what it is. Everyone's looking for it, and they can't find it because there's just not enough because the demand is so high.
All right. Well, thank you so much, and congratulations to all of you for your success in DPC, and may it proliferate, and may all of you have a DPC PCP. Thank you.
Well, thank you guys very much. Before you go, Sarah, I just want to point out not only did she just do a masterful job navigating this conversation, but she did so on her birthday. So happy birthday to you. We are going to go dark. For those watching online, we will be back 2 minutes prior to 12 p.m. Eastern Time to resume the program. Okay, for those in the room.
right, tell me when you're ready. For those in the room, the afternoon session. And so for those online, we've been having a wonderful dynamic lunch and conversations in here, but we're about to kick off the afternoon session, which we've got a great leadoff batter or point guard to help us, Dr. Asaf Bitton, who's the Executive Director of Ariadne Labs, an amazing health system innovation center at the Brigham and Women's Hospital and the Harvard School of Public Health. And he leads their efforts to design, test, and spread scalable solutions that make domestic and global health systems more safe, equitable, and integrated. He's also an advisor to CMS. He's got an amazing bio. You can look at it. I'm proud of the fact also that we met as he was on the NASEM committee, implementing high-quality primary care, rebuilding the foundation of healthcare, and serving on the National Academy Standing Committee for Primary Care, co-chairing the payment work group. He's published 140 papers. He's definitely knowledgeable about the evidence, and he's also the father of a daughter named Talia, who's a basketball player. So please welcome Dr. Asaf Bitton.
Thanks so much, Q. I realize I have the opportunity to speak to you as you're digesting lunch, so you may fall asleep. So my job is to make sure that you don't fall asleep, and really to try to tie together where we've been in terms of what this triple-double concept is, how it speaks to some of the challenges that you heard this morning that CMS, through their capacities, is trying to meet, that ACOs, through their routes, are trying to meet, and through direct primary care. Just to put everything up front, I'm a practicing primary care doc, and the crisis in primary care is so real, so vast, and so important that it's an and, not an or. There is not one primary care solution. There's not one primary care typology. There's not one primary care modality that is going to help this country. It's an all of the above. And we should, in this community, be thinking about how to continue to see that, that heterogeneity, that diversity of approaches as a strength and not a weakness, and really leverage that to improve care for our patients. Next slide, please. Disclosures, as Q said, I work for CMS, but I'm not talking for them. I'm also on the board of NCQA and some other activities, but really speaking to you as a primary care doc and telling the story, next slide, about what we're trying to do here. So in the next couple of minutes, I'm going to present to you a lot of data, but I don't want you to focus on the sort of subtext of the data, but really hear the headlines. And all of this is here so that some of you, if you feel that you need to make the case to your stakeholders, to your clinicians, to your patients, to your policymakers about why primary care is important, or as we've recently seen, there's some members of other parts of the medical and surgical disciplines who don't maybe have full awareness of this data and maybe have a need for a little bit of education. That's what I present this. So every slide is going to be an idea that is really supported by strong data. And the bottom line up front is what Q said earlier and what Sean also mentioned. There is amazing grade A level evidence that primary care is critical to any health system and critical to the foundational population health goals that we all share. The other way to look at it, and I've done work all over the world, sort of studying high-performing health systems, is the following fact. There is no high-performing health system in the world, whether looked at the regional or country level or even a health system in the US. High-performing meaning great quality, great equity at a reasonable cost. There is no high-performing health system in the world that doesn't have a strong foundation of primary care. Bar none, end of story. You know of one that doesn't have that, you let me know, because that's an important observation. So if that's true, then it's incumbent upon all of us in this room and online to figure out how to use every mechanism under our power to really improve primary care. So primary care is associated with better quality. More primary care, better quality across every domain of quality: patient experience, technical quality, preventive care, chronic disease care. This is again, as firm an association as one exists in health policy, and one that you can feel good about. If you invest in primary care and you do it in a way that is with the right incentive structure and in a team-based manner, you get better outcomes. Next slide. More primary care and more primary care access is associated with lower inpatient and ED utilization, as well as lower costs. Now, that does not mean that you put in a few dollars into your primary care systems and next year you are going to have double-digit cost savings. There is a little bit of magical thinking that has existed in different parts of our community or in parts of the value-based care networks that have said, well, let's just give primary care a little bit of money, but they better show us a return. They better show us that return next year. Well, primary care investment takes a while, and I would just humbly offer that no one, especially in the hospital or health system world, ever decides whether to buy the 4th PET scanner and then asks of the PET scanner radiology group to show that return on investment through net savings. So let's just have a reasonable conversation about the fact that it takes time. But over time and over years and decades, more primary care access, lower costs and utilization. Next slide. It even goes further than that. More and better access to primary care as measured by density of primary care physicians. We don't have good enough statistics at the county level for PA and NPs, but we're working on it. Yalda, Jabarpur, and team are working on it. But the association at the county level, controlling for county level confounders, everything from population health, and this is where the argument against, that primary care is just kind of the same thing as population health. It isn't. Really, primary care in and of itself is associated with lower population mortality, and increasing the density of primary care and access to primary care is associated with improvements of population mortality, and that relationship is not consistent at the specialty level. I love specialists. There is no question specialists are important, but we're having a conversation about what cadre of clinicians are associated with better life expectancy. It's primary care in any of its excellent forms. And that supply is falling at the time when we need it the most. Next slide. We know that people without a usual source of care are rising. It's now up to 1/3 of people don't have a usual source of primary care. And the density of primary care physicians and even now primary care NPs and PAs is starting to fall. So in the next slide, we know that basically the issue is not just that people are leaving, but that the pipeline is limited and it's getting more narrow. You can see the lines over onto the right of the graph. Specialty resident matches are going up where primary care matches are going down. In fact, in the bar graphs on the left, we're down to about 20% of primary care, 20% of medicine graduates going into primary care, and that is fallen tremendously over a decade. Next slide. And that has to do with a number of structural factors, but I think this highlights the fact that GME funding, graduate medical education funding, the density of it and the extent of it is inversely associated with the production of primary care. In other words, in states like mine in Massachusetts that have large, primarily academic medical center training programs, they get high levels of graduate medical education funding, but they don't produce commensurate levels of primary care clinicians. And that's something that's within the remit of federal policy that really needs to ask the question, why can't we be more like North Dakota and less like New York and Massachusetts, to call out some states? Next slide. Because the fundamental issue that we have to face, and finally I'm pleased after a number of years where we didn't want to face the issue, is money. Now, it's not that money drives everything, but it's the start of the problems and the start of the misincentives and maladaptations that we've seen over the last 50 years. Primary care only represents, on a good day, 3 to 6% of overall spending, and it's been falling. So we've heard all morning long, primary care works in all these different manifestations, DPC, ACO, et cetera, team-based care. The federal landscape is all in on primary care. The employer landscape is all in on primary care, except what's happening with primary care? Primary care money is falling. So this is an opportunity for us to really harness and leverage that sort of good feeling and good vibes into important action, because this is not sustainable or commensurate with our common health policy goals. Next slide, please. And the deeper issue is the broken production model of primary care, where we have the unit-based, visit-based system. And even though we're 15 years in the value-based care adventure, we are still, generally speaking, on this model, all the way from the practices that are fully fee-for-service to even the ACO practices that have what we call shadow fee-for-service, meaning they're in a risk-based environment, they may take a capitated payment at the system level, but they're still clocked, billed, and watched on an old fee-for-service mechanism. And that's destructive, and that is sort of not aligned with all of the value that we see in primary care, and certainly not with modern, advanced, IT-enabled, team-based primary care of the 21st century. Next slide, please. So the problem's also with the distribution of money, as we saw in our National Academy's report. Again, primary care is basically seeing about the same number of patients as specialty care and getting, less than a third of what specialties are getting paid. And I believe the pie is big enough to sort of not have this be a Hunger Games, redistribution fight. But at some level, there needs to be some boosting of that paltry 5%. It's got to come from some place in the health system. And avoiding that uncomfortable discussion is not in anyone's interest. Next slide, please. The math is very clear. We've done math on on modeling an average practice in all 50 states, taking care of an average panel of patients. Here's the upshot of all that boring math. It's not mathematically possible to take care in a team-based, information technology-oriented environment for all of the preventive, promotive, rehabilitative, and acute care needs of a panel. It is not mathematically possible to do that on fee-for-service, not possible to do it on fee-for-service in with a 10% boost, or even with small increments in care management fees. You need to have wholesale changes in the level and the form of payment. In fact, in other math papers that we've done, you really need to move to about 2/3 of or more of your practice revenue on from fee-for-service to a capitated model, and do that with a boost in order to begin to be able to meet minimal standards on advanced primary care. Let's say in this case, minimal patient-centered medical home standards, taking care of a population and reaching out to those who don't walk in the door. Otherwise, it's not actually possible. So, some of you have heard me say it's not that primary care is a charity case, or people should feel bad for us. We need to be very clear in our discussions with purchasers, employers, payers, and others that this is simple math. You cannot do the book of business that is being asked of primary care with the available form and type of resources that are at hand. That's table stakes, the start of the conversation. It gets more complicated after that, but I will not allow, kind of from a factual basis, the idea that primary care, they got a couple boosts in the fee schedule, they're getting some dribs and drabs here, you're good to go. No, actually, the remit of primary care is growing, and so we need even more and more differently to get there. Next slide. And that's because we have now not even looming, but cuts here to Medicaid. The darker colors indicate even greater proportion of year-over-year cuts, whether you look at enrollment or in reimbursement. Next slide. And so we kind of end in the last couple minutes, this is where I'll end, with sort of some baseline conversations that are evidence-based. So if you didn't want to read these 456 pages, here's what it says. Primary care is the only part of the health system in which investments in it routinely, proactively, and predictably result in better care for more people with more equity at a price that we can afford. That is a completely defensible, science-based statement that you can take home all day long. And within that, community health centers are, if that's the best performing part, primary care, because it produces that, CHCs are really the best part within the best part. They have the best outcomes, the best equity for patients with some of the highest needs across any part of the primary care system. But I think we can all agree that primary care is weakening at the time that we need it most. And so in the next slide, and you know, CHCs demonstrate amazing results, we get to the triple-double. And the triple-double is really based on the fact that every American, every person that's here in the US deserves a relationship that can produce these outcomes, and that to do so, we cannot nibble around in the margins. We actually have to sort of make requisite massive moves toward a couple of common goals. And understand that we're doing it because we want to make sure that the health system is on a foundation that's actually sustainable, that's equitable, and that's relational in a way that people want. They vote with their feet, and what they're seeing at the time now is not acceptable, quite frankly. Next slide. Spending is anemic. In the next, just kind of moving over. People lack a relationship, and we are way down in the number of clinicians. So in the final slide, that gets us to basketball and what Q said. And Q mentioned the MVP here. So about a year ago, my younger daughter, who's a basketball player and a massive basketball fan, we were watching the NBA playoffs, and she asked me a question I didn't have the answer to. She said, "What's all this talk about this triple-double? These players, like this one got a triple-double, that one, who cares? Why is that important? What is even a triple-double?" So for the few basketball fans not here or online, triple-double is when a player in a game gets double-digit figures in 3 of the 5 main statistical categories in basketball. So points, rebounds, assists, blocks, steals. So again, we should ask what Talia asked. Why is that important? And the reason it's important is actually that it's not a marker of individual excellence, even though people assume that it is. It turns out, statistically speaking, that a team on which a player gets a triple-double has an over 75% chance of winning the game. You know, basal chance is 50-50. And so there's something about having 3 double-digit things that's really good. And that got us to thinking on a car ride home one day about if we were to think about the triple-double for primary care, what would it be? What would that impressive thing that if we doubled in a relatively short amount of time, what would it signify and what would it show excellent system performance? And in the last slide, it's really investment, access, and workforce. We double from 5 to 10% the investment, and we can do this. States have done this. Next little sub-slide. And it's not just the level, but the form and the flow. So you need to double the level, but you need to make sure it's in a form, risk-adjusted capitated payment primarily, that allows good primary care to happen by teams, and make sure that that money gets to the people caring for people on the front lines. You need to double access or the reach of primary care, but you start with the best part, arguably, and the part that might be most squeezed in the near future, which is community health centers taking care of rapidly rising number of underinsured or uninsured folks. And so you can't ask community health centers and other parts of the strained primary care system to do that as a charity case. You need to give them the resources to be able to take care of its 11% or a little more than that to 20% in the next few years. And then finally, you need to double the proportion of the next generation of trainees that are able and willing and excited and sustainably want to practice primary care. And that's by going from 20% of graduates to 40%. We do that, we can make magic happen, we can realize the promise, and we can do it in all these different ways that we've talked about: ACOs, DPC, small practices, big practices. But it starts with the money, the access, and the workforce. And I thank you for your time.
All right, so we've set the vision, as Dr. Bitton did, and with help, with an assist from his daughter, and the importance of thinking about the shared messaging. So now we're going to go to how we achieve the vision, and we think about different parts of the health system. And so I'm excited that we'll focus on patient-centered care. And as you think about the challenge of moving this momentum to a movement and how we should be leveraging other parts of the health system, I do think groups like the American Heart Association, the American Cancer Society, as you think about the role of primary care in preventing heart disease and detecting cancer early, is very important. So I'm glad to now introduce a great human being, Dr. Luis Padilla, who, that's exactly, I said, how do you want me to introduce you? Just as a great human being. But Dr. Padilla is a family doc and did some extraordinary work in his career, and I'm grateful that he's our chief health officer at NAC. And so prior to serving at NAC, he served as a decade as the associate administrator for the Bureau of Health Workforce, which was responsible for over 70 workforce programs and nearly 500 staff, including the growth, and he oversaw the growth of the National Health Service Corps, a very important initiative to bring, recruit, and retain clinicians in underserved communities, one of the programs that we both benefited from that program. So he also served here at Unity, at the same health center that I served, for a decade, more than a decade, as a medical director and senior health policy advisor. So I'm going to welcome Dr. Padilla to the stage, and he's going to introduce the panel. Thank you.
I appreciate the shout out as the fine human being. Can always use that. So I'm going to have the panelists come on up. Laura, Eduardo, please. They're going to give a little bit of background, but I just want to give you a snippet of their expertise and titles, if you will. Let's get those out of the way. Dr. Sanchez serves as the Chief Medical Officer for Prevention for the American Heart Association. He's the association's clinical lead on Target BP, a joint blood pressure control initiative with the American Medical Association, and the association's cardiovascular, kidney, metabolic, CKM, health initiative lead. Dr. Makarov is a family physician, both of them are family physicians, and a lifestyle medicine physician and senior vice president of prevention and survivorship at the American Cancer Society. And what I really appreciated about Dr. Makarov's intro here is her dedication and personal commitment to this cause after her husband's diagnosis and treatment and management of stage 4 pancreatic cancer. So definitely a personal experience and dedication in this area. Thank you. Let me sit here. And so I didn't elaborate on your fine bios. So why don't we start with you, Laura, and give us a little bit of background about yourself and your organization?
Sure. Well, first, I guess I would say I also am trying to be a great human. So thank you for your leadership and example. It's great to be here with you all today. I am a family physician, have had practice in a variety of clinical settings, including community health centers and Unity, back when Unity had a site at DC General all those years ago. So that's been an important part of my background as well. Now I have the privilege and honor of leading our cancer prevention, early detection, and survivorship work at the American Cancer Society, which means that I get to bring primary care into the cancer space, recognizing that there's the important part of cancer that oncologists, we need specialists, we need all the super specialists out there, and the ever-growing knowledge base and treatments of different kinds of cancers, but we need all the other parts. So I will share more about primary care and the reason why it matters in all parts of cancer, including the part that is called cancer treatment.
Eduardo.
Good afternoon, y'all. My name is Eduardo Sanchez, as you heard. I work for the American Heart Association, and I'm not a cardiologist. That is a puzzlement to many. But the truth is that 26 years ago, I served as president of the Austin area board of directors of the American Heart Association. I said it then. I think I'm willing to say it every single day, that primary care docs do more cardiology every day than cardiologists do. And if we could do even better and had the resources to do so, there would be less need for the high-cost cardiologists. And oh, by the way, we're the American Heart Association, American Stroke Association, so the same goes for what happens in primary care can prevent those life-destroying strokes that many of our patients have suffered in the past. I am a residency-trained family physician. I came up in San Antonio, Texas. I learned to be a doc in a federally qualified health center, not in Washington, D.C., but in Austin, Texas. And I cut my teeth there, and who I am, what I do, including reminding ourselves at the American Heart Association that primary care is the center of achieving our mission to be a relentless force for longer, healthier lives. We do not get longer, healthier lives, I think Dr. Baton just told us, without primary care at the center of that discussion. So I'll stop there and we can continue the
Thank you. And I neglected to sort of set the context here because I think it's important to recognize that as we have you two in your organizations, really at the forefront of managing and supporting our efforts of chronic disease management and screening and prevention, it really is where primary care sort of meets the road, right? And the issues that we're struggling with primary care are really the issues of a chronic disease and our ever escalating cost of managing those. And I think both your organizations are at the forefront of prevention, screening, detection, and really helping the primary care workforce in enhancing their capacity to manage chronic disease. So let me start with the first question, and no offense to your organizations, but typically, whether it's the ACS or the AHA, they're not known for primary care advocates. So if you could share with us why this is such an important area for you in terms of access, workforce capacity, and as Dr. Baton said, investment and overall investment in primary care. Laura?
Yeah, happy to share on that. So let me start talking about at the beginning, the basics, right? So 1 in 3 adults in the United States are at risk for cancer. In addition to that, more than 2 million people this year will be diagnosed with cancer, and we have more than 18 million cancer survivors living with and beyond cancer in the US right now. That number is expected to grow to up to 22 million in the next decade. So there's a lot of people impacted by cancer. And then you add in the caregivers and the family members, just like my own family, who maintain the impact of cancer like well beyond a cancer diagnosis. So we have lots to think about there. So primary care has been an important partner and investment for the American Cancer Society for actually quite some time. We do a lot of work across all parts of our organization, including in research. We have funded researchers in primary care and the importance of cancer care delivery through primary care, how that matters. You probably all have heard of the Flu Fit campaign. Dr. Michael Potter was funded by ACS to connect flu shots with an annual fit test for colorectal cancer screening a long time ago. It's been an effective intervention to help people have access to 2 important preventive services. In addition to that, our patient support organization is where I sit, and we do lots and lots of work to help increase access to prevention through lifestyle change, which we may talk about, cancer screening, which remains a really important part of the cancer care continuum and an important part of reducing costs and improving outcomes, as well as survivorship for both patients as well as healthcare professionals. A huge part of our work that we do to build capacity and support healthcare professionals out there is in primary care and with community health centers. So I can share more about that in a little bit. The last thing I'll say on this is that we also have a really strong advocacy arm called the American Cancer Society Cancer Action Network that works at all levels of policy to make a difference and help improve affordability of insurance and access to care through affordable health and care insurance, as well as reduce barriers like cost sharing for cancer screening and a variety of other things, including tobacco control and access to high quality cancer care.
Thank you. Go.
So I'll segue from what you said and sort of go in reverse. The American Heart Association is an organization that is the largest civic organization trying to assess and address and advocate for better cardiovascular and brain health. We have our trifecta, as opposed to the triple-double. And the trifecta is betting on first, second, third place in a horse race and getting the order right and winning the big money. And our 3 are access to care, which includes Medicaid expansion, access to the Affordable Care Act premiums, access to for more people to community health centers. The second is quality care. So I think that Laura and I are in organizations that want to make sure that the degree to which we can do even better with regards to what happens in primary care settings. We are organizations that do the research and develop the clinical guidelines around what to do. In the case of ACS, cancer screening and then managing the care of people who've been diagnosed and treated for cancer. In the case of the American Heart Association, it's managing those modifiable risk factors: hypertension, dyslipidemia, abnormal glucose, which is diabetes, and prediabetes. We are also an organization that, as Laura mentioned, is all about the opportunity to have lifestyle be part of the conversation. Specialists are seeing people way past the point where lifestyle could have helped prevent what happened, whereas primary care is right in the center of that conversation with family members, with all involved. The four behaviors that the American Heart Association focuses on as part of Life's Essential 8, that's why I have an 8 on my lapel, are not smoking, healthy eating, physical activity, and healthy sleep. And healthy sleep is a recent addition, but oh my gosh, sleep is so important for good physical health, emotional health, and even social health, right? And then the work we do in terms of recognizing that the 850,000 deaths due to cardiovascular disease and stroke, largely preventable, definitely delayable, depend on addressing those modifiable risk factors. The action for care of people with hypertension and dyslipidemia is in primary care. You can go look at the literature. 65 to 75% of care for hypertension and dyslipidemia happens in primary care. Lifestyle plus the modifiable risk factors, those lifestyle factors have a direct effect on incidence of many forms of cancer, is the key to realizing the benefit of figuring out how we can invest more in primary care and reap the benefits not only from a cost perspective to the healthcare system, but for people living longer, healthier lives, and grandmas getting to see their grandchildren graduate from high school and their grandchildren having babies, et cetera, and so on.
Yeah.
So.
Can I jump in here on the
definitely.
modifiable risk factor piece? So, I think it's often maybe not well understood, and for sure not understood broadly by the general public, that more than 40% of cancers, up to 45%, depending on what you read, are associated with a modifiable risk factor. And then you add in the number of cancers that can be prevented or found early through cancer screening, and then add in access to genetic counseling and testing for people who have a family history of cancer and should start some intervention earlier in their life based on an inherited genetic mutation. That gets us to probably close to 50% of cancers that can be prevented. So that's why primary care matters to the American Cancer Society, and that's why primary care matters to the American public. And we know that the essential functions of primary care, of first contact, continuous care, the continuity that is provided, our comprehensiveness, and well-coordinated care matters. Because convincing a patient to have colorectal cancer screening, has anyone ever done that in like 30 seconds? It doesn't work very well. But if you have 30 seconds over time to talk about the importance of preventive services and doing things that actually are not that comfortable, we need to work on that, right? And that are kind of, they have to take out time off work, and it's just there can be some fear, anxiety. But the continuous relationship that primary care builds with their patients is the key to all those things happening and helping with behavior change. So if we add in heart disease, cardiovascular disease overall, cancer, and let's just add in diabetes, like that chronic disease burden of how primary care can impact healthier lifestyles is, really key.
And Laura, can you speak a little bit more about survivorship? I know the ACS has put out information about 70% of patients now are living well beyond their diagnosis and treatment of cancer. What do you see as the opportunities for your organization to support primary care clinicians in that management longitudinally after a patient surviving cancer treatment?
Yeah, I would love to speak to that, actually. So so this year's Cancer Facts and Figures, which is our annual report on cancer trends in the United States, really was like a kind of a big milestone, which is that 70% of people diagnosed with cancer are surviving at least 5 years. So that's quite an accomplishment for the entire landscape, represents really significant improvements, both in the prevention of cancer, tobacco cessation is a piece of this, earlier detection through cancer screening, and evaluation of symptoms, which is also an important primary care function, and advances in treatment. And so 70% of people surviving 5 years or more with cancer means that people are living with cancer longer and living beyond cancer longer. And so the late and long-term effects of treatment, which includes all parts of a person's health, physical health, emotional health, social health, financial health, all parts, are things that primary care can make a difference in. However, like if you think about like a patient that I saw recently, so 35-year-old female, normal wellness exam, pretty, bread and butter to all of us, right? So she's in my office. We talk about all of her usual kind of well woman kinds of things, preventive care. She's 35. She's otherwise healthy. And then she says, oh, yeah, I have a history of childhood cancer, and I'm worried about my fertility. What do I do? So I actually work at the American Cancer Society, so I know what to do because I do this like every day in my day job. But the average primary care clinician needs help about what to do about those things and to understand like, oh my gosh, the treatment for childhood cancer, 20 years ago or more, 25 years ago in this patient's case, like, I don't know, like I need some help to answer that question and where to send a patient for further evaluation, for specialty care if needed, and then to be able to like be that continued source of trusted information well beyond a cancer treatment diagnosis.
Louise, can I just add, the notion of survival and or living with survival. How many of y'all have taken care of a child with congenital heart disease and or taken care of a child with congenital heart disease who became an adult? And the care for those individuals is distinct from the care of people who don't have that as a history. And so I raise that because the value of American Heart Association, American Cancer Society is that we are organizations that life course and even degree of severity of condition, present or not, and the degree to which it exists, provides primary care providers and primary care settings the resources that might help them take care of those patients, because those are patients who need a flu shot just like anyone else, but in one case might need a different screening schedule than someone not. One other thing is that many people who survive cancer were treated with medications that are sometimes cardiotoxic. And so I saw the language of whole person health, and primary care knows how to do whole person health. Primary care knows that that patient who has cancer also is a patient who is suffering a little bit of cardiotoxicity and needs to see a cardiologist. And the best place to do that interdisciplinary coordination is from the place of primary care. Our organizations help provide the support for that, but also recognize that we're not going to do as well trying to get the cardiologist to talk to the oncologist to talk to the nephrologist. We're going to do better by having the care coordinated by primary care that takes care of those other things, flu shots, et cetera, and so on.
Yeah. And I want to put a pin on that regarding the 2025 hypertension guidelines. But before we do that, Laura, can you sort of expand on what I'm hearing Eduardo talk about in terms of socioeconomic factors that driving health and how the ACS sees that in the interplay between primary care and addressing those factors?
Yeah, that's great. So, at the ACS, we believe that everyone should have a fair and just opportunity to prevent, find, detect, and treat cancer.
So does the Heart Association, by the way.
Thank you. I figured.
I thought I'd start with her first.
I know I'd throw it in.
And I think NAC and the AAFP and a lot of others, which we are so glad to be on the team, right? We're winning this as a team sport. So with that, recognizing that it's really true, people talk about this, and all of you in the room and listening in the community health center background certainly know this, that where a patient lives, their zip code is a bigger driver of health than like genetic code, and that is true for cancer also. We know that social drivers of health and health-related social needs are both major barriers and major contributors to worse outcomes and higher costs. And so recognizing that and doing what we can to reduce barriers like cost sharing for screening tests and screening as a process, not just one screening test, right? The screening test that also needs follow-up if there's an abnormal finding, and addressing those things through reducing cost and recognizing that things like food insecurity matter to all parts of health across the lifespan. And so working like the Heart Association is on food as medicine interventions, both before cancer and during cancer. We know that the biggest barriers when we think about health-related social needs for people in cancer treatment actually are lodging, transportation, probably transportation, then lodging, and then food. Meaning like those are the biggest issues that patients are facing. And so we have programs to try to address some of those things. Our transportation program, Road to Recovery, our Hope Lodges where patients can stay if they need to receive specialized care far from home, and then doing a lot more in the food as medicine space to advance both the science and implementation of effective food as medicine interventions in cancer care.
Eduardo, do you have anything to say about socioeconomic factors in the AHA?
I could. No, I'm joking. Of course. And I will say, we just recently released a guideline on cardiovascular kidney metabolic syndrome, the management of, and in the top 10 takeaways is an explicit statement of assessing and addressing social determinants of health. And I don't think there's anything more to say. The three, transportation, lodging, and food, are the three things that get in the way. I think the only thing I would say is I hate the word non-compliant. Non-compliance to me, I describe inanimate objects that way, maybe pieces of metal that I wish would bend and they don't. But it's a word that's loaded with judgment. And I think that when we look carefully at what it is that might be driving the inability of our patients to take their medications or to make it to an appointment, it's life getting in their way. And we need more forgiving language, I think, to talk about our patients.
Yeah. Thank you. So we can transition a little bit about how you see your organization is well positioned to support as we kick off this action section of the Triple Double Initiative. Want to talk a little bit about how you see your organizations building upon your current work and initiating action among your members and the patients and populations that you serve.
Sure. From 2021 to 2023, I had the great privilege of serving as a principal investigator of something called the National Hypertension Control Initiative. And that work was, we were charged through a cooperative agreement to try to improve blood pressure control in the lowest quartile of the community health centers. That was roughly 350 community health centers over that period of time. If you have forgotten, 2021, 2022, 2023 overlapped with something called the COVID-19 pandemic. And so the Heart Association dug in, we leaned in, we figured out some different ways of doing some things. We built on a program that you mentioned, Target BP, and we saw some fairly dramatic improvements in blood pressure control in those 350 settings compared to the 1,150 others that didn't get the training and technical assistance we provided. So we think we're well positioned for a number of reasons. So I'll just cut to the chase. One, we produce the guidelines that are evidence-based. We have shifted our guidelines and are expanding those guidelines from being not just the what, but being the how. So they are not just, here's the clinical stuff you ought to do, but here's some of the implementation strategies that you might put to work. With Target BP, we've partnered with the National Association of Community Health Centers, a collaborative agreement between ourselves and NAC, in trying to do a few things. One is leverage that systemness of the community health centers to, in a systematic, standardized, protocolized way, take some of the learnings from the National Hypertension Control Initiative and apply them to even more community health centers. And over the last year, from 2025 to 2026, we've seen about an 11% increase in the number of community health centers that are participating in Target BP. If you measure what you treasure and you treasure what you measure, we feel like blood pressure control is a proxy for the degree to which other things are being well and become an entry point for having conversations about those other things. I wouldn't say that it's easy to do blood pressure control, but it's a little bit more simple than some of the other things. You don't have to have a stool sample for blood pressure control. You don't have to be in any kind of untoward situation to be able to measure someone's blood pressure. And the things to do include lifestyle change with measurable reductions in blood pressure, include people being on medications, and include taking care of social determinants of health. So we feel like we can build on what we've learned, learn and add to the evidence base as we partner with others, and continue striving to do even better in the process.
Laura?
Yeah, that's great. Similarly, so thank you for all of that work. The blood pressure program that you all lead is really, really great. So similarly, as we think about, let's just use cancer screening and early detection and prevention through screening as the example here. So we certainly publish cancer screening guidelines, and there was a recent update on our colorectal cancer screening guidelines this summer. That's led by Dr. Bob Smith at at the ACS. So those are evidence-based guidelines. Now as we look for other guidelines, the screening guidelines are complicated. It's complicated, I think, for all of us clinicians, but extra complicated for our patients. So we'll continue to work in primary care. We have had a long history of working with lots of different primary care partners, doing implementation science through our Accelerating Research to Care network. This year's program, we have 85 primary care practices participating with us. About 60% of those are community health centers. When we do, this is what I see is that as we equip clinicians and help primary care do what they do best, just a little support goes a long way. And so practices that participate with us in this year-long screening program see measurable increases in their cancer screening rates, which of course are important for other reasons too, like the UDS and other things. And so there's more work to do. Screening rates remain suboptimal, and we know that patients cared for by community health centers, we see lower screening rates, but we also see more transparency in the community health center data. So I'm not sure all what to make of that, but we do have room to grow and more to do, and we are welcome new partners. We are continuing to work on educational resources to equip clinicians and clinical care teams to provide the right care at the right time for all patients. I'll say one other thing directed towards patients. So maybe the equation is equipping clinicians and clinical care teams along with empowering patients. So as we think about what happens with patients when they're not in our clinics, there's a lot of other opportunities to educate and empower patients with trusted information. So we have a new online tool, it's a web-based app called Cancer Risk 360, which is really designed to be a comprehensive risk assessment tool to look at all risk factors for cancer. So it provides a personalized action plan at the end. It is not AI, actually, but it is based on a personalized decision matrix that any user can use it, adults, and you take about a 5 to 7 minute quiz. At the end, it develops an action plan. We've purposefully designed that to be useful in a primary care setting so that patients can come in with some information and some discussion points to talk about how to reduce the risk of cancer and cardiovascular disease, and where are they with their cancer screening, and are they a candidate for genetic testing, and how is their lifestyle doing, and to begin a conversation and kind of work on all of those action recommendations over time with patients.
Thank you. So as we wrap up this session, I want to give you all about 30 seconds or a minute of final words before I wrap up. Eduardo?
We at the American Heart Association see partnership with primary care as the only path to get to a cardiovascularly more healthy United States of America. Y'all are, and as it relates to primary care writ large, absolutely an important partner. As we all grapple with how we talk about the language of diversity, inclusion, and inequity, our commitment to work with the National Association of Community Health Centers is a way for us to not have to talk about it, we just do the work, and the work that's being done speaks for itself. So I do want to express gratitude for the invitation for us to be here and the opportunity for us to continue working with y'all, working with the American Cancer Society and our other civic organization partners to bolster what happens in primary care. We do well, we can do even better.
I'll echo that. Thank you for the invitation to be here. We really appreciate it, and it means a lot. I'll just say that similarly, the same for the American Cancer Society and our mission to end cancer as we know it for everyone, is that primary care is a key, maybe the key to our partners and how we can work together to make a big difference. I'll also say, I think our goal is this, and it's pretty simple. I think there really is actually a secret to all this that maybe was first coined, I think it was like 100 years ago, the quote by Dr. P. Berry about the secret to caring for the patient lies in caring for the patient. And that is exactly what primary care is designed to do.
Yeah, thank you. And I just want to thank you both for being here in our partnership. I know we've had partnerships with the ACS and obviously our ongoing partnership with the AHA. And I just want to say that I was excited about this panel because typically we're not thinking about these organizations as being a part of this really significant initiative in terms of primary care. I think this discussion has hopefully demonstrated how this is going to have to be a broader initiative, not just among the primary care community, but partners like AHA, ACS, that assist us in reaching these three goals of access, workforce capacity, and greater investment in primary care, because the results are evident. I think each of you expressed that. The more we do that, we're all benefiting, and more importantly, our community members are benefiting, living longer, healthier lives. So I just want to thank you for your participation and leadership today. Thank you.
Thank you.
All right, that was a great panel. And, you know, as was reflected, the importance of thinking about how you achieve the vision with patient-centered care and these advocacy groups that often represent topics and conditions that are very keenly connected to specialists like cardiologists or oncologists. As we reflect on the role of primary care in preventing those diseases or the progression of those diseases, I think it's incredibly important that we think strategically at a national level as well as a state level, which is going to introduce the next panel as we think about moving from this momentum to a movement. And movements require things at a federal level, at a national level, but also at a state level. So I'm excited to introduce another great human being, Dr. Marcy Nielsen, who will moderate this panel about activating the vision in the states. Now, Marcy is just an extraordinary person. She's a primary care and health policy leader whose career has spanned so many different realms. She started her career as a health staffer for U.S. Senator Bob Kerrey in Nebraska. She also went to lead Kansas' $2.3 billion healthcare agency under then Governor Kathleen Sebelius. She's also led this the Patient-Centered Primary Care Collaborative, really important group that Ann Greiner leads, and I'm grateful that Ann is here and as well. And that initiative is so important. I'm just going to also highlight she's a former Peace Corps volunteer and just an amazing human being. So I'm excited to introduce her as we talk about how we can translate this at the state level. Dr. Nielsen, Dr. Marcy Nielsen.
And I invite all my panelists to come on up. Good afternoon. Did everybody go and get their second cup of coffee, maybe third or fourth? We are thrilled to have a full room with lots of friendly faces and new partners in this work. As Q pointed out, my name is Marcy Nielsen. I serve as the strategic consultant for the Triple Double, although I refer to myself as the strategery den mother of the Triple Double. I am very honored to be able to moderate this panel on activating the triple-double vision in states. And I wanted to quickly ask, how many of you in this room have worked in state policy at some point in your career? So maybe about a third of the room. Very important for us to realize that as we take this vision that Asaf has described and that Sean and Q have operationalized, where the rubber really meets the road is in states and the work that they do. In my case, where the rubber met the yellow brick road, given my time in Kansas. Which I think is just so very important for us to take off our federal hats for a minute and put our what really matters to patients and families is what happens in their communities and often their states. And with that, I would like to invite each of you to give a quick introduction, where you work, and then just a snippet about what your organizations are doing to advance primary care, and perhaps in particular, goals that are affiliated with the triple-double. So Carrie?
Hi, I'm Carrie Weber. I'm the Executive Vice President for the Oklahoma Academy of Family Physicians. I'm also the Executive Director for the Oklahoma chapter of the American Academy of Pediatrics. So between those two organizations, we represent about 44% of the physicians in the state of Oklahoma. And so obviously we have a huge focus on primary care and advancing that in our state. One of the things that we'll talk about today that we're extremely proud about is our increased primary care investment in the Medicaid space. About 4 years ago, when we started that bill, Oklahoma was spending about 3.9% of their overall spend in primary care in our Medicaid dollars. And we have now in legislation that they have to reach 11% of their overall spend by the end of the 4th year. So we're coming up on the 3rd year and seeing some strides in that. So we're really excited about that. And we're also really excited about some of the work that we're doing in our workforce and our preceptor tax credits that we've done in our state as well. So I'm excited to be here and kind of talk a little bit more about what we're doing in Oklahoma.
Fantastic. Katie?
Yeah, thanks. Hi, everyone. I'm Katie Green. I'm the Director of Population Public Health of the National Academy for State Health Policy. If people aren't familiar with NASHP, we're a nonpartisan, nonprofit state health policy organization, and we work with executive leaders, state health policy leaders from across the executive and legislative branches. And I will say I've been talking a lot about primary care over the last year in particular. And one of the things that we've done that's been particularly exciting is we partnered about a year ago with the Millbank Memorial Fund to develop a primary care policy menu. And what that was born out of was, of course, a continued need and interest to strengthen primary care systems. But when that opportunity arises, because a legislator's been hearing about it, or because you're confronting a crisis, or you have a commission, or a rural health transformation plan, here's really a set of strategies that states from across different geopolitical contexts might have different health systems, different needs. Here's a place for you to start to think about those different parts across payment, across workforce, capacity building, all these different things that go into strengthening healthcare systems. So we've continued to work with states on implementing those. Through NASHP's continued work, we run a rural primary care access learning network. And what that does is that brings people across state health policy systems. So whether that's Medicaid, primary care, offices, public health, really brings people together to talk about some of those challenges and solutions so that we can all learn from each other. And we've also been working to support state rural health transformation leaders and those officials that are administering those funds. And of course, I'm sure we'll talk about it more, but primary care has been a huge focus for that work.
Thank you, Katie. Julie Shills?
Hi, everyone. I'm Julie Shills. I'm with Primary Care Development Corporation. We are a 30-year-old nonprofit, started in New York City, spread to New York State, and now we are national. There are 3 areas of focus for our organization. And as the name suggests, Primary Care Development Corporation, we're pretty all in with primary care. So we have a capital investment team that provides support to community health centers. We have a consulting and training team that provides support to primary care practices, public health entities, behavioral health organizations, really that capacity building within the work that they do every day. And for today's discussion, we have a policy arm. We're very proud of that. One of the areas that we're focused on now is Primary Care Investment Network. This is a network of members from 30 states and 70 organizations from across the country. We're entering into our year 4, we have great partnership and support from the Commonwealth Fund, Milbank, and also the California Healthcare Foundation. We do convening. We bring the individuals in states. It can be a state representative. It can be a primary care association. It can be the state chapter for AFP. Or primary care physicians that are coming together to support primary care investment in their state. We have open dialogue, convenings, provide technical assistance to the states, and really find that it is an open dialogue for everyone to learn from each other and to move forward. We had the opportunity to support NASHB and Milbank in the policy menu and provide, the states provided some insights into their work to help support that effort. So I think as we're doing the work, we find collaborative partners like NASHB are incredibly important.
Excellent. Shelley?
Great. Good afternoon, everyone, and thank you so much for having us today. I'm Shelley Reiser. I'm the president and CEO of the Pennsylvania Association of Community Health Centers, as well as our 2 subsidiary organizations, the Pennsylvania Health Center Technology Alliance and the Pennsylvania Community Care Collaborative. As a PCA, it's so important that we're here today, and I have the opportunity to sit with you, and thank you for the invitation for having PCAs here. In Pennsylvania, PAC has 53 health centers, and the membership is inclusive of CHCs as well as lookalikes. They serve 1.2 million patients across the Commonwealth. 1 in 12 patients gets their care from a community health center. And as we think about what we want to do with our reach and increase in that, we are in 475 locations across 57 of the 67 counties in Pennsylvania. And the opportunity that we have today as we talk about those partnerships, I'm going to share with you a little bit about our partnership that's been a longstanding partnership with our Pennsylvania Department of Health, as well as our Pennsylvania Academy of Family Physicians, and some great work and outcomes that we've done there. Today, I've also brought with us our Director of Workforce Innovation, if anybody wants to talk to her afterwards, as well as our Director of Policy and Partnerships, so that you can actually see what we're doing at the state level to help advance these opportunities for our patients.
Fantastic. One thing you may not be aware of is that the goal of the triple-double in the states is to select a number of states where we can sort of pilot intensive work that's focused on collaborations that allow us to focus on one or more of the goals, essentially giving support, financial, technical assistance to help states prioritize what they'd like to work on as part of the triple-double. We gathered probably 20 primary care association members, the CEOs, as well as the AAFP state chapter, and Carrie was able to be at the first meeting that we convened back in November. For lots of folks, this was the first time the AAFP state chapter would have actually been in a room to collaborate specifically with the PCA around primary care. We see this as a real opportunity that the triple-double has to pull together these 2 organizations who have very similar policy priorities. I would love to hear, Carrie, first, how you have successfully been able to navigate in Oklahoma, a state that is rather conservative. You've been able to move into legislation specific targeted goals for primary care investment in your Medicaid MCOs. But I'd also love to hear a little bit about when you came to our meeting in November, how you see ways in which the triple-double might continue to serve as a catalyst to help move further action and activity and support you at the state level.
Yeah, I think that's a really great question. I'll address the first part and then I'll go to the November meeting. I think one of the things that is really important to emphasize maybe to legislators when we're talking about this primary care investment is to not think of it as spending more, but to be spending more strategically. And so it wasn't like we were asking them to increase the overall pie. We were just asking for our piece of that pie to be increased. And I think when we were able to have that kind of conversation, it read across the board a lot more reasonable to the legislators. I also will say one of the things that we have been doing consistently in Oklahoma is every year in every interim study, you will hear at least one or two interim studies about primary care. We are trying to be in front of the Senate. We are trying to be in front of the House, stating our case, always talking about the importance of primary care and why that investment matters. And I think because we started to build those relationships, we happened to be in the right place at the right time for the right opportunity in Oklahoma. It was not some magic opportunity that we had worked on for years and years and years. We were given the opportunity to make this increase in this investment when our state moved from our state managed care program to national managed care companies. And when they did that, we had built some really great relationships with some key legislators. And because of that, and because of their buy-in to the investment in primary care, they came to us and said, if we're going to do this, we know this is going to be a big lift for providers. What is something we can do for your family medicine providers that would make a big impact? I happened to be at a national conference, and we had about 24 hours to come to them with a plan. And so we did. We asked for 15% of that overall Medicaid budget to be spent on primary care. We got 11, so we didn't get the full 15, but we did get 11. And I think one of the things that was really important in knowing that is like, it is a big ask, right? Oklahoma, I think some people will say it was about 4%. Every time they ran the numbers, it would be like 3.2%, 3.9%, depending on what they included in it. And so we had to have a really good strategy and a really good communication going into that to talk to those legislators, because jumping from 3.2% to 11% can sound really scary or like a lift that's too big. And we were able to convince them that if we did this in a phased-in plan over 4 years, that those managed care companies would have the opportunity to do that. And so I think one was relationships, two was right place, right time, and the willingness to make that opportunity happen, and the champions that we had because of that. And then the other portion is the November meeting. And you're right, I had not worked very closely with Sarah Berry in Oklahoma prior to that meeting. And now we are working significantly closely. We're going to a lot of joint meetings together to promote this. And we're working at doing this exact same primary care investment in the private insurance space. So that meeting in November just allowed us to take the work that we were already doing and expand on it and really build a great relationship that's allowing us to further our network and I think share a similar message and a similar goal. I think we were all doing really great work, but maybe a little more siloed than we should have been in a state, especially in the size of Oklahoma. So,
thank you so much for that. And Shelley, Pennsylvania has long been doing fantastic work in primary care. You may not have a target yet for your primary care investment, so there are lots of different ways that states make progress toward these goals. All of them fit within the rubric of the triple-double. Can you say a little bit more about some of the terrific work that's even been happening this legislative session?
Absolutely, and it's a pleasure to. And I mentioned that we'd had a long-standing partnership with our Pennsylvania Department of Health. We have had a career center through the Primary Care Association that's been supported and funded through the PA Department of Health for 13 years. And the fantastic opportunity about this is that we not only are able to support recruitment and retention efforts that directly benefit our health centers, but we actually keep track of how many vacancies every health center has within their provider community. So we know at any given point in time where our need is and how to target those needs. we actually can track not only those numbers across CHCs, but we conduct events that promote those practices and are accretive to adding members of the provider community to them. We actually have found that whenever we hold these events, by bringing one of our CHC providers to those events and talking about what it's like to work at one of these health centers, we've gotten significantly more interest at each of these events, and we've received placements from those as well. And we also conduct events that not only promote opportunities for the providers, but also we target residents so that when they're residencies, so we can start showing them where these great opportunities exist for our CHC community. We also have had 3 to 4 provider placements as a direct result of our regional recruiting events lately. I do want to mention, too, we talk about our partnership with the Pennsylvania Academy of Family Physicians. I'll move into the budget piece in a minute, Marcy, but I think it's important to know that in the last year we had a subrecipient award dollars from our PAFP partners. We were able to actually invest in something called Doc Cafe, which is a direct recruitment tool for seasoned providers. Within 5 months, we had 2 placements in our communities for providers, which is really significant when you think about how we're trying to recruit into these areas and supporting our rural as well as our urban communities. And we also, we've had the opportunity, while we just wrapped up our Pennsylvania budget, we did not get our $5 million ask, although we will go back at it again next year because this is a continuous education process. It's not a once and done. What was funded in full, again, was our primary care practitioner program line item. And from that state budget, that helps support PAFP. That helps support our career center in full. And we also worked very hard with our state legislators to remove the income tax on loan repayments because they were paying income tax on those loan repayments. So again, it's a multi-pronged approach that we take and we look at as what is important and matters to our providers, to our CHCs, so that we can make sure that our health centers are the economic engine for those communities and we're able to recruit the best providers possible.
Fantastic. And hearing about some of this creative work that is happening in Pennsylvania around workforce, it really is the little things that matter, and they all add up. Katie, NASHB has such an interesting perspective on what states are doing, and I have to out myself as a huge fangirl of NASHB, a former board member, and NASHB was such an important organization to me as somebody new running a healthcare agency in Kansas. You regularly collaborate with state leaders and you publish documents like the NASHB policy menu. In that work, you're able to both see states that are struggling, states that are succeeding. When it comes to making progress in primary care reform, what are the trends you see in terms of when states try these things? It seems like they're more successful, and when states are facing these barriers, it seems like they're really slowed down.
Yeah, that's a great question. And I'll say,
And it wasn't on the document. Yeah, sorry about that, Katie.
That is okay. There's so much to talk about, and one of the reasons why this panel is so fun because there's so much synergy between the policy menu and the triple-double and the things that you see unfolding in the states. So I'm going to give the quick Cliff Notes version of anybody that has not committed the policy menu to memory. Really what we prioritize with that. So it is 1, make and keep primary care a top priority. 2, pay primary care more and differently. 3, make it easier for people to access their primary care provider. 4, expand and support the primary care workforce. And 5, build provider capacity to provide patient-centered whole person care. And one of the things that you've touched on is states are in different places. And primary care, one of the reasons we've been able to have so much momentum is it's not a partisan topic. You see great things happening in conservative states and liberal states. And one of the things that I think is great, and we've had a real privilege to do at NASHB, is to learn from all these experiences. There's a lot of there's a lot of experimentation going on. So when we were putting the policy menu together, we talked to, I think, some 25 odd states, and then had conversations through the network and many more. And we had the opportunity to say, what's going on? What are you prioritizing? What's worked? What hasn't? And so, one of the things that I think you had challenged me to think about was what might be surprising, and what are commonalities across some of those different states. And some of this might be obvious. I don't know if it's surprising. Might be so obvious it's surprising. But some of the things that I've really observed that are important are, number one, just having a champion. There is so much going on at champions, plural, I'll say. There is so much going on at the state level. States are very overwhelmed with HR1 implementation. Depending on the state, you might be facing a real budget shortfall. When it comes to investment in primary care, it's really great news that the data is on our side in terms of the need for investment. But you also need that story, that commitment. Just keeping it in front of people and being a pest. On that front, sorry to pull in the basketball metaphors, like a good offense is so important. One of the things I was talking about with folks at my table was just, I've worked in policy for a long time, and sometimes I just forget the need for education. We're in a situation in 2026 where there are 39 gubernatorial elections. There are state legislative elections in most states. The average shelf life for a Medicaid director or a state health official might be 2 years at this point in time. So the need for re-education is constant. And then the last thing I thought I wanted to highlight as very important is coordination. And I say that not only to emphasize it, but there are also different ways that we need to think about it. One is just across agencies. So, if you take a look at that menu, some of those things need to be implemented within Medicaid. Some might sit within workforce agencies or primary care offices. And things are so much easier if people are working in the same direction and collaborating with each other. That's number one. Number two, one thing that we really emphasize within the policy menu is those primary care commissions. Again, leadership can turn over, but having those group of people coordinated, moving in the same direction. When you are a state policy person, you think a lot about Medicaid because that is the lever you have. But there are some real risks and downstream effects of only thinking about Medicaid and not thinking about commercial. So to the extent to which you can not have a bunch of different quality metrics, or really have some continuity across payers can really help move things along, having goals, having people working towards them. And the last we talked about a little bit, which was just states really need to learn from each other. There are people that have been at this a long time, and they have great lessons learned. We talked to some states with some, policy innovations that we really like to highlight, and they said, honestly, like, this didn't work great. If, we had to do it again, we had to go back, talk to people, iron this out. Or if we were talking to somebody that wanted to do this is what we'd tell them. So that's really a role that we at NASHB try to play, and I know other folks in this space are playing a really important role as well.
Thank you. I really appreciated your creative thinking there. Julie, you are in the trenches with states as part of your work with the Primary Care Investment Network that I know you get funding and support from the Commonwealth Fund and from the Milbank Memorial Fund. But you also have such an interesting career, having worked in the primary care space with a private sector hat. With collaboration is kind of your middle name. Tell us a little bit from your perspective what you see states struggling with or what they're excited by when it comes to primary care investment. But don't limit yourself if you have some observations from your time in the private sector. I really appreciated Katie raising this issue of this can't just be government. This has to be the private sector, commercial sector too. That also was not on this list.
I love Marcy. No, I think that's why the triple double is so important and so important for now, because it creates an overall messaging that we can all hold on to. And we've all said collaboration. All of us have said collaboration, and that is the key. And within the states right now, I think as discussions started back in November, maybe even earlier around triple double, it was that moment where we thought we should really bring PCAs and state AFP chapters together. Why didn't we think of it before? So bringing the collaboration among really important stakeholders in the state has been really critical in the work. And the states, some states have been doing this for a really long time. You have Rhode Island and Oregon, Colorado, who have had a state legislated percent of primary care spend. But now they're working on dashboards, or they're working in other areas. So I really appreciate what you said, Marcy, that states can start at any point in the continuum. And that is where the policy menu comes into play, to have a roadmap, to have a framework, to have something to help guide you. So having these active and open conversations. We said HR1, that is a big challenge. We're currently working with 3 states right now providing technical assistance: Minnesota, Nebraska, and Texas, all doing a little bit of something different, but what is consistent among all of them is the collaboration. In Minnesota, it is Jamie with the state AFP chapter, along with David from the Department of Health. They are bringing together, it's not legislatively mandated, they're bringing together stakeholders who care about primary care, and it does include a variety of different payers. So bringing everyone at the table to have a conversation. They're looking towards they have good data in their state, and using that to create a dashboard so they can understand what is going on in our state, how are we supporting primary care. In Nebraska, there is a legislated primary care commission and workforce, but the slots aren't filled. So a group of individuals, employers, the AFP chapter, local primary care physicians who have worked in ACOs, and they're giving Amy with the PCA a little bit of a break because Nebraska was the first state to implement work requirements. So they're giving her a little bit of a break, but she's part of the action and really coming together to fill those spots. And then you look at Texas. They have always worked with the Academy of Family Physicians and the PCA working together and thinking they have a new APCD that has been funded, and thinking about how do we use that data to really support.
All payer claims database for those of you watching at home.
Thank you, acronym monitor. So, I would just say, and you asked a question of what are some of the barriers. Asaf said it earlier. When there is investment targets or in value-based payment models, the payments actually getting down to the point of care and primary care, or when primary care does achieve savings, getting those savings to go back into the primary care system and keep that virtuous cycle going. We still need more employers. It was great to have an employer voice today, but we need employers at the table with us as well. The other thing, there are a couple of things. I'll just say data and access to data and having it be transparent. The fact that organizations like the Graham Center need to purchase data to be able to do the great research work, this data should be available. And it shouldn't cost a lot, and we should have it at the fingertips of the really wonderful primary care researchers that we have in this country to be able to tell us how are we moving? How are we looking forward in terms of tapping into triple-double? Our work in the investment network is about investment, but if you think of the other two categories, there's a lot of things that go into investment. So it also does include the workforce. It does include having access.
Thank you for that terrific answer. I think about the panel that preceded us, and Dr. Padilla had pointed out, you know, this can't just be a coalition of folks who are all primary care providers. We need to be thinking creatively and broadly about who can join our efforts. And of course, the American Cancer Society and the American Heart Association. When I think, Carrie, about the success that you have had in Oklahoma and the fact that you were at our first November meeting, which was really sort of a, is there an appetite for this kind of meeting? When you think about those new partnerships, what would you like to see happen next from a triple-double perspective? We're coming to a state near you, and who would you want to bring to the table, and what could the triple-double help you with? Also not on the list of questions.
No, I think that's a really great question, and I think you hit it spot on. I think we have to invite so many more people to the table than just those that are traditionally interested in primary care. I always tell people I think they would find it interesting that I work very closely with the Oklahoma Insurance Association. But we have to, right? Like, we have to be integrated so closely with those health plans and those payers, and so that they understand what the primary care investment is and why it's important. I jokingly always say to them, help me help you, right? Like, let me help you with your chronic disease management so that costs are lower. But then I also think it's providers, but it's the legislators, and it is also community organizations. I think anyone that you can have at that table to help build the momentum is incredible. I think this has been great, and the triple-double and the campaign itself is creating some sort of energy and momentum around primary care in a really exciting way. And we're talking about primary care a lot differently. And I think that in itself is going to help states as we continue this work that we are doing. I think we have to also be realistic that this work takes time. It's not going to happen overnight. So you have to have the people in the room and people supporting you that also understand that, right? That understand that the initial investment and the change in financing is going to take some time to produce the results that you want. But even the slight little changes, and if you can get those people like the healthcare authority or your state health department to also help echo that message for you, I think that's better. And so I think what's been really great just since the November meeting is sometimes you feel like you're working on something without a lot of counterparts working on that with you. And this is 3 different things that we're all working on, right? We're working on investment, we're working on workforce, we're working on access, but this puts it in all one message and allows us to kind of build off of that and build that momentum and build those collaborations with people. And so I think leading off of November, where we've been able to take that in Oklahoma is really saying, like, what does that look like for us now? We've got this really great investment in Medicaid, but we can't stop there, right? And so being able to continue and build that collaboration with other organizations has made them realize, like, okay, we can do this, and we can do it in creative, different ways. And we've used the policy menu so many times. I take it to legislative meetings all the time, but I've also introduced it to other organizations who are thinking about this as well. And so I think what the triple-double allows and can continue to do for us is bring more resources and ideas of states on how they can do it. And you're right, we don't do it the same. Pennsylvania and Oklahoma are very different, but we're learning off of them. Like, we started backwards. We started with Medicaid. Now we're going to be going to private insurance and looking at the commission and trying to build it out, because we know that it's important for the accountability piece and for the measurement piece. And so I think the triple double just keeps us on track and allows us to keep building that momentum, as long as it provides resources for us to use at the state level that we can make our own, but still has that overall energetic message that I think is building a momentum along the way. So.
Well, I love that you talked about resources. One of the things that we will absolutely need to do to make this campaign really lift all boats, as they say, is we're going to need to raise dollars so that we have resources to share with states. A goal of ours is to be giving states grants, and those grants would be meant to incentivize the partnership between the state chapter and the PCA, but also to collaborate broadly in your state and your community on a priority that you have. So Shelley, I'm going to come to you next and say, if we came to you with a grant of 30, 40, 50K, recognizing that's not a lot of money, but it can maybe act as a catalyst for work that you'd want to do, what would you try in Pennsylvania?
No, thank you for that question. And any funding is helpful. I'll start there. And I think we have to start with, how do we maximize that and how do we amplify that? And I will say, kind of building on what my colleagues have talked about, one of the areas that I think, as we look at how does funding support that, how does the partnership and collaboration support that, we are seeing that it is difficult to get clinical rotations. It's difficult because it changes the productivity and it changes the revenue, which ultimately impacts the bottom line of our health centers. While $30,000, $40,000, $50,000 doesn't necessarily change that bottom line, it starts the conversation for the awareness and the amplification of how do we start chipping away at the problem. And it's bringing those partners to the table to be able to understand, how do we tell our story? Because the more people that understand our story and the message and can amplify that and promote that, that helps all of us across the board. And the fact that, the PCAs, the AFP chapters, our other partners with NAC, that we're all at the table messaging this in a very similar vein, I think helps get us to that 5 times the amount that you've just talked about. We've got to start somewhere, though, and I think that's a great place to start.
Thank you for that. We are coming to a close of our panel, but I would like to ask both Julie and Katie the same question, which is very similar to the one I posed to Shelley and Carrie. What would you like to see the triple-double do? Not from any other perspective, but you see a need in the work you're already doing now, and you've heard now what the triple-double goals are. Where would you say, Marcy, this isn't on your list? Here's something that might be useful to think about. Don't be shy, Julie.
I'm thinking about something different, so I may not answer your question. So that gives you an out too. But
she spent some time in Washington, D.C., folks.
Yeah.
Answer whatever question you want.
I just want to go back to the collaboration between NAC and AAFP and how powerful that is, and the fact that these two organizations who work with other organizations that happen to be near and dear to my heart, and with the help of Asaf, Chris Kohler, many others, created a really simple and effective messaging campaign that still allows, we all know healthcare is local. We all know that. It still allows everyone in the states who know their state best to understand where to start, what to focus on, how to bring their efforts together, and that is really important to allow that flexibility. in the work. The other thing I'm going to say, I know we talked a little bit today about where do we want to be in 5 years. I happen to be a quality improvement sort of geek. We talk from the perspective of what can we do by next Tuesday. So I'm just going to lead that challenge of how can we take being in a room together today and what can we do a week from now and how can we take this messaging forward. I've been doing this a long time, people, and Asaf said it. We want to start seeing action, and now we have a platform to have action. So I guess in a positive way, I couldn't think of anything different that Triple Double should be doing. So good work.
I love that answer, Julie. Katie?
Oh, okay. Well, I was thinking back to the discussion earlier today with the 5 basketball. I'm really stuck on the basketball metaphor. I'm sorry, but
That will make Q very happy.
So if you get your triple double in rebounding and shooting and assists, your blocks, you still have to make assists and you still have to steal. So I think these are really core fundamental principles that we all need to be working towards. But we need to be thinking about primary care holistically. And, going back to our menu, I think it's not only paying for primary care more, but paying better and figuring out how to use that funding effectively, making sure it gets to primary care providers, which is a challenge. How do we really incentivize value-based care that improves outcomes in whole person care? So I don't think there's anything wrong. These are great goals, but the more you work on them, the more you figure out that you need to do around it, and bring in some of those other providers. So much of what we're talking about right now is how to meaningfully integrate behavioral health and social services, within rural health transformation, the sort of infrastructure of rural health clinics and community-based organizations. I think there's just a lot of work that needs to go into making it happen that complements the work of the Triple Double.
That is such a fantastic answer, and Asaf would be the first person to tell you we picked 3 goals that were clearly uniform across stakeholders because we need to start there, but this is just a place to start. This is not the end of the campaign. I love your mention of rural health, behavioral health. So with that, we want to start with the triple double, but not stop there. And I'm going to give this back to you, Q. Thank you very, very much for your fantastic ideas.
Can we give them a round of applause? That was a great panel. Look, I do want to highlight, as was shared a little bit, we have been the past year, Dr. Asaf Bitton did a presentation at our big conference at NAC about a year ago in August and highlighted the triple double there. And we've been doing a bit of a soft launch, and we've been giving these basketballs at our advocacy work, and I will tell you, it is resonating. So the idea of how we engage at a national level, but ultimately the real rubber hits the road at the state level, at the local level, and how we think about advancing this movement at a national and a state level is important, and that was a great example of the opportunities we have. So we've been talking about setting the vision, we've been talking about patient advocacy groups and patient-centered care, and we've just heard about the state opportunities. Now we're gonna move to the private sector. And as you reflect on healthcare and the healthcare dollars, over $5 trillion, we know that so much of that funding is connected to the public and the private sector. And so I'm glad to introduce Dr. Purva Rawul, who's amazing. She's an internationally recognized leader in value-based care and health policy. We've had the chance to work together when her most recent role as the Chief Strategy Officer at CMS Innovation Center. And she's got a great career. You can look at her bio online, but just appreciate that she played a very important role. She was on the Senate Budget Committee as a staff member during the development of the Affordable Care Act and was an advisor to Senator Lieberman, and has some great publications and a BA and PhD from Northwestern. So let's welcome her as she brings the private sector perspective. Dr. Rawal.
Thank you, Q. I think we have, we're down one panelist, but this means everyone else has more time to answer questions. So I'm going to welcome Dr. Sri Chagatura to the stage. He is the Executive Vice President and President of Healthcare Delivery at CVS, so like no small job. And Dr. Neela Jessel, she is the CMO of Athena Health. Dan Castillo was supposed to join us, the CEO of Optum Delivery, but unfortunately I think he had some flight issues. So grab a seat. And I just want to say thanks to NAC and for AFP for continuing this event. I think this might be year 5 or 6, I don't remember now. And I think I've been able to come to almost all of them. And I keep getting invited back, so thank you for having me. This is like, I think, an especially interesting panel, not just because I'm moderating, and because of the panelists, but because of the triple-double. There is, I think, some real momentum around reinvesting and reinvigorating primary care, its importance. I don't think that's what we are demonstrating, and I think in this panel in particular, it's not about the value of primary care, but it's really about talking and learning and hearing about organizations that are already scaling advanced, high-quality primary care and how they're putting the different pieces of the puzzle together within their very large and complex organizations. This work is happening. We can learn from it, and we can do a better job of, I think, supporting it. So some of the main topics from our panel, we're going to start just hear a little bit about each of their organizations, and in particular where primary care sits within their organizations. We're going to touch a little bit about, as we all know, there's lots of different modalities for delivering advanced primary care, so we're going to talk a little bit about how, in each of your organizations, what are your strategies for how you think about those modalities and deploying them effectively, and again, at scale. We can't have a primary care discussion, even with the private sector, without workforce and how you are approaching workforce, how you are thinking about the role of digital health and AI in the workforce, and really enabling the delivery of high quality primary care. And I think that came up in this morning's discussion with some of the CMS officials that were here as well. We'll talk a little bit about scaling and where you are in that kind of scaling journey. And then challenges. What else do you need to keep doing the work that you're doing to make healthcare more, especially primary care, more accessible and affordable? So that's sort of just will orient everybody to kind of what we want to hit on today. So Neil, I'll start with you. I don't know if you could tell us just a little bit about your organization. It's very complex, so give us a sense of Athena Health, your role, and then where primary care sits within your organization, your overall strategy.
Yeah, sure. First of all, thanks for having me. So I'm Neela Jessel. I'm Athena Health's Chief Medical Officer. So when you look up Athena Health, and I'm actually glad we're down to 2 panelists because it needs a little bit more explanation why I'm on this stage and how we are related to primary care. So when you look up Athena Health, you'll find we're a healthcare IT company. We provide practice management, electronic health record, and patient engagement services, software, right? What does software have to do with primary care? Well, in order to tell you that, I have to tell you a little bit about the why behind the what, right? Why did Athena go into the business of electronic health record software? So in 1997, and that year has special significance to me because my twins were born in 1997, so it's easy for me to track Athena's age. So in 1997, Athena's original founder, Jonathan Bush and Todd Park, set out to buy a public health OB/GYN clinic in the Bay Area because they wanted to improve maternity care. That was their original mission. Well, like all of us in healthcare, they learned pretty quickly that it's actually really complex to run a healthcare business. And more importantly, it's very hard to provide accessible, high-quality care if you don't get paid appropriately for your services, right? We all know this. Part of the reason why we're here today, no mission without a margin. So what did they do? They recruited Ed, Todd's brother, who was an internet engineer at the time, and he built custom software for them to help them get paid more easily for the services their clinic provided. Now, that clinic back then was called Athena Women's Health, so you can see the connection to today, and it was really about two parallel missions, right? To provide excellent, accessible healthcare to people who don't have great access to healthcare otherwise, and to also get paid for those services and take out a lot of the complexity of the getting paid part. So that's how Athena Health originated, and fast forward 28 years, that same mission and vision-driven attitude is in our DNA, and it runs through every aspect of our healthcare company. And we always joke that we happen to be a healthcare company who also provides software, and that's not far from the truth, because our vision actually is to create a thriving ecosystem that delivers accessible, high-quality, and sustainable healthcare for all. And that vision comes from that origin story of Athena. And every day I'm honored to be chief medical officer of a company with 7,500 great human beings, to pick up an earlier thread, who wake up every day thinking about how to make healthcare better, right? And yes, we're a public company, and I hear that, not a privately held company right now, and hear this all the time. But you can do well and still do good, right? Those two aren't mutually exclusive if you have the right guiding vision. So why does this matter, right? You can probably guess by our origin story that primary care and CHC is absolutely core to our business. Like, that is how Athena originated, right? We deeply care about the frontier of medicine and ensuring access. Like, we cannot execute on our vision if we don't participate and play our part in ensuring access and high quality care for all. So that's where our affinity to especially CHCs, rural health centers, comes from. That's why we're so closely connected to primary care. And I'll include women's health and pediatrics here, even though I know by this definition it's probably more internal medicine, family medicine, but the frontier of medicine is crucial to providing access. And we enable this kind of access with our technology platform, and I can go a little bit more about this in some of the subsequent questions, why that is really different in Athena's case, because Jonathan and Todd and Ed back in the days had the vision to found Athena as a cloud-based single instance software platform. That is extremely powerful. We have a presence in all states, and we have data about roughly a quarter of the US population. That data is extremely powerful, and it also helps us help transform healthcare in the way it should be transferred, right? Placing more emphasis on value than volume.
Thank you. Sri, I'm going to turn to you with the same question. I think what's interesting in having the two of you here is that Athena Health was an IT-first company, right, at its inception, is now really all of it. It's doing care delivery. You guys started out as a care delivery or care provider. CVS did, and now you are all of it as well, including a lot of the IT components, which I think are critical, as we talked about.
Yeah, so hello everyone. My name is Sri Chagatura. I'm a physician. I trained in primary care. I continue to practice and see patients, and for the last 25 years in the same clinic. But in addition to that, I have the pleasure of working at CVS Health, and I oversee healthcare delivery. I actually remember having a mentorship conversation with Todd Park a long time ago. And he asked me this question, what do you want out of your career? And I said, I want to have impact. And he said, well, that's a very simple formula of mass times velocity. I was like, that's momentum, but we'll go with impact. I was like, but what do you mean by that? He's like, the bigger the organization, the faster it's moving, the more impact it will have. The problem is they're largely inversely proportionate. So big organizations tend to move slow, small organizations move fast, and it's about knowing what drives you, what motivates you. And I've always been driven and motivated by large organizations, because when they do things, there is a tremendous impact. I like to think we also move fast, but let me tell you a little bit about CVS Health. So CVS Health, as you know, we have pharmacy. So 85% of Americans are within 10 miles of a CVS pharmacy. We have about 9,000 locations across the country. In addition to CVS Pharmacy, we have a number of other verticals. So we have Aetna. We provide health benefits for over 20 million individuals across Medicaid, Medicare, and commercial. We also have Caremark. So we provide drug benefits for 1 in 3 Americans, and are the largest purchaser of pharmaceuticals and distributors of pharmaceuticals in the world. And then we also have healthcare delivery. And that's the pleasure that I have to oversee. And within healthcare delivery, and we'll talk more about the companies and what we're trying to achieve, is Oak Street Health, which is focused on primary care for seniors, Minute Clinic, which is convenient care in your community, and then we have Signify Health providing in-home health services. So it's really a pleasure to be here.
So I'll move on to the first question. One is, you already, Sri, you sort of teed this up talking about all the different components or assets that you have at CVS Health. But for each of you, it'd be great if you could talk a little bit about how your companies, your organizations are leveraging or applying the different modalities that primary care is delivered in. So, you think about patient portals, home-based care, in-person, telehealth, right? There's so many different modality minute clinics that primary care can be delivered in. How do you think about how do you think about leveraging that continuum, applying it to what can be very different populations and very different ecosystems and communities of ecosystems?
So maybe just to continue the thread, CVS Health, and as I think about our healthcare delivery platform and across actually all of our companies, we're all trying to achieve the quintuple aim: cost, quality, access, equity, and experience. But if I sort of back up and think about how do you achieve that quintuple aim, it really involves trust and engagement. And so we need to have trusted providers in locations that are easy to engage with. And that's a through line across all of our companies. And so with Oak Street Health, what we have with Oak Street Health is 230 clinics across 27 states, focused on Medicare Advantage and dual eligibles, largely in the urban core, where we are caring for some of the most complex disenfranchised patients in America. And it's been a real pleasure to have the oversight of this company. There has been a lot of headwinds to value-based care, and maybe we can talk a little bit about that and sort of how we've been thinking about version 1.0 of value-based care versus version 2.0. And I would say version 2.0 has been, do you have true med cost levers that can actually fundamentally improve healthcare outcomes? And I'm pleased to say we have that in spades, evidence of that in Oak Street Health. One proof point is 40% reduction of those patients who are engaged in our model in hospitalization rates compared to a traditional fee-for-service Medicare population. So that is a model that is a highly complex VBC primary care model, which is very different than what we have with Minute Clinic. And so Minute Clinic, as a convenience care service offering. So we have about a little over 800 clinics that are providing over 150 different types of services. So we started out with acute care services, but we added on chronic disease management and preventative services. And then over the last year and a half, what we've done is we have now nearly 600 clinics across 14 states plus here in Washington, D.C. that are now delivering primary care. So you have two models side by side, primary care and convenience care, and you could come in to see us for both. And so, to my knowledge, this is one of the largest scaled primary care practices across the nation. The other piece around that's conveniently located, we have 50 states of virtual care access to, and we have a virtual primary care product, which we then offer to employers, and we sell directly to employers through Aetna. And so we have both of these, and I think one of the other pieces that's worth noting is that this is a nurse practitioner-led model. And so we have really leaned into nurse practitioners as well as pharmacists as being able to provide and deliver services. The last company is Signify Health. And so Signify Health, we provide in-home health evaluation. So we do 3.5 million home visits per year with a network of nearly 12,000 clinicians. And in that, we do a 1-hour comprehensive visit where we're reviewing chronic disease management, preventative services, primary care needs. What we're finding is that at the back end of that conversation, we have built trust because it's been 1 hour in the home. And then that allows us to introduce the opportunity for additional connections into care. So we work with payers to understand who are their preferred high-value providers for primary care, and we can refer patients into those primary care practices so we can become an engine feeding into high-value primary care. We also can feed back into care management. So we just We have some pre-published data that we've just submitted that shows that we built essentially an active line where you can call Aetna Care Management at the end of that visit if you qualify for Aetna Care Management. With that warm handoff, we're finding a 35x increase in engagement compared to when a payer just tries to engage on their own. So what we have with Signify Health is really, I think, one of the more powerful engagement engines in healthcare, in the home, that can then feed into primary care and other services.
That's great. I think if I did sort of summarize what I heard you saying is that it's not a one size fits all. The modalities are there to meet people where they are in their care journey, right? You get your minute clinics that are now 100%. Connected to primary care. These are for busy working folks. You've got the urban underserved core that Oak Street is really caring for, and then you've got Signify, and all of these different modalities get deployed and help meet people where they are.
Exactly, and I think this room is, and our audience is well versed on this, but 25 years ago when I trained in primary care, was, as Dr. Baton talks about, a general store model, one size fits all. What we've noticed and know now is that bespoke, built for purpose primary care for subpopulations can deliver incredibly high outcomes because it's built for purpose.
Dr. Jessel, I'm going to turn to you, and you mentioned in particular Athena's presence and partnerships with community health centers and RHCs and rural health clinics in particular. So if you could talk a little bit about how you're deploying modalities, but especially for rural populations, I think that would be really great.
Yeah, absolutely. And I think it's like you read my brain. I was going to make the point that one size doesn't fit all, right? There's lots of diversity across the US and the need for lots of different care delivery models, and that technology has to be flexible enough to support different care delivery models. So when I think, for example, about direct primary care that we talked about earlier, yes, that is a great model, but it's also only accessible to a portion of the population, right? And then there's a large portion of the population that doesn't have access, but has access through community health centers and rural health centers, especially in the more rural areas of the United States where you have significant access challenges, especially when it comes to seeing specialties, right? We talked about this earlier this morning, that in many areas, the primary care providers, I think the cardiologist talked about this, right? Provide more cardiology than most cardiologists. So how do you support this? How do you make the technology support various care delivery models and also care delivery models that are truly the definition of the original, integrated care delivery model, which is truly what community health centers are all about, right? And you have alluded to this too. You have lots of different care delivery models because it really takes a village to keep patients healthy, engaged, and drive the right outcomes. So when I think about how our platform supports this, how our technology supports this, and there's two key aspects to this. First of all, I already talked about our platform model. We have a single instance, it's cloud-based, everybody is on the same instance of software. So we learn a lot about what our customers do on our platform. And the second key aspect to this is that we provide software and services. So we actually manage the practices in partnership with our practices. We have a business model where the financial incentives are aligned. So if we do well, if our customers do well, we do well, and vice versa. So that allows us to see where the pain points are and rapidly develop technology solutions to fix those pain points, right? So if we pick up on issue X in state Y, then we figure out how to intervene and employ technology to decrease that friction. Because one of the primary issues we have in healthcare in the US is the fragmentation, right? And when I talked about our vision, that our goal is to create a thriving ecosystem, that's obviously partially self-serving because the more people come on our platform, the better we do, but it's also to create this ecosystem because, as you just outlined, without this ecosystem, it is really, really hard to keep patients healthy and drive the right outcome. So by supporting this ecosystem of people on our network, and not just medical practices, but also the other side, right? We have a partnership with payers. Like we partner very closely with United Healthcare, we partner very closely with Aetna. We surface insights that the payers have that practices typically don't have access to, or only have access under difficult circumstances, right? Many payers have provider portals where they expect providers to go and look at care gaps, diagnosis gaps. Well, providers have like 10 minutes with the patient if they're lucky, right? No provider wants to log into a separate payer portal and look at that data. You have to bring it to the electronic health record where providers live, right? Data that isn't served at the point of care is essentially useless because it doesn't help you make an educated decision at the time the patient actually sits in front of you. So we try to be that bridge, that connecting glue for the healthcare ecosystem, where we leverage our technology platform to connect all kinds of different players in the ecosystem to really bring them together and build this connected ecosystem that ensures longitudinal care where nothing falls through the cracks and really can accommodate the journey of the patient. So community health centers and rural health centers, of course, are in an even more difficult position, right? Because they typically have a patient population that has even less access to care and maybe sicker, and payment is an issue, right? And finding the right specialist is an issue. So how can we bring services that enable good engagement of that patient population, good access? For example, a couple of years ago, we made that decision, even though we've always been, first and foremost about primary care, the front door of medicine, to branch out into specialties because we felt there was a need to better support specialties that are front door adjacent, so to speak, and support various care delivery models. Community health centers rely heavily on integrating behavioral care, rely heavily on integrating dental medicine. We, as the technology vendor, must be able to support those specialties. You had mentioned your minute clinic business, right? Lots of patients only have access to care via urgent cares. And maybe if you're a primary care physician, you don't feel great about the urgent care, quote unquote, stealing your business. But the matter of the fact is, we have to meet the patients where they are, right? And if the entry point is the urgent care clinic or the minute clinic, because that's when they could get off work and that's where they could get their care, we have to be able to support this, but then we can use that to funnel them appropriately into a primary care physician, for example, right? It's all connected. Like, if we don't get to the point where we can make healthcare truly the ecosystem that it needs to be to support holistic care, then I don't think we'll be successful in ensuring access, high quality, and most importantly, sustainable, right? We'll just keep creating cost.
Yeah, I think what's sticking out to me, what both of you said, but especially what you just talked about, Neela, is the idea that the ecosystems are out there and they exist. What your organizations are able to do because of your scales and size is to build an intentional ecosystem and then connect it.
Yeah, and I think just to build on that, we've been intentional not trying to build the entire ecosystem. We believe that primary care matters, and that's why we've invested in primary care, and we believe the home matters, and that's where we've invested, and we will partner with the broader healthcare ecosystem through specific contractual relationships or through technology and data transfers. But it is really important for us to just state that we are not trying to build the entire healthcare ecosystem here.
That actually tees up the next question, which is really about scaling, because there's pockets of innovation everywhere in primary care and other areas. And when I was at the Innovation Center, that was obviously a challenge. Then it's a continued challenge now, is that you can have innovations out there, they look promising, how do you actually scale them? And I think that's maybe a unique thing that both of you can bring to today's conversation, is how are your organizations thinking about or on that journey of scaling advanced primary care? And then who are those partners that you work with, whether they're other corporate partners or even community partners? What kind of partners do you need to be able to sustainably scale these models?
Yeah, sure, I can start with that because it came up this morning too during, I think, the first panel discussion when Abe had mentioned that there is tremendous cost pressure, right, in the healthcare sector. Like, staffing costs are rising as cost of living is increasing. Right now with the AI transformation, you can all read this in the newspaper. Software engineers are making a lot of money. Cost of living increases. You have to pay your staff more. But there is a ceiling to how much you can raise your prices, right? Because in healthcare, as we also talked about, the still absence of the new fee schedule, it's very, very hard to increase your prices to stay on top of your rising costs. So how can you solve for this, right? How is that scalable and sustainable over the long term? Well, you have to somehow take out cost. And again, like, the best way from observation where I sit at the technology intersection with healthcare is to automate processes that don't need to be completed by humans, right? And free up the humans to actually engage in patient care, right? And I think we heard this quote also, the best patient care is when you actually provide care to the patient. But how can you do this when you get increasingly burdened under administrative work, right? Prior auth is like the new bane of, and I think the number one complaint of why providers hate healthcare. It has overtaken the EHR in the most recent AMA survey, why providers are burned out as prior authorizations. Just one of many reasons. So how can we leverage technology to automate processes to actually amplify humans, right? We have a finite number of humans. There's only a set physician pipeline, right? Even if you supplement them with advanced practice nurses and PAs, there's more and more people with chronic illness to take care of. Our population is aging. The pandemic hasn't helped, right? Chronic conditions are increasingly becoming the norm. So how can we scale people, the existing people, by offloading burden from those people so they're free to concentrate on the things that truly matter and that they should be doing. And that's really where technology, especially now that we have a new tool in our toolbox with generative AI, has tremendous potential to transform how healthcare operates. I think we have talked about, the transformation of healthcare for 20 years now. We all were hoping that value-based care was the thing that would finally transform healthcare and make it sustainable, and I still have high hopes for value-based care, but it still hasn't quite yet materialized to the degree that we're hoping. My doctors, by and large, and clinicians everywhere still view the EHR as the devil because it added administrative burden instead of wicking away administrative burden. But I truly believe we have the opportunity now to change this. Like, we've seen incredible potential what AI, and I don't mean machine learning, which we've employed for a long time, but generative AI can bring to the table insofar as supplementing humans, right? I'm not going to talk about replacing humans because I don't see that happen anytime soon in healthcare. It is a very gray business. It's not very black and white. So there is definitely significant restrictions where you can employ AI and do it in a ethical and safe way, so you don't have any sentinel events, especially from a patient safety perspective. But there's tremendous potential to help us scale our existing workforce, because I don't think we'll get more. The cost will continue to rise. It's very unlikely that revenue will continue to rise as much as cost. So we got to figure out how to amplify what we have, and technology, in my mind, is the answer. But of course, I'm a little biased. It's a healthcare vendor.
No, I agree. Technology does matter. So I think to your question of scale and how do we, as I started my opening comment, scale is something that's been a central driving motivation for myself and for our entire company. And as I had mentioned, Oak Street Health is one of the largest scaled VBC providers for primary care. MinuteClinic is now one of the largest primary care providers, largely on the commercial side and virtual side, and then Signify being one of the scaled on the home side. And so as I think about how can we continue to be successful in scaling, it does require, one, to have a common mission that everyone understands, and that's about mission and culture that you can drive all the way through the organization. The second is, do you have the data that demonstrates that everyone understands what good performance looks like against that mission? And that gets very closely to technology, which is then how do you use technology to be able to help flow the ideas down and the operating model into the organization. You need to have processes, and very clear processes, because it's very easy for leadership to have a notion, to have the front line have the notion of what needs to happen. We have our chief technology officer came from Disney and was the CTO for Disney. And in Disney, they have this concept of the frozen middle. Things get lost in middle management. And so how do you make sure that the processes actually can flow through to the people doing the work down at the ground, the leaders in the middle? And then lastly, it's the people. Like, you have to have great people and people who believe in everything that you're doing. So scale is not any one thing, it's a combination of those things. But if I kind of bring it to life at, let's take Oak Street Health, if we're thinking about care model innovations, we have people who are, what's the beauty of now compared to 15, 20 years ago is that we now have a much better evidence base of what care model innovations work and what are the tactics necessary to bring them to life. So having a central population health care model team that can look at the evidence, identify what works, but we know that implementation does need to start locally to be able to hack away at, how do you import that external innovation into your ecosystem. So we generally will find regions that are able to, based on bandwidth, performance, take on innovation. We'll deploy it there, clear metrics on how to scale, champions that can tell the story on what worked, what didn't, and then quickly use technology and processes to scale that across the entire fleet. But what you don't want is in perpetuity pilots, which you see a lot, and you need to have an evidence base that allows you to scale it over time.
Can I make one more comment to the scaling? Because I think that's important because, of course, people who run smaller healthcare operations, right, a practice with one provider or two providers, look at a company like CVS, right, that has tons of resources and pockets, and think like, well, how could we ever do this, right, and be innovative and leverage technology? And I think that's, again, where vendors such as us have a responsibility to enable scaling by bringing the technology to even organizations who don't have the resources, right? And I think AI is a great example. Like larger healthcare organizations have clinical informatics team, IT teams, procurement offices, right? That can evaluate multiple vendors and figure out, does this help us? Does it hurt us, right? Is it worth the investment? Small practices and community health centers don't have those resources by and large, right? So the way we address this is we do the due diligence and we offer those vendors already fully integrated to our customers. So it's a plug and play and you can easily try it out and see if it meets your needs. And that goes for solutions that are part of our native software, right? And solutions that can potentially be added as part of a marketplace. Because if we don't figure out how to make everybody innovative and enable innovation, it's going to be very hard for smaller practices to scale.
Yeah, and similarly, I think my team would say we don't have limitless resources. And so we also have to think about partnerships as well and have to make those choices. And so we're clear-eyed on what we can do well and where do we need to partner to go faster. And so you asked a question which I didn't fully answer, who are we partnering with? And so we have partnered with Time on oncology to help our patients who need oncology services, especially community-based oncology, with Strive to help with CKD and ESRD, with Impassion for end of life. And so these are close adjacencies to primary care, yet we know that it would take a lot for us to build those capabilities, and it made much more sense to partner with people who are using evidence base, and we could build that partnership.
It's that connecting that ecosystem piece again. I think the other thing that strikes me is, and I think, Neil, you said, you still have high hopes for VBC, so do I. But it's an evolution. You talked about VBC 2.0, right? The first part of this was me figuring out what the puzzle pieces were. Now, using technology and scale, we can start to connect those puzzle pieces together in a different way to get to better outcomes and more sustainable costs.
I mean, the reality was version 1.0 of value-based care could get away with risk adjustment. That is the reality. And what we have had with rebasing of the risk adjustment model with V28 is that risk adjustment has less value, but what never changed was taking great care of patients. And so what we see now in version 2.0 is value-based care that has true care models that can actually keep patients healthy and at home and out of the hospital will continue to thrive. And so we're in it's a good spot because we've sort of leveled the playing field. And if you continue to invest in those care models, VBC will continue to thrive.
Yeah, and the challenge with VBC is that it requires a completely different approach than fee-for-service, right? And I think, we started as a fee-for-service company, and we had become very good over the years. And a couple of years ago, we, as a company, made a conscientious decision to want to become as good at VBC as we were or are at fee-for-service. And that requires a very different mindset and investment decision. And what we found is, that we support the entire spectrum of value-based care, but very few people on either end of the spectrum, right? Very few people are still completely in fee-for-service or completely in value-based care full risk. For most people, they're somewhere on that journey, and this is why it's important for us to be able to support both, because you still have to support fee-for-service for those practices who use their fee-for-service payments to finance that transition to value-based care, right? And the other challenge, I think, with value-based care, especially for smaller healthcare operations, is it requires copious access to data, right? And not just data, the data by itself is useless if you can't glean the appropriate insights from the data. So most practices require some sort of assistance to actually transform the data that we now, thankfully, thanks to the advancements in interoperability over the last decade or so, we have access to more data than ever, but data by itself is just that. It's useless facts, right? If I can't transform the data into useful insights and also make those insights actionable, it doesn't help anybody. And that often comes up too when we talk, for example, very important in the CHC space and primary care, to social drivers of health, or formerly called social determinants of health. They're only helpful to me as a physician if I actually have resources to act on them, right? It's very, very challenging for me as a physician to ask a patient and then sit there with that information and be like, yeah, sorry, you have housing insecurity, don't know where to send you, right? So that's, I think, where we have to marry the two together, and ultimately that is truly the big challenge of value-based care, is not so much getting access to the data, but getting access to the data in a way where you can actually prove that your interventions drive the correct outcomes. And that's, I think, where, again, technology plays a huge role, and where it's important to integrate technology in such a way that to the care team at the other end, it's seamless, right? The care team shouldn't have to care if the patient is in a fee-for-service arrangement or a value-based care arrangement. They should focus on delivering care, right? And the more we shift focus from quality metrics and this and this and that to, and care gaps to, what does this patient need? Did the patient get the services they need? If not, what do I need to do to get them the services? I think the more successful everybody will be, because right now many providers run screaming for the hills when they run value-based care, right, and measuring. But at the end of the day, I would say, but it's just good care. Like, those things are being measured. You should do colorectal cancer screening, right? You should do X, Y, and Z. Like, that's why they're measures. So how can we make the care providing and the measurement as seamless as possible to actually drive those outcomes?
Do you want to add something? You're good. So I think we have maybe 30 seconds, but you can take a minute. I was going to give you guys each a closing question. What are maybe just like, what are the one or two challenges each of your organizations is facing in, as you are trying to scale and spread access to affordable, like, longitudinal primary care? And they don't have to be brand new issues. I'm sure you and I were talking about this a little bit before. Some of these are evergreen issues.
They're evergreen issues, right? So if I think about the issues, we need to get compensated, and that's what the triple-double is around primary care. So we continue to have, our conversations with our payer colleagues around Minute Clinic reimbursement rates, Oak Street Health value-based contracts, appropriate, payments for Signify services, recruiting and retaining great clinical and non-clinical talent, and making it a mission-driven place to work, where people wake up every single day saying, I am fighting the good fight, and this is why I'm excited about being in this place. Making sure that the technology is not multiplicative but subtractive, that the technology is actually taking work out of the way. And so really hacking away and using technology in service of, not against, our care team. So I think, many of the issues are evergreen issues. There's nothing fancy here, but I know everyone in this room is working through them.
Yeah, and I'll just second those comments and say, to me, the most important is to remember that none of us can do this by ourselves, right? It's all about partnership and really all of us working together to build this ecosystem that supports patients in their journey.
Well, I just want to thank both of you, and I'm sorry Dan couldn't join us, but we filled the time, and thanks to all of you.
Thank you.
Thank you.
Yeah, that was another great session. And so now, and just to highlight, that as we reflect on that session, the importance of engaging the private sector and thinking about the opportunities there are, whether they be care delivery or health tech, is important as we think about the triple-double today and tomorrow. So now I'm excited to introduce a bit of a fireside chat with Dr. Deborah Lubar, and I'm going to just highlight her before she goes on the stage. She's an amazing leader. She's a public health leader with expertise in population health strategy, policy, and operations, and she became the CEO or the president of the Milbank Memorial Fund last December. So Dr. Lubar most recently served as the Chief Operating Officer at the CDC, where she led agency-wide operations, developed program and policy strategy, and oversaw a budget and execution of a $19 billion, 22,000 employee federal agency. She worked under 5 administrations at the CDC, and she's been such a key part of the triple-double. The Milbank Memorial Fund has been under Chris Kohler's leadership, and grateful to have you as the leader, and excited to have a fireside chat with the role of philanthropy as you represent all of philanthropy, Deborah. Big responsibility. Come on. So, would love you to just share a little bit about yourself and, kind of you've been in the role now for 7 months, and we've talked about, why does Milbank care about primary care? So,
yeah. So for those of you who don't know the Milbank Memorial Fund, it's a 120-year-old operating foundation. And its founder, Elizabeth Milbank Anderson, was interested in public health and health care delivery for poor and underserved communities. I have the same interest, but for a slightly shorter period of time. As part of that work, over time, the Milbank Memorial Fund had a lot of involvement in state policy work around healthcare reform in the 90s, and really has focused our work on improving population health and health equity through state health policy, and in particular through supporting state health policy leadership in both the executive and legislative branch. Chris Kohler is a great leader of primary care and was able to really build that portfolio. I see it as a really important strategy for population health and healthcare delivery improvement, because it really is the point where public health hits people. And in my work, whether it was in chronic disease or infectious disease, in emergencies and in peacetime, no matter what the guidance was, no matter what the intervention was, primary care had a role in making it happen for people on the ground.
Now, that mission of population health and health equity, and as we think about philanthropy, and earlier today we listened to CMS, and you most recently came from the public sector, right, and government. So interested in you sharing that dynamic of what can philanthropy do that government can't, and where does government need to lead instead, especially as it relates to this opportunity in primary care?
Well, this has been my great adventure of the last 7 months, because I went from a $19 billion federal agency with some regulatory power and those sorts of things to a much smaller organization with a different kind of influence and power. And Milbank actually isn't a grant-making organization either, although we work closely with a lot of them. So what I've seen as really the difference is government can move these big levers, federal government can move these big levers. At Milbank, we really believe in the state role in moving big policy levers. And we can provide and fill gaps in philanthropy with consistency, with sort of longer-term view, with an apolitical lens that still relies on evidence and builds on what the federal government and our academic centers are creating that supports population health. So a couple of examples here. Katie talked about the policy menu for primary care, and that's something that Milbank and NASHB collaborated on, and that has a different flavor than if a federal agency had put it out and funded against it. It really provides a very long-term view. It provides for variability in what states want to do, can do, and need to do for their population. So that's one example. Another one is we work with the Physicians Foundation and with the Robert Graham Center at Milbank to produce the primary care scorecard. And a lot of the data slides that you saw from Dr. Baton were based on that work. And that came as a result of the NASM report that Asif mentioned, which called for tracking the recommendations. And there was no government entity at the federal level that was going to track them. They cut across agency responsibilities, and the data, as someone mentioned earlier, is coming from all different places. So we took that on and can provide that consistency of measuring against those recommendations. So that's sort of the long, stable view. But the other thing is, in philanthropy, we're pretty nimble. I mean, you know, so some of the larger ones function a little bit more like big organizations. At Milbank, we're super nimble. I'm like, let's put this on the web, and it's there. And I'm like, wow, that would have taken me a month at CDC. But so when there's opportunity or when there's threat, we really can move with that. And we can do that together as philanthropies. We coordinate with each other and with other nonprofits. So an example of that is recently we were contacted by legislators in Michigan who saw the primary care policy menu and said, we want to do all of it. Can you help us? And we were like, can we help them? Yes, we can help them. And so we sent an expert to be at their kickoff meeting. The lead sponsor of the legislation said he was handing out printouts of the policy menu like Tic Tacs. So, we were able to just say yes, and that is something that is not always available from a government agency.
I mean, and that agility and that ability to adapt and customize and build relationships. And I know the history of the policy menu started in a way that was unique, right?
Yeah, well, this is Chris Kohler's story, but I'll steal it. So he had a legislator, he had been the health insurance commissioner in Rhode Island, and he had a legislator say to him, he was seeing all these bills that were not going to move the needle. That was happening in a lot of states. And this legislator said to Chris, well, I want to do something meaningful, but what would it be? And so we were able to get that feedback from the field, and then we thought, we're seeing it replicated in other places. So it wasn't a top-down decision. It wasn't, we want to create a policy menu. It was, what does the field need? What are we hearing that would really take the next step, where folks are ready to take the next step? The other thing that I think is lovely about being in a philanthropy, and I think this goes for lots of organizations, is, we at Milbank really try to see this big picture for health policy and population health. And so it's not just Medicaid, it's not just healthcare regulation, it's not just public health, it's not just behavioral health, it's not just social services, it's not just transportation. And so we try to really engage state leaders in thinking that way, in that kind of matrixed way of thinking or leadership way of thinking, particularly for those who have oversight over multiple state agencies or for legislators who have jurisdiction over multiple state agencies. And that's a luxury that is hard to have in government when you have your own silo to manage.
And I wanted to talk about now broader philanthropy. So you just shared in the last 7 months and kind of the comparison of philanthropy and government. I recall when I was at HRSA and we did a great initiative with CDC around public health, primary care integration. And there are a number of health centers that are also public health departments. So it's fascinating to see kind of the opportunities to partner across HHS agencies. But as you look now in the first 7 months, and there's a group called the Funders Network. Would love you to share more about them and the work that they're doing, and bringing diverse philanthropy together. You've delivered some real wins, and would love you to share some examples. And what are you seeing in that type of model that might be different than the model you saw, in your prior role?
Yeah, so I think based on that NASM report in 2022, before I was with Milbank, we and the Commonwealth Fund saw a need to get philanthropies behind those recommendations. And there's a lot of interest in primary care and in healthcare reform in the philanthropic sector. How can we move together? And so in 2022, 6 organizations, and it actually included AHRQ, so there was a federal agency as part of it, got together. Now there's about 13 philanthropies that get together, and some of them are national and some are more regional in nature. And part of it is really to share to coordinate and also to share innovative investments that others can learn from. So a couple of the concrete things that came out of that, one was the Primary Care Investment Network, which Julie spoke of, that is a partnership that Milbank and PCDC and Commonwealth have. So that was an early attempt to really drive state engagement and learning from each other. A more recent one is a NASM GME summit, I guess. I don't know what NASM really calls them. But that came out of this group saying we really need to get focused on workforce. And that also spurred activity across funders. So I know that, that the Robert Graham Center just put out a GME IQ tool. Milbank just put out a GME roadmap for states, how states can drive GME while we wait for the federal government, or to inform the federal government, as states often do. So those are a couple of ways that funders have collaborated using this space of the Funders Network.
So as we reflect on the opportunity in bringing more people to this table of primary care, especially those funders who might not necessarily think of themselves as primary care funders, what do you see as the opportunity and the challenge for us?
Well, you know, one thing I've been thinking a lot about, we've been thinking a lot about at Milbank, is that we have two state networks, technical assistance networks. One is for primary care and one is for affordability. And there is substantial overlap, and more there are really common goals for that. We see both of those as essential for population health. I watch the affordability problem, you know, basically eat every policy solution we come up with. You know, you think about ACA and why did it need subsidies, and why when the subsidies went away, do we have problems? You look at other things states are trying to do, and you know, they're having to roll things back instead of roll things forward right now. So we're really looking at those connections, and there is a community of nonprofits and philanthropies that focus on affordability, and there is some overlap with primary care, but it's not total. And I connect that to something else that Katie said. We do a lot of work with NASHB, so we think alike. There are a lot of governors going to change this year. And you know, we know at least 18 of them will change, and probably more. And affordability is going to be on those agendas, and it's going to be an issue in all of those elections. So, you know, the more that, and today we saw a lot of examples of connecting primary care and affordability, not, as Asif said, show return on investment in the next year, or, you know, if you're investing in pediatrics, how long is it going to take? But just that it's part of a package, and more we're hearing state leaders talk about reforming the system, not just addressing affordability, not just addressing primary care. So I think that is how the tent gets bigger. And it also means, I think, the primary care community getting involved in some of those other healthcare reform-related issues.
And I mean, I will highlight the Milbank Memorial Fund, and you've worked in 5 administrations when you were at CDC. This idea of being nonpartisan or getting bipartisan support is key in the DNA of the health center movement, and finding ways to work, you know, with both sides, because so much of the legislation that gets passed here in DC requires both sides of the aisle to think and vote to push these forward. When you think about primary care and the opportunities that we have and the affordability crisis we have, being a bipartisan, nonpartisan issue, does that resonate with you?
It does, and we see that in the states. You know, we see states across the board interested, and that's why we want to provide that sort of menu of options. I think in both of those spaces, the stakeholder engagement is growing, and I think Triple Double is a really great initiative to move that, because I think we have these state officials and legislators who want to make a difference here, and they don't always have the ground support that can push back on some of the vested interests. And so I think in every state there's an affordability issue. In every state there's a primary care access issue. And so really trying to get the community to speak to it, and the grassroots, and I think you call them the grass tops, as well as the experts and the state officials and legislators really needing to push in the same direction, even if they don't agree on every policy point. I think that is what can make what I think is already a pretty nonpartisan issue move forward in this environment.
Anything else you'd like to add? Call to action? Anything as you're reflecting?
A call to action for this group. I guess what I would say is I know that in your audience there are a lot of folks who are focused on day-to-day running their primary care practices, running their community health centers. And I just really encourage you to be part of the policy solutions that states are seeking and be part of the triple-double because that is ultimately going to improve the quality and cost and outcomes of your care, and your policymakers can't do it without you.
Yeah, I often reflect on that, and once again, I reflect on starting as a primary care doc not too far from here at the corner of 14th and Irving, and realizing so much of what I was able to do in that exam room was beyond the exam room. And so the need to have grassroots advocacy and challenging, how we advance that with many stakeholders like philanthropy, like Milbank, is a key. So thanks for that call to action, Dr. Lubar. Thank you. All right, let's thank Dr. Lubar. We're going to welcome Dr. Nielsen, and we're at the home stretch, so we're almost there.
Dribble. Yeah, come on up here. So is everybody ready for our final session? Deep cleansing breath. It's been a fabulous day. You have heard a lot today about the why and the what of the triple-double. We would like to spend the last 25 minutes talking about the how of the triple-double. And so we're going to hop through some slides, the three of us together. Also, this was not on their question. So let's, if we're ready, we need to forward a slide. Fantastic. So this is the slide that helps describe our actions that we'd like to be taking over the course of the next year, 3 years, who knows? But you'll see we basically are working from 3 different tracks. First, we start with this unified messaging. You've heard a lot about that today. We've heard a lot of our audience talk about why it's helpful, important, maybe even necessary for us to be able to create this movement, to have shared messaging that people can buy into and share with their networks. The second item we're calling the Triple-Double Learning Lab, and that's to build from the work that NAC has long been doing in the space of grassroots advocacy and training. Here, and I'll let you speak to this in a moment, Q, the idea is to expand beyond what the advocates today focus on, rightly so, CHCs and funding for the safety net, and think more broadly about primary care and bring other folks to the table and get them trained and aligned with this message. And then finally, we had the panel on states, and we described in that session some of the work that we intend to do around the state collaboratives. So, our 2 fearless leaders, tell us a little bit about what you'd like to add regarding these particular tracks and why these 3. We could have done a whole host of different, we could have pulled a whole host of different levers in order to move the triple-double. And maybe, Sean, I'll start with you and the unified messaging campaign.
Yeah, I think the unique thing here is it's very simple. It's action-oriented, and I think it aligns with, what Dr. Lubar just talked about, some of the realities of the American public and the challenges and lack of confidence they have in the way the healthcare system is functioning, right? So they know it's challenging to get to primary care in their community. They understand the workforce shortages. They know that they don't have a usual source of care, or somebody they know doesn't have a usual source of care. And it just lines up nicely with what I would just call 2028, 2029, which is, as Deb just said, there's going to be a big conversation that takes place. And these are 3 easy solutions that start to address problems that people are experiencing today and are going to continue to experience. Second, everyone that cares about primary care and access to comprehensive primary care can find themselves in 1 or 3 of these messages. It's not exclusionary. No matter where you are in the clinician prototype, care delivery, your type of practice, if you're a technology company, everybody can find something to support inside these shared goals. So we've created a table or a room that's very inclusive to lots of different people coming on board. Third is the word Washington, D.C. is not really in there. I think this is a grassroots movement. I think it probably lands better in the States than it does in D.C. in many respects, not all respects, but many respects. So, what works in Oklahoma is not going to be what works in Texas, what works in Massachusetts, what works in California, but they can all build campaigns behind these 3 overarching goals that have a national connective tissue to them.
Excellent. Q, do you want to tell us a little bit more about NAC's work in the grassroots advocacy space?
And before that, I just want to resonate with everything Sean said and just highlight the fact that it's also very measurable. The messaging is very, like the importance of measure is, I think, important to track. And I do think primary care, if you look at the data, we haven't been valued sufficiently. The numbers show that we're not getting the respect, those of you remember Rodney Dangerfield, we need to get more, and part of how you're respected is these measures improving. So, but I will share NAC and community health centers. So NAC has been around since 1971. Community health centers have been around since 1965. The origins of our movement are connected to a recognition that there was a need for health for all, and there was a need for primary care that addressed whole person health for individuals, for families, and for communities. And so it's in our DNA with the combination of NAC, primary care associations, community health centers, to actually advocate at a local, state, and federal level in a grassroots, grass tops way. And I would suggest that there's a direct correlation between the success that we've had. When I started seeing patients, a couple miles from here, we only served 1/3 of the patients we serve today. How many public or private or nonprofit sector entities have tripled in 20 years? Why is that? I think 1, at its core, we're local, we're trusted, but also we've worked with both the public and the private sector in a way that's shown our value. And that grassroots, grass tops advocacy plays a very important role. So the Learning Lab part of this, look, candidly, as I've been in the role now 3 years, I recognize and value and appreciate the responsibility that NAC has and that primary care associations have to the funding, sustainability, and support of community health centers and the safety net. But ultimately, if you look further upstream at the bigger issue, it's the fact that we need primary care to grow and be strong for our nation's health. And so this is where we at NAC, we at the PCAs, we at the health center movement offer the potential and the promise and the skills that we've had applied, for health center funding to the broader primary care movement. And I'm hoping this is something, and Sean and I have been talking about this for over a year, And Marcy, it's three leaders here, really. We've been working so hard, and many other leaders in the room. But I do think to move from momentum to movement with real measurable improvement, it requires kind of us to really be bold and really demand more to do more.
I just want to point out that Q has either a career as a poet or a rapper. I mean, the alliteration is incredible. I mean,
well, as this idea, and I love when Asaf tells us the origin story. I would as we're closing up the day and we're thinking about these three different kinds of activities, the origin story of the two of you deciding, let's do this, because I remember clearly a conversation where Sean was like, I think we need to get all of the state chapters and all of the PCAs together. Let's do it. Okay, let's do it 2 months from now. And me thinking, have I taken the right job here? Tell us how the two of you decided, let's working with our friend Asaf, launch this thing.
Well, I mean, a lot of it is just craziness, right? I mean, I think, the concept of the triple-double came up I believe in an Uber, and, I had a conversation, I believe it was in Chicago or something, with Q, and it was, really built around this, I think 2 parts, frustration and, with where we were and this optimism of where we could be. And similar to NAC, I mean, family medicine, it was born out of almost a social movement in the post-Medicare, Medicaid, time of, creating equitable access across communities to comprehensive primary care. And it is a discipline of medicine, is a practice type. But the motivation then and the motivation now is still around expanding access to care for people of all ages across the life spectrum. So we kind of had this, shared vision, I think, of what was possible. We both are relatively new in the roles, not new, but new enough to still, have a lot of energy to be courageous. I think we have a shared vision, like many people in this room, that, the years 26 to 30 feel a lot like 06 to 2010. And it's a moment, and leaders and organizations that want to make a difference, figure out how to be present in the moment when it exists. And I think that is a lot of our shared motivation. The conversation about let's get our state people together, part of it on the 2-month horizon was just my belief and understanding that something that big just has to be done under such a short time frame that there's not room for, opposition to build or confusion to arise. So it was just like, let's just do it in 2 months or 3 months, whatever it is. Let's just force it to happen. People will come, they won't come, whatever it is, but we're going to get them in the same room and we're going to see if there's energy. We got energy, and then we got synergy. And then I think it's taken a little longer to get to today than I think Q or I really thought. We have really talented organizations and teams and partners, and it still took us a year. But I think we're ready to go at the right time, if you will. We're at the start line at the right time. And I'm excited about it. I'm terribly excited about our organization's partnership. I am more excited about people that are in this audience here today and people that are watching online, and about the partnerships that are to be identified and to be formed. We're good. And now I think it's really exciting to start to build that with other people and, get off the start line and get to work.
I mean, it's probably inappropriate for me to say this, but I think you guys kind of have a bromance. Just saying, it's just my observation. Q, why don't you tell us a little bit about, from your perspective, like you leapt at this. This is a very animating, motivating project for you.
Look, it's similar to primary care. It's all about people and relationships and trust. And I think ultimately it came down to that, between the bromance between me and Sean, and you as well. I mean, I will tell you, you've been an extraordinary leader and partner in making this real. And I can't say more enough of the role you've. Can we just give Marcy a round of applause? Look, I think a lot of factors came together. I think Asaf, where are you? There he is. I mean, yeah, like it's kind of a funny joke. Like I was at an AI conference, and he was at the primary care event, and we just met for lunch, or we met in the bathroom actually. We're like, why don't we go take an Uber together and talk about the opportunity in primary care? And then that's literally where I was like, and you came up with the triple double, Asaf did. So, and then once he shared it with me, the speed of trust, I shared it with Sean, and I said, we have our partners conference last year, and let's get our teams to, you offered right away, let's bring my state AFP chapters together. Just like happened quick. And then you played an integral role throughout, right? I mean, Asaf presented at our August event last year. You were there. You convened a lot of the stakeholders that are in this room. So I, as you said, I think when we look at the challenge and the opportunities, people like Sean and I get impatient, but I think that's our job.
Yeah.
But I do, the urgency of this issue is literally primary care saves lives and saves money. So there is this extraordinary urgency and impatience we should all have to challenge state and federal lawmakers, to challenge other parts of the system to say, these numbers are wrong, and we need to find ways to make them much better for the communities in need across this country, which aren't just underserved communities in low socioeconomic status. I would argue, I did my residency at Cedars-Sinai, UCLA. It was beautiful to see the juxtaposition of a NICU baby from a celebrity next to a Medi-Cal baby in that NICU, where I met my wife, who's a social worker, and I'm grateful for that. Hi, Amy.
He is hitting all his marks.
Yeah.
Nicely done.
No.
He covered the dog, the daughters, the wife.
But we do need primary care in Beverly Hills and Watts. We need it in both communities. And so our ability to work together across this nation to make sure primary care is available to all there's such an urgency and crisis that we have to push together on this as soon as possible.
That is fantastic. And it leads sort of to how do we pull all of you into this? Maybe if we take a look at the next slide, which is our theory of change. The notion here is that we're starting with this unified messaging, sharing it broadly. I hope you've gone online to see some of the materials that we shared. We have a campaign launch toolkit. We've got a white paper that describes the concept behind the triple-double and how we intend to do this work. But we want to provide those enabling tools, amplify your collective voices. We think as we generate proof points, to Q's point about data, that will be very important to track that across states and see what's working, what parts of our unified messaging aren't resonating. And then finally creating this reinforcing cycle where we continue to learn from one another. We share the new messages, the new learnings, and the cycle replicates. Anything else you guys would want to add to the theory of change before we share our call to action?
I don't think I have anything. I think the unique thing about this campaign or movement, if you will, as compared to a lot of other things I've worked on in my professional career, is a point I made earlier where I think there is just a way for everybody, no matter where they stand, what space they occupy, can find a way to be involved, and they can find something to support in this campaign. You'll never hear from any of us say you have to support it all. I think you can find a way to contribute, and it can be parochial, it can be generous, it can be as unselfish a directive as you want it to be, but I think there's a way for lots of people to participate in this effort. And I think it all comes down to people want what the outcome we're striving to achieve is, which is, better primary care in their communities for themselves and their families that's accessible and affordable and comprehensive. Employers want it, patients want it, physicians want to practice in a way that brings them professional satisfaction because they're helping people live healthier lives. And so find whatever corner of, this campaign that resonates with you and get on board.
A couple of things I'd highlight. This is about shared messaging to achieve a shared movement, and don't let perfect be the enemy of the good. So we often get caught in messaging and, I wish the messaging was different, or I wish it wasn't a basketball or something else. And I respect all of that and allow,
I only said that one time.
I don't remember. You can actually, there's a triple-double in volleyball as well, if you want to use the volleyball analogy. But I think, this opportunity around shared messaging, once again, the measures are the measures. So that's, I think, a powerful component of the triple-double. I do think it's a beautiful story. I've said this is stories. How do you create change in a grassroots, grasstops level? It's stories, along with the statistics. And so that's the alliteration you were referencing. My mother was a poet, actually, so hi, Mom. But no. So she's an...
He's killing it.
No, I'm not, no. But seriously, the stories are, HIV/AIDS, Ryan White was the story. We have to think about these stories. And the health center story, Dr. Jack Geiger. When I see health center advocates on the Hill or in state capitals or Capitol Hill, and those patients and those providers or those clinicians, those physicians, and those board members come in to those members of Congress and congregate and share their stories, that is what catalyzes change, that grassroots, grasstops change. And so we need to do that in primary care as well. And I don't want perfect to be the enemy of the good. Like, if you want to change the messaging, stick with the same numbers, I hope. There's really room for you to make it your own. And my hope is we'll track this at a state level, at a national level. We'll give you feedback. We'll celebrate the wins. Like, I do think it's better to be carrot than stick. Like, celebrate the states that are doing it extremely well, celebrate the members of Congress and the state legislators who are passing bills or pushing bills, and we create kind of interest from the other groups to say, I want to do that too. So focus on that opportunity about shared messaging to a shared movement, and don't let perfect be the enemy of the good.
And to the point that you made, Hugh, about wanting folks to feel like they sort of own this and they can change this up, we will be white labeling all of the resources so that you can take the triple-double and all the materials that we create and put your own logo on it. We really do want to stay connected, because it is in growing the movement that we will be most successful. I have just 2 more slides. One is, again, an opportunity to thank those folks who had faith right from the beginning, and have been truly our key partners. We want to populate this with so many logos. I want to give you guys an opportunity to add anything here. Without all of these other folks, without using all of the things you've already developed, our goal here is never to reinvent the wheel, but it is to build on the terrific work that has already happened and to just be some of the connective tissue. Shout out to Ann Greiner, she gave me that one. Connective tissue, that's what we want to be.
Yeah, I want to, many of these people have been on a journey. We've been fellow travelers is a word we use inside our building. We have been on a journey for a number of years, and I'm deeply appreciative of the partnership just my organization and primary care generally has been able to have with them. There's plenty of room. And, I really, there's the time, talent, treasure, call to action that we'll probably get to, but I invite people to come along. I think it's an imperative for the well-being of our country. I think this work matters, and I think it is simple and achievable, and I'm with you. I hope there's a lot of, the OGs will always be there, but I hope there's a lot more, moving forward.
Hugh, anything to add?
Look, I often say, you want to be like Hamilton, in the room where it happens. So I'm grateful that there has been an effort to think about, people, these folks being in the room, and we have space for others. We also, want to build a table that's very broad and diverse. I think it's essential as you think about our healthcare system, like we saw today, philanthropy, the private sector, patient advocacy groups, the public sector, the federal government, state governments. There's going to be so many, it's behooving upon us to make sure we're welcoming, we're open. And this is how we view, advocacy at the health center movement. We don't look, in terms of just yays and nays. We look at nays, maybe future yays. And it takes time and relationships and understanding and that grassroots, grass tops advocacy. So I'm a big believer that as we look at the broader health system, the evidence is clear and consistent that primary care saves lives and saves money. So we should keep pushing that and challenge the rest of the health system to be in the room and be at the same table.
And our final slide, which is the call to action that you mentioned earlier. Here, we're not saying you align with our message. What we're saying is align where you can. Figure out what you're doing that connects back to the triple-double, because the tent is, in fact, big, and the doors that are open are wide. We invite you to amplify the messages that we're sharing here today. If you go to primarycareforamerica.org/goals, you will also find lots of information and 3 sets of materials that we hope you find useful. I mentioned them earlier. There's a fact sheet that gives you a quick overview of what the triple-double is. There is a campaign launch toolkit for those of you who are ready to start having this conversation in your community. We have lots of information in that toolkit. And for those of you who are still toying with, what exactly is this, and can I see this in writing? There's a fairly short white paper that describes why we're doing this work and how that work will be operationalized. I invite the last 2 comments for the day. Q, Sean, what have I missed here, and what do you see as the call to action for this audience?
Did you make it first? Are you going to rhyme yours? Or?
I'm trying to come up with a rhyme.
Okay. So first of all, Marcy, I want to thank you. I mean, Q has said it. I really want to thank you for being a partner on this journey. There's a lot of people in this room, from our organizations that have done a tremendous amount of work, and I want to recognize, that work. These things don't happen, with 2 CEOs putting their heads together. I promise it probably would have happened faster if that wouldn't have happened. But, look, I have been fortunate or unfortunate, however you want to look at it. I've been involved in every major healthcare debate in this country since 1997. They all have a rhythm, and they have a timing that is, incredibly consistent. And we are entering one of those time periods. I told Deb, she took all my talking points. Affordability is impacting, the private sector, the public sector, and individual families. People feel disconnected from health. People feel isolated and alone. People feel like other people don't care about them. We heard, just an incredible amount of data today about the state of our healthcare system and the solutions to be solved, and I won't get into that. But the thing we also hear is people want primary care, from the individual to the family to the businesses to the government, and it is a unique opportunity. And that runway is not paved forever. And I think my call to action is We have done a lot of work over the last 15, 20 years to build a case study for primary care. We've done research, we've written papers, we've convened NASM, committees, and now it's time to leverage all of that knowledge to fundamentally change the course or the direction of the healthcare system to be more oriented around primary care. And that opportunity exists. And you have to believe that opportunity exists because we believe it exists. And I'm not telling you that runway is straight. There may be some curves, there may be some starts and stops, but I just encourage everybody to get on this journey with us because I think it's a unique 3 to 4 year time period we have to do something really, really big.
Look, I'll echo the window of opportunity for primary care is now. There's an urgency in the communities that need it, across all these categories of the triple-double. There are, med students who are deciding, what residency they'll do. There are people in rural America who lack access to primary care. There are, opportunities that we have to really think about, the 100 million plus that need access. So there is a window, and I would suggest there's just because there's a pulse here in DC that is interested in more prevention over treatment as well. So, but I'll just reference 2 quotes that I love referencing, which I referenced one earlier. Helen Keller, alone we can do so little, together we can do so much. And we do need all of you at the table, in the room, to advance this work. And then the other quote, I love Nelson Mandela's quote where he talks about vision and action. And vision without action is just daydreaming. And action without vision is just busy work. And vision and action can change the world. And ultimately, when you think about this, the triple-double is a vision of what we want, but ultimately we have to work together to achieve the action. And that's what I'd end on.
That's well said.
Thank you both so very much for your leadership. Thank you to all of you who have spent your day with us and online. We probably should end on this profound quote that Q gave us, but I personally feel like I need to thank my 2 other angels. If these guys together are Charlie, my 2 other angels would be Grace Tronosky-Rice at NAC, who serves as Q's Chief of Staff and VP for Strategy. And the other angel is Bethany Burke, who serves as Sean's Chief of Staff and also VP for Strategy. And all I can say is I get to be Sabrina. Thank you to all of you. We can't wait to have you be a part of this effort.
Hey, for those in the